action plan recently we discussed, but it is not easy for the government to straight away allocate resources. So we are involved in a pilot program as of now, NIMAN's Dementia India Alliance, which is an NGO, and the government of Karnataka. We are discussing to see as to how this can be implemented. So when it comes to mental health intervention, we always talk about health care in the hospital, tertiary care hospital, but actually the maximum amount of care is required in the community, which is self-care and informal care. That is where most of the common mental health conditions can be handled, which is using the task sharing approach. But this segment is what is very, very minimally available as of now. And one of the solutions for this aging problem, the United Nations has come up with a decade of healthy aging from 2021 to 2030. What is this decade of healthy aging? Healthy aging is primarily focusing on functional ability. They may have a lot of problems, but the focus is on providing appropriate support and promote the functional ability, how the person can do what they are meaningfully able to they prefer to do. So it's about the intrinsic capacity, which is the physical and mental capacity, will decline to some extent because of various mental health conditions or physical health conditions. But by providing environmental support, you can still provide improvement in functional ability. Now, this is something, an important thing, public health framework. We need to provide appropriate intervention for people who are already healthy, for them to do promotion and prevention. People who have problems, the middle one-third, to provide acute care and then prevent disabilities. And people who are already having disability, to provide rehabilitation and environmental support. Through that, we can actually improve the functional ability for everyone. And healthy aging is not restricted only to the people who are in the first one-third of people who are healthy. It is applicable for anybody, even with a person with disability. If you have an age-friendly or disabled-friendly environment, you have supportive aids, their well-being and their functional ability can be improved to some extent. So that is the concept of healthy aging. Now, the 4 action areas which is kind of applicable even for mental health care is combating ageism. We already talked about how the person, they don't get help because they are not actually seeking help because of the biases, because of their internal ageism, as well as other stakeholders. And age-friendly environment, which is very, very important. Again, it ranges from the social, physical infrastructure to access, attitude. Even attitude is very important for us to ensure that care is promoted. And integrated care for elder people. And one of the main challenges is promoting access to long-term care for people who need long-term care. So these are the 4 action areas which is required for all stakeholders to work on. And
this one will be straight. I can put this.
Which is relevant for mental health care. We already heard about district mental health program, which is kind of now operational in all the districts. Most of the districts, more than 700 districts across India. And another major recent initiative from the government of India is a national tele-mental health program, which is called Telemanas. I think everybody should know. Are you aware of Telemanas? Telemanas, have you heard of? What is the number?
But it will be 2 cross. No?
What to do?
14416. Okay. So everybody has to be aware of Telemanas, which is the single largest public health program for mental health which has been launched recently. And this will help in reaching the access, in promoting the access using technology. And the National Program for Healthcare of Elderly, again, is another important initiative which has contributed to various centers for aging. There are centers for aging, regional centers of aging in Bengaluru. There are national centers for aging in Delhi and Chennai. There are several regional centers across the country. More than 20 centers are there, wherein there is capacity building for pediatric medicine, and there is opportunity for psychiatry departments to collaborate and promote mental health care for elderly. And there are some other programs which is health and wellness centers, which is now called as Auditorium. Again, mental health in elderly is one of the target packages within that. If properly implemented, this can definitely help in promoting the Auditorium in promoting the healthy aging. As well as there are programs from the Social Justice and Empowerment Ministry, which takes care of support to daycare centers, residential care centers. Primarily old age homes are supported through these schemes where they fund NGOs, and then because through that they can provide social care for people. There is a provision for supporting mental health care also, but the extent with which it has been utilized, it's quite limited because the challenges in funding, the challenges in kind of able to provide good quality care with the financial resources what is available through this project, there is a limitation. But for general old age homes, almost around 600 old age homes are supported by this scheme. There is a national action plan for seniors, welfare of senior citizens by the Social Justice and Empowerment Ministry. Now there are several other initiatives like Karnataka Brain Health Initiative is another initiative which is led by NIMANS, the neurology team, which again is a model which has been kind of talked about and which is already being discussed to scale it up to the national level, wherein dementia will also be one of the important focus in that. And there are other NGOs like Nightingale's Medical Trust and Dementia India Alliance in Bengaluru, which have been running active aging centers for people in low socioeconomic status, which is called Hiriyaravadi centers, which basically allows people to come in the morning and then do some activities. They don't spend their time idle. They are able to get physical activity, social engagement, cognitive engagement, which again is a mechanism to prevent dementia and promote healthy aging. And these are some things, models which has to be scaled up across the country. There is a recent trial which is a trial on preventing late life depression, which has been done in Goa, which again was something which used task sharing approach. Using lay health workers, they were able to intervene people who have subsyndromal depressive symptoms and prevent depression. So these are, again, there is another important trial called Finger Trial, which is a multi-domain intervention, which focuses on physical activity, social activity, cognitive activity, and this is something which is being tried in India also in some of the centers. Their pilot projects are worldwide finger network through that. But what is the limitation in ongoing programs? There is a difficulty in access for those with disability and limited support. There is also the integration with general health care is still inadequate, both at the PSC level or at the district hospital or even in the tertiary care centers. The health services are scattered. So people have to elderly, they have 3 or 4 conditions. They have to visit 3 or 4 doctors to actually get pills or get interventions. So that becomes a limitation. So there has to be a system which is integrated. And the concerns and effectiveness of implementation of the program. We have many programs which is very good in paper, but how much it translates into real life, if you go and see in the field, there is a challenge with respect to that. And the lack of access to community-based rehabilitation and long-term care services. Even though Mental Health Act, you will be listening to talk about Mental Health Act mandates about this availability of the services, but still there is a challenge for people to have this. Now, coming to this, okay, we have talked about problems. I will just give a glimpse what we are doing as a service, NIMANS, because I think all of us have some responsibility to do whatever we can do at our levels. So NIMANS has a dedicated geriatric psychiatry unit, and our geriatric services is already heading into 25th year this year. It started in 1999. We have general OPD service, IPD service, neuromodulation, which is ECT, TDCS, TMS, as well as tele-geriatric psychiatry. To some extent we are able to do psychological, psychosocial services to some extent. Again, even in a tertiary care unit, it is not easy for us to provide, to have enough human resources to provide comprehensive care. We collaborated with Legal Services Authority and initiated Legal Services Clinic, which already was available for general population of persons with mental illness. For senior citizens, we had a separate service which was integrated into that. And several outreach initiatives in collaboration with NGOs we have been doing. And the scale of our services, I think it has kind of become too busy now for us to manage our workload, both inpatient, outpatient numbers, and outreach support. We provide destitute old age home, we provide regular support. All these things are whatever we do, we have to do in addition to these activities. Now we have a training, again workforce capacity building is an important component. We have training from super specialty like PDF and DM, along with fellowship in for social worker and psychologist and nursing. So more importantly, we also train physicians, primary care physicians. I think NIMANS Digital Academy is another important initiative where we have been able to train lot of stakeholders, including primary care physicians, say volunteers, and several other stakeholders. And another important initiative what we have been doing is Vayomanasa Sanjeevani, which even collaborates with Indian Psychiatric Society Karnataka chapter, and we promote awareness. For the last 3 years it has been going on, where more than 180 sessions have been conducted regularly in English as well as in Kannada and in Tamil. So we have been able to do some systematic programs to promote awareness. I think some of the colleagues who have been supporting, Dr. Saraswati is here. So several people support us from IPSKC also for this initiative, and which again promotes public awareness is something very, very important. And online support, again we have started with a support group, online support group in collaboration with Dementia India Alliance and with NGOs. So Age Friendly Karnataka is another initiative through the Legal Service Authority and the government of Karnataka we tried out. And Vayomanasa Sanjeevani has several things with not only awareness, we also train volunteers and do outreach activities through this. Now, apart from the capacity building, some of the philanthropic efforts from the caregivers have supported this training of physicians. One of the caregivers donated money for us to do this training, online training of physicians. And with several CSR funds we got to do this kind of outreach activities. One called Alzheimer's Seva, and again through HelpAge we are having an initiative called Sarthak. And say apart from the last one, the major program what we are doing currently is a Taluk mental health program, which is led by the community mental health team, of which elderly is also a component. This uses a life course approach from womb to tomb. It talks about issues from perinatal to geriatric. So there is the Belur Taluk in Hassan district is adopted for this. Along with that, Munsiari Taluk in Uttarakhand. So we are doing it in collaboration with Government of Karnataka and Government of Uttarakhand and AIMS Rishikesh. So this is a model program like the Sakalvara project what Dilip had talked about for district mental health program. We presume that this, our hope is that this Taluk mental health program will also be talked about in future, where the scaling up of mental health care services from a district level to a Taluk level can be done through this project. This is by utilizing the government resources and using a ASHA worker model, having 2 health workers for every PSC who will be dedicated for mental health. So this is the program which has started, 1 year has happened and some activities have been conducted. And to end with, so when we talk of wisdom, aging with wisdom, so we think elderly when they become aged, they are getting wiser. It is not universal, everybody don't become wiser. Wisdom has several components. You need to have social decision making, emotion regulation, pro-social behavior, self-reflection. There are several components. It's a newly researched topic. But what we need to do is, what we need to understand is, it is not a linear relationship with aging. Mental health as an important factor in this. If there is somebody who is having a mental health problem, cognitive impairment, despite getting aged, they may not become wise. So we need to, we as mental health professionals and healthcare professionals, everybody's responsibility is to kind of promote mental health. It cannot be isolated, and through that, I think we can hope for aging with wisdom for us as well as for the community in general. Thank you very much.
Thank you, Dr. Shivkumar. Graceful aging is the word today. Government of India is pumping in lot of money. Apart from this, even if you walk into Ayur clinic, especially the CARI, the Center for Ayurvedic Research Institute, they have program for people with ADHD to aging program. India is aging. Okay, our number of, as the age, our life expectancy has gone up, even the people with aging is going up. In spite of that, if you look into the statistics of dementia, we are not on par with the Western society. If you look into American statistics, by 61 in 5 they tell they are all afraid of this dementia. For example, when people with between the age of 45 to 55, when we were interviewed, what are you worried as you grow old? Most of them said, we are worried about dementia. Whereas if we same people are interviewed in India, probably they tell, I don't want to be a diabetic, I don't want to be a hypertensive patient, I don't want to be a cardiac patient. Still, we need to have more awareness about cognitive decline as we grow older. Probably many other systems in the society, being extended nuclear family, little more socialization, other rituals, etc., might have contributed in reducing that decline in mental health. Only thing, probably as Dr. Shivkumar is mentioning, so many programs are there. One thing we should remember, most of the elderly will visit a physician or a family physician or a general practitioner, because invariably they will be having many other comorbid conditions. And people with comorbid conditions will have more mental decline than a healthy individual. Apart from promoting our healthy lifestyle, we also need to see that how they can screen simple questions. Many a times in the last family physicians, this thing I said, if the patient says, Yako ಸ್ವಲ್ಪ ಮರು ಬರ್ತಾ ಇದೆ, just tell them to draw a clock, give them a time, 11 o'clock 20 minutes or 4 o'clock 8 o'clock 50 minutes, something like that. You just simple and then refer to the doctor, they will do it. Probably creating more awareness to catch them early will be the most important thing. ICMR, we should be thankful for coming out with two things. One, recent guidelines, why one should not use whey protein, how one should cut down salt for a healthy living as we grow older. This has contributed a lot of youngsters who are coming with gym and polysubstance abuse. They are telling, now I understand, doctor, I should not take so much of. Similarly, probably Government of India, ICMR also has to come out with guidelines for healthy aging. I think Dr. Shivkumar has elaborated about lot of programs which are going through. Only thing is we need to reach the needy to see that how India can have a healthy aged population rather than the sick population, which will be a huge burden on our already collapsing healthcare system in the government. Thank you very much.
Any questions from the audience?
Hello. It's a very nice presentation.
One more.
As usual.
There are three.
I just want
One,
to ask
two.
three questions. One of them is that this Monday I was in a meeting in the interior part of Kerala. They were taking care of elderly persons by the NGO as well as palliative care plus ordering mentally. Three groups. And out of which, one of them they told us that they would like to have a scheme where the elderly people who are not being taken care by the families, they can give their share and they will look after them free of cost completely. But rest of the other patients are all completely free, running on donations and various things. And this is something, a new thing which has come, and the judge also was there. So they say that we have passed an order like this, share can be given to the person who is not being looked after, because when the rule says that every children have to take care of the person legally, a lot of children are not in a position to take care of them, especially when they go for work. That's one thing is little more clarification. The other one is that the role of AA in basically bringing in algorithms and issues like that, and can AA have a role in the care of the elderly in the long run? Telemedicine is only the technology being used for that, but is the AA going to have any better thing? In that case, we are in a little advanced position in with regard to the AA things from the Indian computer side. So, do you have any input in this?
Thank you very much for the question, sir. I think when it comes to social care, the cost is something a big issue, and people who have some resources, whether they can utilize these resources to get the care. Now we have many organizations which provides care where people can actually give up their properties and then they can actually pay a kind of one-time down payment, which is a huge bulk of huge money they pay, and then they lifelong they move into a kind of assisted living facility. So many NGOs does that. The biggest challenge with this system is it is not organized, and there is a concern about abuse. I recently interacted with one of a very senior professor from IIT who is 89, bordering 90, who is alone, who is not married, who doesn't have child. He wanted to give a property to one of the very well-reputed trusts, and then he wanted to donate it for a specific purpose. And then he was trying to make it as a will kind of a thing where after his life they can utilize this and then do it. But when he actually read the document, it felt as though he's donating immediately, and he's kind of taken the entire his assets is taken by that organization now, and then he will be at their mercy. So even for an educated person, then he became very apprehensive, and then he didn't go ahead with this proposal. So there's a lot of concern, and we have had people like that who have crores of rupees. They are unmarried, and then they don't have family, they don't have any other family because they don't trust anybody. It's a quite challenging thing to provide support. Now, what happens in Western system? The means tested rehabilitation. For example, in UK, you have to sell off your properties. I think even in some of the Scandinavian countries, it is there like that. Like if you have some assets, they will liquidate those assets, and then the social care system will take care of it. If you don't have some of the countries have long-term care insurance, but in places where the government assures these things for everybody, or people who have something called as means testing, that you need to go below the particular level of social affordability. And if they have properties, government will have to sell it off, and then they go beyond that, then they are eligible for receiving the care. But there is an organized system for that. In our country, it is at the mercy, and it is kind of not an organized system. NGOs can do anything, the oversight is the problem. To come up with the program, I think the policy of our government is that care has to be provided by the family. What happens to those who don't have family? What happens to those where the family is there but they are not willing to take care? Their legal mechanisms are there, but it is not easy to get justice, and it is quite disorganized. There is no coherent system for us to navigate and get a kind of remedy. So the second point, sir, the second point about AI you had asked, there are several interests in studying AI for elderly. One of the things is about how you can detect problems in elderly people going for optal evaluation. Routinely they do a lot of scans and tests. Whether through that, whether they can actually detect cognitive decline early. Because retinal markers of aging is something which routinely get acquired when they go for optal evaluation. So there is a discussion. There are several institutes are doing, and globally as well as in India, there is interest to collaborate and do. Voice recognition, through the voice, the changes, how it is happening, through various parameters, whether you can pick up dementia in early. Even for care, AI used chatbots kind of a thing, which can provide guidance to the family caregiver, which can provide guidance to the paid caregiver. These are some things, initiatives worked up by some startups. They have had discussions with us. We don't know how far it will become practical and become realistic. Every day, time and again, we get requests for collaboration with various technology from the academia as well as from the startups.
One of the first arrest of the children who are not taking care of the elderly has taken place in Kerala, immediately after the implementation of this act.
These things have become diluted now, and there are a lot of kind of challenges for people to get, because a lot of any system which has some protection, it is also meant for abuse, because people use these legal measures to abuse, to kind of take other personal kind of motives and then use it. So a lot of safeguards have come. Now it is not easy, because we used to talk about the Maintenance and Welfare and Parents and Senior Citizen Act, which gives the power to take away the property what is donated by the elderly, gifted by to the children. But now it is quite difficult. You have to document in the will you are donating to the children with the condition that they have to take care of them. If you have not done that, you are not entitled to get benefit under that. So it is quite kind of challenging for people to do that.
Sir, there is a question.
Dr. Anand, sir, Associate Professor in Community Medicine. I appreciate, sir, it was very good information you shared with us. I just want to have two questions. One is about your experience on the gap which is between you as a psychiatrist and the community is there any gap which you have appreciated, which will, if you enlighten us, which we can incorporate as a community medicine specialist to reach that particular gap? That's one, sir. Next is the places you have selected. Imans reaching out to Munsiari and Rishikesh, Bengaluru. I've been there to Rishikesh and Munsiari. I don't know what was the reason why you selected that place. Reason because the happiness index over there is quite good. Next is the needs and wants are not different compared to the people in the lowland areas. So can, or just like that our psychiatrist wanted some rehabilitation.
Nice questions.
Thanks.
Thank you very much. Thank you very much for the questions. So I think the first thing I will clarify that it is not meant for a holiday of psychiatrists from here to Uttarakhand. So the rationale with which we have selected is we have selected Munsiari, which is very less population but very challenging terrain to implement any public health program. So because access itself is I think from Rishikesh it takes 6 hours journey for us to reach, and sometimes in winters we cannot reach. So how do we implement a mental health program or a community based program in collaboration with the government in a setting where it is not easily accessible? So that is something like a very difficult task. So for us sitting in Bangalore, we have collaboration with Rishikesh, but the key investigators are from Bangalore. So it's a quite challenging. That's the one reason why we have selected that. We also wanted north and south and something which is not easily accessible and very challenging terrain. Belur we have selected again based on some of the indicators where it was not extremely poor kind of a thing or extremely resource rich setting. If you take the Belur taluk, it's a medium sized taluk. It doesn't, the health indicators, we have looked at the health indicators also. Dr. Naveen is a community psychiatry head, he is the main PA along with Dr. Jagdisha. In fact, the government took a lot of time for us to kind of accept why you have selected this place. Karnataka government said that you look into all the data and then come up what is the rationale for selecting this place. So we have applied our mind, and it is not a very robust mechanism, but these are the parameters, and it is not something very close to Nimans. It's at the same time it take I think 2-3 hours for us to reach there. Minimum 3 hours it takes to reach there. So how we can implement it? There is no psychiatrist in the government setting there in Belur, in Taluk hospital. The entire Taluk doesn't have a public facility which provides psychiatric care. So these are the rationale. The second, the gap. I think this itself depicts there's a gap in the sense that where there are places where there's no public health facility providing psychiatric services, and they have to travel to the district headquarters, or sometimes even there is not enough satisfaction, they come to places like Bangalore. So I will give one example where somebody recently, I had a person from Tamil Nadu. The first initial this thing, somebody told you go to Nimans, it will get better. So the person, the only spouse is come with the elderly person with dementia who has already missed 2-3 times when they the person got lost while in their traveling nearby places. She on her own she brought for the first consultation for dementia to Nimans, selling off a goat and selling off some properties and assets, getting some 10,000-15,000 rupees and then coming here. So, and here within a month they had to come 2-3 times. So because we were not sensitive enough to kind of understand and then integrate with the local health system there who can provide that care. So that's the challenge. So there is a other system where there is a social worker who brought a grandmother with dementia in Chamarajanagar, where the person is being taken for a religious treatment in one of the famous places and getting physically assaulted. Physically, there is a I think these are realities when you see now. I think what we heard from Sakalvara and the earlier programs, and even today this is happening, where there is a ritual that 9 times this person has to be beaten. So there is a 9 times. If you do that ritual 9 times, the person will get better. And even for one simple faith healing, this thing they give, 20,000 is the charge. So these are places where we need to integrate with the community team. And sitting here, we can't do it. And we had a person who is wandering, who has bipolar disorder, elderly, who has been getting better and then working as auto driver. And then when he's and 3 or 4 people in the family have mental illness. That whole family is ostracized. This is in Mandya, somewhere near Mandya village, and the family thinks this is a ghost house. So there's a lot of stigma. We tried reach out to the police person through a referral. We gave a letter, but we were not able to get the person. So because they say you come and take the person, police will help you, but we will not go on our own. So these are the areas where community health system. We reached out to the DMHP, but still we have not got the person. So these are the gaps. Even when we diagnose, we know that the person has a problem. To bring to health system, still it is a challenge.
Dr. Shivakumar, luckily we are on time. Just one question. Carers have a huge burden on maintaining the patients with cognitive impairment. Okay, the daycare has helped a lot of patients to get a break. Can NIMANS also be a model to show how we can have a daycare center where a patient walks in by 10 and goes out by 4, so the carer can take care of other chores and also give quality care to the patient, number one. Creating awareness or support system to the carers. After that, we will close it.
Sir, daycare is very, very essentially required for people with both healthy. I was talking about a Hiriyarvadi center for normal people, and which is run by some NGOs in the slums. It is a good model. NIMANS have been giving proposal for daycare for the 12th 5-year plan, 13th 5-year plan, 14th 5-year plan. Now with the Niti Aayog plans, we have given proposals. I should say that recently we had a success in the sense that the department, the psychiatric rehabilitation services has in principle agreed to give up space and collaborate with us to start a daycare facility. But the space is still not enough, and we have explored collaboration with Dementia India Alliance to get some funding also to start a daycare. But the space itself is a constraint. The biggest concern about daycare is the viability because of economic reasons, transport. And we feel that whenever there is an integration with the residential care, daycare is also there with the residential care, there is a success. Second, there are models where Bangalore, at least say one of the NGOs is doing by having auto, 3 people the auto is bringing, and then it is working out reasonably cost effective. So these are some of the challenges, practical challenges for running daycare. So recently I had visited one of the high upscale residential care old age homes which is providing dementia care. So we are motivating many people to start daycares, and NIMANS is also trying to do it. We need some support and resources. Second, about caregiver training, we have tried online training, and recently when we interacted with the Social Justice Secretary also, we are discussing about a proposal where everybody who is getting trained in general geriatric care will get a module of mental health care or geriatric mental health care and dementia care through an online or a hybrid program. So for home care, we have done some training through a CSR support. I think this is very much required. The Government of India has a target of 1 lakh caregivers to be trained within the next couple of years.
Thank you. I think we'll come to the end of this session. It was extremely informative for us to know what's happening in this aging thing with government proposals. Thank you very much, Dr. Shivakumar. I'll hand over.
I think he's thinking that his session
Thank
is
you,
with us.
sir. We would also like to welcome the chairperson, Dr. Jagdish A., consultant psychiatrist and director, Abaya Hospital. Sir.
Now, I request the chairpersons to present a token of appreciation to Dr. Shivakumar P. Thangarajan.
Now, I request Dr. Dakshayani M., Professor and Head of the Department of Ophthalmology, the Oxford Medical College and Hospital Research Centre, to present a memento to Dr. Prakash G.M. Sir and Dr. Jagdish A. Sir.
చూడరా అక్కడ పవర్ ఆగినా లేకపోతే ఏం నొక్క మాకు చూసురా ప్లగిన్ చెక్ చేయ ఫస్ట్ లైవ్ అవుతుంది
Thank you, sir, and thank you, ma'am. Without much ado, let us move on to our next topic. National Mental Health Program, District Mental Health Program Breaking the Boundaries, Transforming Mental Health Care Across Urban and Rural Landscapes by Dr. Abhay Matkar, Professor and Head, Department of Psychiatry, SDM Medical College, Dharwad.
To chair the session, I would like to invite Dr. Murli T, President, Indian Psychiatric Society, Karnataka Chapter, and Professor, Department of Psychiatry, the Oxford Medical College and Hospital Research Center, and Dr. H. Chandrasekhar, Professor and Head, Department of Psychiatry, ESIC, Medical College, Rajaji Nagar.
I request Dr. H. Chandrasekhar to introduce the speaker.
ಹಲೋ ಇದು ಮಿಡಲ್ ಪ್ರೊಜೆಕ್ಟರ್ ಆಫ್ ಆಗಿದೆ ಅಂತ
At the outset, I congratulate the Department of Psychiatry and Department of Community Medicine for organizing such a wonderful CME. In fact, I am happy that you have taken this community mental health as the theme. In fact, it's the first of its kind I am attending. So I congratulate first thing. And of course, wonderful hall, hospitality looks so nice. Thank you, sir. So the topic, in fact, Dr. Abhay Matkar is going to present a very important, I can say, theme topic. So it's my privilege to introduce Dr. Abhay Matkar. And briefly about the topic, I say mental health in India has three periods. Like, post-World War dehospitalization movement. We had from 1945 to 1947 to 75. It was like integration of mental health into general services, encouraging mental hospitals. But real mental health started with introduction of the National Mental Health Program in 1982. And of course, over time, it has grown, on which Dr. Abhay will be talking about. Of course, there is a lot to talk about Dr. Abhay Matkar. In fact, Dr. Abhay Matkar is actually MD Psychiatry from AFMC Pune. In fact, when you say AFMC, of course it comes under that university. He was in Indian Army. He was a major in Indian Army. Served our country in various important capacities. I think he even served in Kashmir at the height of the when there was a challenge, a real challenge, and he is currently Professor and HOD Department of Psychiatry, SDM Medical College, Dharwad, and currently President of the Indian Psychiatric Society, South Zone. Of course, there are a lot of things to talk about him. He is the most active member of the Indian Psychiatric Society, national body. He was in the election committee. He was active in most of the last 1 decade. He has taken a major role in implementing our mental health programs. And he was the first president of Indian Psychiatric Society, Karnataka. In fact, he was a predecessor to me. And most importantly, he is my batchmate in MBBS. So indeed, welcome you. And he will be talking about NMHP, DMHP, breaking boundaries, transforming mental health care across urban and rural landscapes. Thank you, sir.
నాకు 10 seconds late.
Finish by 11.
Good morning to all of you. That's it. Thanks to the organizers, Chandru, Murli, and all of you. At the outset, I would like to thank each one in the Department of Psychiatry in this college. The reason being, each one has contacted me for extending the hospitality. You want this, you are coming back there, you need a upper berth, you need a side berth and all that. There is more to it. I don't extend like what Chandru talked about. I must express my sincere thanks to Dr. Chandru, Dr. Saraswati here, and Dr. Rajani, who have been instrumental in doing an exceptional job in terms of DMHP in our state. Our state has won lot of accolades for all that it has been doing since the inception of DMHP, and it continues to be a leader in all the aspects. In Dr. Rajani, I just made a mention about it. She is the one I spoke in front of her, not behind her, that she is one instrumental in bringing about lot of changes which are not just defined in DMHP, but went beyond, and she has won national and international acclamations for all that she continues to do for DMHP. I thank her for helping me through all this presentation. Thank you, ma'am. This could be one of the presentations where you will see that the chairperson will have to do more than the speaker also. Part 1, Chandru did it. He had to because he is my classmate. And now next, Dr. Rajani will continue. I must appreciate, like what Dr. Jagdish and others have told, that this marriage between the two departments is going to work very well. Psychiatry, unlike other branches of medicine, we all know, is not an individual-based disorder. Sure. It's a social disorder. So it doesn't affect a single person. The index person is affected, yes, but we all see that it's the family, it's the society, it's the community which gets affected. That means when we address two issues about the causes, about the management, we need to look into all these spheres to find an answer. What better way than interacting between community psychiatry and psychiatry today in this CME. Thanks for calling me for this. I'll just go through briefly in my presentation. So what has been the burden? Most of you are aware that at least 10% of the Indian population does go through mental illness, out of which 1% accounts for major mental illness. We do not take into account a lot due to statistical problems. We don't get adequate data, but I'm sure there will be a lot more than this. The most problematic areas are those subclinical issues, those cases which are not reported, and definitely a large number of patients with substance use. Is this clear? Is this clear? Clear, hello? Okay. Right. The topic in hand is basically something to do with the journey of National Mental Health Program to DMHP. Quite a few might have been born when NMHP came through, that was in 1982. Why was this need felt? Definitely then and even now we feel that there is a continued need of addressing mental illness. Mental illness continues to be stigmatized and it needs to be addressed urgently. And that is why it was felt it would be impossible to create a separate subsection to deal with mental illness.
So it was felt that some team needs to integrate with an ongoing process, that is National Health Mission had this as National Mental Health Program in 1982, and since then they have been working towards the implementation of DMHP program, which has seen the light of day since 1996. We are proud to say that over a period of time, all districts in our state have implemented DMHP program. We should be proud that NIMHANS has been able to contribute to what is called as a Bellary model. That means it was in the district of Bellary where a lot of studies, the initial part of studies took place, and it was conceptualized how to go about in the establishment of district mental health program. Now the main objective at that time was just to improve mental health at grassroots level. Now we will see over a period of time how this has changed. But if you look at it, the initial one was just to be treatment oriented. And that treatment oriented was to be community based. Now why this was important was because the need at that time was more towards treatment. Nothing to do with prevention, hardly anything to do with research. So what does the Bellary model say? It works around the psychiatrist, yes, definitely. That is at the district hospital, but at the community health centers and the primary health centers, it is the trained people. It could be medical officers, it could be psychologists, it could be social workers who will continue to look into those early signs of mental illness, and then they can be guided. Most of this may not need psychiatrist's help. Now this is something which is very important for all of us to know. In my own practice on this day too, I can say that at least 30 to 40% of my patients do not need medications. If we are able to address this issue at a grassroots level, how best it could be to see health for all in the near future. So there are other aspects also in terms of beds in the district hospital. It was initially 10. I think now it is going to be increased over a period of time. As I said, all the districts in this state have implemented. Around 800 districts in the country have implemented this, and I'm sure more would be added in the days to come. So what are the components of DMHP? They are mainly 4: clinical services, capacity building, IEC activities, and advocacy. Clinical services, it would start with the psychiatrist and it would encompass other departments too. Now it has progressed into not just in terms of gross or adult psychiatry only, but it has gone into other subspecialties like child, maternal health, de-addiction, which is one of the most important social problems which we have. Some drinks, please. Water, sorry. My classmate says water on the table. Sorry, Chandru. Now, in terms of capacity building, this is one particular aspect I think where DMHP is working a lot. Now, why this is important? We cannot give a psychiatrist to all the places, especially at taluk level, especially at the community health centers. So it is imperative that psychiatrists at the district level tend to train medical officers at all PHCs to recognize mental illness at the earliest phase. Now why this is important? We all know that in medical field, like physical medicine, early intervention helps, and this is said in all the branches and definitely works so in mental illness also. Then comes the issue of health related departments also taking a part, which I'll come to a little later. The IEC activities are very important, and I'll take a little extra time a little later. So this is something to do with the DMHP organogram, DHO, DMHPO. Then there are psychiatrists, as I told. There are psychiatrists in all the district programs in at least our state. There is a paucity of psychologists in some places, but otherwise the staffing is plus or minus okay. I'll wait for your comments later. Okay. As I told you, we all started with the treatment model in mental health program, that is National Mental Health Program, which went to District Mental Health Program. But what was important, that was not adequate to address. There were a lot of lacunae in the whole system per se, which could not address just the therapeutic part. So what was important is research. And research was through collaboration with NIMHANS. NIMHANS has been the backbone for most of the activities of mental health, both at national and local level. Digital technology. Previous speaker also spoke about it. In fact, at one end of this tunnel, this end, I find that digital technology has played a major role. We felt that mental illness can't be addressed on the screen, but now we have seen over a period of this COVID and afterwards that technology, the screen-based interview, screen-based therapy was quite helpful, and we continue to be leaders in that as far as mental health advocacy is concerned. Public-private partnership. All know that the government themselves can't do much. We have one scheme which we are doing in my own place. We have one PHC which is taken care by the unit which Murli works for, Vivekananda Trust. They provide manpower, they provide medications, and we have psychiatrists from my college who go there. Now this is very important. Relying only on the government setup for provision of manpower, infrastructure, medicines, and what you want cannot be fully foolproof and time bound. So it has to be a public-private partnership, and there are various schemes under which it can be done. Corporate social responsibility is one of them. Capacity building. We are trying to improve through various means how best the grassroots medical system is empowered to know, to understand, to possibly manage psychologically those mental aberrations which do not need medications. So what are the initiatives? Going forward, that means it's not just stuck to the treatment part. There are a lot of initiatives which have been taken place, and I'll just go through them now. Mano Chaitanya. Now this is something which I think has been the brainchild of Karnataka to begin with. It is something like a Super Tuesday where most of the taluk places or most of the PHCs are covered, and once a month at least. So the patients are aware, the consultants are aware that a psychiatrist is going to be there, so they will be there once a month at least to seek help. Now this has covered all the taluks, and as we know, these are the statistics till December that 5 lakh beneficiaries have taken help out of it. Matru Chaitanya. This is something perinatal mental health services. This was an aspect which was not addressed to, and frankly was neglected maybe 20 years back. The reason for that was obvious. At that time, the deprivation was more to do with nutrition. So it was a physical need at that time. Over a period of time, it was felt that psychological inputs are also required for the well-being of mother and the child to come through. So this was felt, and this has also been integrated into mother and child services. I just talked about technology. E-Manas is something which is doing a stupendous job in our state and also in our country. It has to follow the MHCA guidelines, but we often see that we have been able to treat a lot of patients, especially when they come for their subsequent visit. First visit, we might have a little apprehension to talk to the patients, wherein we try to insist them to come and seek help in person, whereas subsequently we can do the follow-up for these patients through telepsychiatry. So there have been a lot of mental health establishments which are registered. Telemanas, I think there's going to be a talk a little while later, but that is something which is a digital arm of DMHP, and this is a helpline which is available to all callers around the clock, and this is also doing an exceptionally good job. Karnataka Brain Health Initiative, this is another thing which is more for the neurological conditions, but then I think there is a lot of interaction between neurological disorders and psychological disorders. I think this initiative with NIMANS is going to help a lot. Dawa and Dua. We all felt, especially the allopathic branch of medicines, we felt that we were working and we will continue to work in a watertight compartment. It was something like, we know all. No. At a community level, we need to understand that the patient's understanding of illness is also important in treating the patients, rather than just saying that noradrenaline causes anxiety, dopamine causes schizophrenia. No. The understanding at the community level will help not only in understanding the disease, but also in helping them in treatment. So the integration with other branches is also very important. Assisted home care services. Dr. Jagdish talked about it a short while ago, but this is part of the program which is there as part of DMHP program. It is just in its initial phases, but I am sure a lot of work could be done in this area too. Capacity building. We again felt that only psychiatrists or psychologists could do the job and need to do the job. Community involvement is very important. And then almost all branches of medicine and people who are not working in the field of medicine are involved in capacity building. It's basically to identify minor illnesses and of course major illnesses and how best they can either manage it themselves or are in a position to refer them to the concerned authorities or the psychiatrist person. Now this is very important, and if you see the figures, they run in thousands. And these are non-medical people, including of course the medical professionals too. So this figure is very high and it is top down, that means psychiatrists take care of medical officers, psychologists, social workers and the rest. And the numbers over a period of time are increasing day by day. IEC activities, information, education and communication. Now in this area, we find a lot of public-private participation, the CSR activities, and you can see one lady too who has been contributing a lot as far as depression is concerned. Now this is very vital. I talked to you a short while ago how important it is for private participation too. Various activities are done, and amongst the most important social activities for us as of now today is against suicide, depression and the addiction. So these are the three areas where a lot of thrust is given, and more organizations are coming forward to address these particular issues. The other issues are the telemetry, e-monitoring of DMHP, urban self-harm study, Karnataka Kishore Swavalamban program, and Shema. So these are the other programs. I'll just rush through them. The other aspect is the primary level of prevention. Now this is something which can be done through various programs or something like counseling services, camps and home visits. Now this is also undertaken by DMHP personnel. The total consultations as far as clinical services is concerned is expanding day by day. We also see them at the taluk level also, like every Tuesday, Super Tuesday, which also is called. That is the time when we see the number of patients increasing. And now they are coming not just for major mental illnesses, but they come to see for stress-related problems too. I talked to you about Dr. Rajini, Dr. Chandru, Dr. Saraswati, all working in this field, and many more, of course. And they have got a lot of accolades for this. I am sure we will continue to work in this area to see that DMHP program sees better days too. There has to be a critique for all this, right? So we need to understand what else could be done, what could be done better, and what are those issues which we need to relook at. Unfortunately, the treatment gap continues to be phenomenally high. 80% of the patients still do not get treatment. Now that's a huge gap which we need to reduce. That is a major thing. And then there is a non-uniform adaptation of progress across states. Now this is something which needs to be administratively looked into. In terms of administration, there is multiplicity of administrative bodies resulting in fragmentation of responsibilities. I'll give an example. Health is a state chapter, but National Mental Health Program comes from the center. So it is something which the center is going to tell the states how to do it. It is not just going to be treatment only. So it just doesn't come only under Ministry of Health and Family Welfare. The rehabilitation part goes to the Ministry of Social Justice. So there are two departments. Now this is where more and more problems are being seen, which needs to be addressed. For everything there has to be a political will, there has to be a leadership. We had found quite a bit at some time or the other, and I think we are moving ahead, but a lot needs to be done. At the state and district level, what are the variances? It's a top-down approach, which is something which will not help now. One size fits all. That means the national says so, DMHP says so, everybody has to do the same thing. But that doesn't take the practicality. The problem at the grassroots would be different. So grassroots issues need to be addressed. Size of district and availability of consultants, proximity to district hospital and medical college are also important. Like there have been studies which say one of the district was just 200 square kilometers for a DMHP program. The other one covered 3,000 square kilometers. Now this disparity is quite huge and needs to be addressed too. What about human resources? There are 2 per 100,000 population of mental health professionals. This does not include just psychiatrists, it's others also. In terms of clinical psychologists, it's 50% shortage. The rates might vary with different studies. There are other issues also. Okay. Okay. Right. So I talk about poor pay scales. That affects all of us, isn't it? DMHP is no less. They are on contractual basis. There is no retainership motivation for most of these people. So that is something which is very important. Workload. They are made to work. The workload itself is very huge. And then there are administrative tasks also related to the mental health programs on which they have to undertake. Limited resources, lack of training and technical skills. Now most of these programs which I have read about, Dr. Rajini will throw more light of course, is, I'm trying to bring her into picture more and more because she's the one who's going to answer most of your queries, not me. The problem comes where most of the medical officers are trained only once or twice and then they are sent back to the society. So managing them, giving them updated programs is something which is very important, which we are lacking. I've talked about telepsychiatry and management of patients well, non-psychiatrists. This is the way forward to address this particular problem. Financing. It all started that the center would take care of all the programs of the state mental health programs, like that is the district mental health programs. Then it came through that it will be 60 to 40. That means the center is going to give 60%, state will have to take care of 40%. And then after 5 years of implementation, the state will have to take ahead. That means the finances will have to be taken care by the state. Now this is where the problem starts. You put some financial load on the state, they will start saying that they don't have adequate resources. So that's something which we need to address. Data and monitoring, documentation, lot of documentation to be done. There is definitely treatment gap which I spoke about. This is something very important, the biomedical versus community model. When I started my talk and I told you about the role of NMHP and DMHP, it was emphasized that it will be more of community level participation, understanding the suffering of the patient at the community level, but then came the psychotropic drugs, the medications, we started addressing. So as of now we are at the crossroad, we will not get into the other issues. We are now at the crossroad wherein we need to take care of the community with selected use of medications which are definitely helpful. In terms of funds available, only 10% funds are utilized. We all are oriented to pills only. That means any problem, we want that the pill should take care. That is something which is not one of the aims of DMHP. The forthcoming, that is the ongoing program of Ayushman Bharat and health and wellness clinics have just been established, and their role to go along with the DMHP are still to be defined. So what is the way forward? Expanding Taluk mental health program. We talked about district mental health programs. Now we are going to address issues at the Taluk level. Strengthening maternal mental health with RCH program. These are national programs. Strengthening child and mental health programs with the national programs for Balya and Kishore programs. Convergence with medical colleges for DMHP strengthening, which is taking place in most of the places now. Expansion of KABI across the state. This is all I wanted to present. Thank you so much. I request Dr. Rajini to add a few things to what I have presented, because she is the one who is the leader in this particular aspect.
Thank you, sir, for that wonderful presentation. Thanks the organizers for, I want to thank immensely the organizers for giving me an opportunity. Few additions. So actually Karnataka scenario is much better than other states compared to Bihar and other states. So we have a complementary supplementary system in Karnataka. We have district mental health program which is expanded across the state from 2016, and we have more than 40 psychiatrists under DMHP. We have around 70 psychiatrists in government medical colleges, and we have psychiatrists under health and family welfare services also. This is, and along with that, we know that Karnataka is one of the highest producers of PG psychiatry seats also, around 172 seats, including government and private medical colleges. So many states like Bihar, they have only, day before yesterday we had a review in Government of India. Like Bihar had only one psychiatrist who is also deputed to mental hospital care. So but Karnataka scenario is much better. So it is not top-down approach, it is bottom-up approach. So we start the care from house girl, and then even the Ayushman Bharat Arogya Mandirs, we have around 8,000. We are training all the CHOs every year periodically. And already around 2,500 CHOs under Ayushman Bharat Arogya Mandir health and wellness are trained, and they'll be trained every year. It is not once. And around 680 they have already started reporting. Their job is basically to screen everybody who hits the Ayushman Bharat Arogya Mandir, and they have to do brief counseling and they have to defer to the nearest PHC. So good thing is, I don't know whether the treatment gap is 80%. We have to re-look into it, because our consultations at the primary care was almost zero in 2016. Now it is up to 3 lakh consultation in a year. At taluk level, our consultations were around 10 to 20,000. Now it is annually 5 lakh plus consultations. Our consultations in public health institutions were around 60,000 in 2016. Now it is 10.2 lakh consultations. And then the Matru Chaitanya, like new initiatives, mother screening in the perinatal period, that was also almost zero. Now last year it is 4 lakh screenings have happened, and many have taken treatment also. And Dawa Dua project, I think first in its India, like if you see Murugamalla Dargah, Waqf Board and Minority Department has given, it's a collaborative initiative, where a counseling and treatment center is being built inside the Dargah premises. I think probably this is first in its kind in India. Our DMHP teams, they go and they treat up to 4,000 clients in the Dargah premises. So similar to that, Ukkada Gatri and other places also, where this myth is there, the psychiatry team goes there inside the premises of temples and dargahs also. They treat patients, and many are reintegrated. And also the funds, we have good funds, sir. Up to 80% we are spending. It is 10% maybe in other states. Karnataka is utilizing good amount of money also. We have a robust monitoring system which we have developed in collaboration with IIITB. So these are the few things that I want to highlight. So if you have any questions, I think there are a lot of initiatives. Government of India has not rejected not even one initiative what we have done. So we can take a lot of initiatives. For example, 15 initiatives, innovations we have done from Karnataka. Karnataka state is one of the highest in mental health who have done innovations in past 6 years. And one recent study was urban suicide prevention study, wherein just piloted in 5 hospitals. We found out 5,000 plus suicide attempt cases. Many were 6th attempt, 5th attempt, 4th attempt, 2nd attempt. And very heartening news is only 0.8% repeat attempts. Otherwise it is huge. And only 2 deaths out of 5,000 who also are 2 chronic schizophrenics. So this is being expanded to around 18 hospitals this year. So any innovation, anything what we are proposing, the Government of India or the state, they are very supportive. Probably we are very lucky, and all the higher officers, even including IAS officers, they are very, very supportive, and we are doing lot of innovations along with the DMHP services. So thank you, sir.
Thanks a lot. Thank you.
Comprehensively covered everything. But now I want to open the topic for question and comments. But we have very less time.
Good morning. So it was very good information for me. This my senior team learn more from you. My question is one thing. We know that for 30 to 40% of people don't require medication. That means they don't require a psychiatrist as a specialist, as a first contact. So almost 50% of our population requires only the person, someone who is equipped with psychological assessment, then screening them and sending them to the right person out. There is a huge gap, though this particular population not getting the treatment in time. What is the DMHP's plans for incorporating medical colleges? Because most of the doctors, they can handle these 30 to 40% of the patients in the periphery. How we can involve the medical colleges in addition to the funds which are being generated or supported by the community through the social welfare thing. Because that is, as you told, double-handed programs will not be that successful, sir. So what is this plan at district level and to the level of taluka and to the primary centers? Specifically, how we can equip our future doctors, I mean interns and the MBBS doctors, to take care of this 30 to 40% of requirements. Thank you.
Sir, thank you, sir, for this question. Sir, basically, as you rightly said, not many require medication. So in my comments also I told that the screening with a validated tool which has 10 questions, it starts from the CHOs, that is Community Health Officers of Health and Wellness Centers. So they basically screen everybody, and those who need counseling will be done there only, and then those who need medication, they will be referred to PHC. All the PHC doctors, we have around 2000 plus PHC doctors, they train periodically, and in the trainings we are utilizing the services of the medical college resource persons also. And many medical colleges like Chitradurga and other places, and even Mangalore, they are adopting taluks and PHCs nearby. Even St. John's has adopted. So we request all the medical colleges to come forward to adopt PHCs, CHCs and taluka hospitals, so that the services can be complementary and supplementary to the government initiatives. Because government alone cannot reach each person, 7 crore population, and 10 to 15% of them definitely need intense care, and as you rightly said, maybe 40% of them need non-medication services also. So that's how it is, sir. The strategy, the guidelines also we have written, wherever there is no DMHP psychiatrist, we request the medical colleges to give the services of their psychiatrists and psychologists and nurses. We have a remuneration for them also. So for example, if they go and see, we get up to 100 to 300 cases at taluka level on Super Tuesday clinics, that is Manojatanya clinics. If a doctor from medical college comes and if he sees minimum 60 patients, he would be given maximum of 3,000 per day. So that is a non-government medical college doctor. So many collaborations are there on the plate. I think we will be very happy if medical colleges come forward to any of these services.
So we have adopted one PHC. Ours is a private medical college. We have adopted one PHC. We go there once a month. So we have to just write a letter to them. There are certain formalities to be completed, and that will be done. So this is a good way, sir. I think that's what Madam also hinted at. And then we get the medicines from Infosys Foundation also. So Sudhamurthy would be very helpful. So she can access it. So we just need to adopt one particular PHC and then work towards it.
One or more.
Yeah, sure. Sorry, one or more.
We have 2,500 PHCs.
Let them start with one.
I'll take the advantage of because there is no more questions, I'll continue with one more point which I had to clarify. Now there is a buzzword that integrative medicine. How DMHP or the NMHP is planning to incorporate them into our role, because the alternative methods of like healers, faith healers sort of thing. I mean, not exactly faith healers, are the concerned people who are the spiritual leaders or the social leaders or the physical activities leaders like Ayurveda, yoga therapists and all. How we are planning to incorporate them into our scheme of affairs?
That's in line from past 8 years, sir. We also sensitize and train Ayush doctors and faith healers. And other departments like Women and Child Department, Agriculture, Horticulture, banks, everywhere, all the departments we sensitize. Ayush doctors also, we train every year periodically. And the faith healers also, from churches, dargahs, temples. So what they do is, it's like again similar to Dawa and Dua. So whatever you do, you can do. Whoever needs medication, please refer. That has been very helpful, sir. Like I quoted an example of Dargah. They do whatever rituals they want to do, they are doing. But up to 80 to 100 patients we see every Wednesday inside the Dargah premises. So that's why we are building a center. Similarly, we are planning in Gulbarga also. So that is one. The second point, what you asked, sir, Ayush doctors. Ayush also, those who want, they can avail Ayush services. So because Ayush doctors are also trained, they would do their job, and if they can't manage, they are referring to the PHC doctor or to the psychiatrist in the Mano Chaitanya clinics. So the numbers also are speaking, sir. In Mano Chaitanya camps, at the taluka level, it was almost a single digit, double digit. Now we are getting, for example, 3 months back I went to Anekal, we had 300 patients in one day, single day. Of course, Niman's community team is also helping there. And now we have moved into taluka mental health services. Karnataka is the first state to move on to the taluka. We had 10 taluks where one psychiatrist and one social worker is appointed. For example, Gauri Bindu, 400 patients were coming. So we have full-time psychiatrists there. Now Anekal we have proposed, so like that 14 taluks where it is hard to reach and where the number of clients, patients are more. So we have come out with that. And then yoga services are available. I mean, they have started in health and wellness centers. That is Ayushman Arogya Mandirs. So all these are, work in progress.
Yes. Yeah, there is a question. Yeah.
So my name is Sainath, sir, of second year MBBS. Sir, the project which was done in the survey which was done in Bellary district, sir. There I want to ask one basic question, sir, household level. If a family who has a patient of dementia, sir, which was a previous topic, the people around them, the caregivers, do you have any any suggestions for those people's mental health, like as the family, as the mental health of the entire family as a whole is important also.
Yeah. Now this is one of the most important aspects which you have brought about, and I am thankful for this question. That will reach her also. That will reach her also. Now one of the problem with the DMHP has been, if you look at the input, people who are going to serve are just the mental health professionals. The caregivers are not included, and that's a real unfortunate thing. I think going forward, that is one of the very strong things which has already reached them, that caregivers also have to be included, patients also have to be included. That means those who take service, they also have to be included in making out what the program of DMHP should be like. And I am grateful to you that you have raised this issue, because this is something which so far was not addressed to.
Nice that you asked this question. So recently, last month, we have started with the caregivers, addressing the caregiver burden also. We have started, I think we interacted with around 70 caregivers, and we did a program for them also, a day-long program. So a lot of this Mental Health Care Act mandates that also, and Karnataka we have started that under Karnataka State Mental Health Authority, where Commissioner chaired and even Justice N. Kumar was there with us. So we have started in that line also. Thank you.
Thank you, ma'am. Thank you, sir.
I think we are done with our time.
Thank you, madam. Time is over.
I think we are.
You should tell him.
I would like to welcome Dr. Rajni P, Deputy Director, Director of Health and Family Welfare. Welcome, ma'am. I now request the chairpersons to present a token of appreciation to Dr. Abhay Matkar.
Presentation.
Volume little bit increase, no?
डीन है क्या
Now I request Dr. Suresh P, Professor and Head of the Department of Radio Diagnosis, the Oxford Medical College Hospital and Research Center, to present mementos to Dr. Rajni P. and Dr. H. Chandrasekhar.
Chairman వచ్చాడు.
Thank you, sir. Thank you, ma'am.
Good morning, ladies and gentlemen. Knowledge is the weapon against ignorance, and ideas are the weapons against delusions. Armed with knowledge and ideas, let us battle out darkness in our minds. With these inspiring words, I, Dr. Varsha,
And I, Dr. Nritya, welcome you all with utmost pleasure and joy on behalf of the Department of Community Medicine
and Department of Psychiatry
for the CME on Strengthening Community Resilience, Optimizing Mental Health in the Modern Era.
Mental health is crucial for overall well-being, affecting how we think, feel, and act. It influences our ability to handle stress, relate to others, and make choices. Remember, mental health is just as important as physical health, and one way that it can be maintained is through finding a sense of community.
Community can be defined in many ways, but when simplified down to its most important element, it is all about connection. It's not just a group of people, but a feeling of being connected, accepted, and supported. This connection makes us feel wanted and love, aids us in navigating through the tough times, and infuses our lives with meaning. As social beings, we are not meant to live in isolation. Community is critical for us to thrive. It is more of a necessity than a mere desire.
Moreover, the importance of community extends deeply into our mental health. Being part of a supportive community can significantly reduce feelings of loneliness and depression, providing a sense of belonging and purpose. It fosters emotional resilience, offers practical support during difficult times, and enhances overall well-being. Reducing stigma, promoting awareness, and ensuring access to mental health services are essential steps in fostering a healthier, more resilient community.
Established in 1974, the Children's Education Society aimed for academic excellence. Led by visionary Vidyashri S. Narsaraju Garu sir, and continued by our beloved chairman Shikshana Bhishma Dr. SNBL Narsimharaju Garu sir, which led to the origin of the Oxford Medical College Hospital and Research Center, Bengaluru. This leading institute in healthcare, education, and research prioritizes addressing mental health concerns among other health issues.
We welcome you, sir. Learning is a journey, and the touch of divinity is necessary to aid us and to keep us motivated.
Now, I request Ms. M. Lekha to invoke the Almighty and pray for the abundant blessings.
పడింది ఊగుతుంది
గణేశ్వరం భజామి సతతం సురేశ్వరం భజామి సతతం సురేశ్వరం శ్రీరజానయుతం గణేశ్వరం అజేంద్ర పూజిత విఘ్నేశ్వరం గణాది గణాది సన్నుత పద కుంజల మంజల చతురకరం కుంజల మంజల చతురకరం గురుగుహాగ్రజం నరవాకారం ప్రజానయుతం గణేశ్వరం ప్రజానయుతం గణేశ్వరం.
Thank you, Ms. M. Lekhana.
The lamp is a symbol of dedication, devotion, and the continuous pursuit of knowledge. It signifies the need to share the knowledge acquired and lead others along the same path. Let us now light the lamp and pledge to the forthcoming with our learning.
I request the Chief Guest, Dr. Rajni P., Guest of Honor, Dr. Anna Rao G. Kulkarni, the Chief Patron and Chairman of the Oxford Educational Institutions, Dr. S.N.V.N. Narasimha Raju Garu Sir, to come forward and inaugurate today's CME by lighting the lamp. I request the other dignitaries to join them.
It'll be too loud now. It'll be too loud now, that's why. కూర్చోలేరు ఒక చోట. వీళ్ళని ఎవరు పిలవట్లేదు కదా. అవసరం విల్ స్పీక్.
Thank you, dignitaries. I now invite a person with dynamic principles, exemplifying discipline and determination, Dr. Lalita D. Hiramat, Professor and Head, Department of Community Medicine, the Oxford Medical College, Hospital and Research Center, to welcome the gathering.
A very good morning to one and all present here. I extend my warm welcome to each and everyone gathered here to today's CME program, hosted by Department of Community Medicine in collaboration with Department of Psychiatry. I am deeply honored to stand before you as we embark on a journey to explore the critical theme, that is, strengthen the community resilience, optimizing the mental health in modern era. In an age defined by the unprecedented challenges, the significance of nurturing mental well-being within our communities cannot be overstated. It is a call to action that resonates with every healthcare practitioners and researchers present here today. Our college has rich tradition of organizing such CME program in all streams of medicine to enlighten our young minds and promote participation of future doctors to serve society. In this modern era, the concept of community resilience has gained the paramount importance, particularly in the realm of mental health. There is a need for multidisciplinary approach that engages healthcare professionals, community leaders, policymakers, and individuals themselves in contracted effort to promote the mental health literacy and reduce the stigma surrounding mental illness through collaborative effort and innovative strategies. We can create future where mental health is not only supported but celebrated as cornerstone of thriving communities. I would like to share a quote on mental health by our beloved Narendra Modi ji. Let us work together to create stigma-free environment where the mental health is prioritized and every individual feels supported in their journey to well-being. On this note, I would like to welcome Chief Patron of today's CME, Dr. S.N.V.L. Narasimha Raju Garu, Sir, Chairman, Children's Education Society, the Oxford Group of Institute, who bestowed us with his never-ending support and guidance in enhancing our knowledge and creativity to conduct events. Sir, you are the source of inspiration. We welcome you, sir.
I would like to invite Dr. Murli T to present a memento to our chairman, sir.
I am glad to welcome our chief guest, Dr. Rajni P, Deputy Director Mental Health, Directorate of Health and Family Welfare, Bengaluru, Karnataka, for today's CME. We are truly delighted to welcome you, ma'am.
I would like to request Dr. Murli T to present a memento to Dr. Rajni P.
I would like to welcome guest of honor, Dr. Annarao Kulkarni, Indian Association of Preventive and Social Medicine President, Karnataka State Chapter. We deeply appreciate you for the sparing your valuable time to be with us, sir. We welcome you, sir.
I request Dr. Sapna Bhima to present a memento to Dr. Annarao Kulkarni, sir.
I express my gratitude to our esteemed Dean cum Director, Dr. Sia Janti Ma'am, the Oxford Medical College, Hospital and Research Center. Your advice is guiding force for all our activities. We welcome you, ma'am.
I request Dr. S. Dilip sir to present a memento to our Dean Ma'am.
I am pleased to welcome our respectful Medical Superintendent, Dr. V.B. Gowda sir, for this CME. We welcome you, sir. I extend my welcome to Deputy Medical Superintendent, Dr. Sanjay. I would like to extend my warm welcome to all eminent speakers from NIMANS, SDM, MVJ, KIMS, and Spandana Health Center, who have traveled all the way and made it a huge effort to join us today. I welcome you all. Our unparalleled speakers include Dr. Shivakumar, Dr. Abhay Matkar, Dr. Kasturi Pandey, Dr. Mahesh Gowda, Dr. K. Naresh, Dr. Manjunath Ashwat, and Dr. S. Dilip. We welcome you all. I am glad to welcome organizing chairman for the today's CME, Dr. Murali T, Professor, Department of Psychiatry, President, IPS Karnataka Chapter, and the immediate past president of the World Association of Psychiatry, whose leadership and exceptional dedication have been instrumental in bringing this event success. I welcome you, sir. I am delighted by presence of registered delegates, heads of the department, faculty, postgraduate students, and undergraduate students in this CME. I welcome you all. As we delve into the insightful discussion, let us remember that each exchange of knowledge has a potential to transfer lives. Let us harness the power of collaboration and innovation to prepare the way of healthier and more resilient tomorrow. Once again, I extend warm welcome to all. May our deliberation be fruitful, our connections meaningful, and our endeavors impactful. Thank you, Anna.
I request Dr. Shweta ma'am to present a memento to our MS Dr. V.B. Gowda sir.
Thank you for your words, ma'am. A harmonious blend of compassion and competence, her extensive medical background combined with an unwavering dedication to public health has been the cornerstone of numerous initiatives that have transformed community health standards. I now invite the chief guest for today's CME, Dr. Rajni P., Deputy Director, Directorate of Health and Family Welfare, to say a few words to everyone present here.
Good morning, everybody. I think already I have spoken enough. I think I'll just start with one story and end with another story. So, a lot of young minds are there. So, I just want to start with a story. So, imagine that all of you are, I usually use this story very often. So, imagine you are all young, and you are young, 2021. And all of you can go back to 2021. You are in, you like this person in the opposite house. Yak madam adella haled gnapstira. So you like this person in the opposite house. I think many of them, which house madam? That's right. Okay. So 6 months you are close friends, everything, dating, everything is fine. One day early morning, you see your person going with another person in a BMW car, right? So what's your first reaction? Quickly you can tell your first reactions. Sir? No reaction. So shocked. Okay, next reaction. Sad. Okay, young people, What is your first reaction? Sorry? Angry? Sad? Sorry? Jealous? Yes, very good. Then I'm not getting any reactions from that side. Appreciate the nice car. Then, sorry? Revenge? Yes, very good. Then, anybody who has good voice? I mean, loud voice. Stab? Yes. Learned from the previous TV news. Any other reaction? Huh? Relief. Okay. ಬೇರೆಯವ್ರನ್ನ ಹುಡುಕೋಬಹುದು ಅಂತ. Sorry? Gym. Okay. So you are stressed out and same scenario, different reactions. Actually, father had chest pain. She was going to hospital with her cousin. So did we think in this line? Yaradu? Abhay Matkar. So this is how the stress happens. The definition of mental health is you should know your strengths and weaknesses. You should be able to manage your day-to-day stressors. This is a day-to-day stressor which I gave you an example. Did we manage well? Yes or no? No. Are we mentally healthy? Okay, let's work towards that. Okay? And we should contribute something to the society. This is the definition of mental health. I'm sure a lot of speakers are there. So I will end with another story as promised. So Gandhiji once was with a history teacher. History teacher told Gandhiji, it seems, Gandhiji, you are Upavasa, Satyagraha, all these things, I don't think so. I've never read in the history that this will pay results. This will not pay us independence. So then what Gandhiji told? Any guess? Any guess? Look teacher, your job is to teach history, my job is to create history. Let us, can't hear. Create history in improving mental health services, at least in Karnataka and then globally. Thank you very much.
Thank you, ma'am. We really appreciate you for engaging the audience. Next, a man par excellence, Dr. Anna Rao G. Kulkarni, National President, Indian Association of Preventive and Social Medicine, and Professor and Head, Department of Community Medicine, Sri Madhusudana Sai Institute of Medical Science and Research, is known for his perseverance and a perfectionist. I invite sir on stage to say a few words, everyone gathered here today.
Phoned me and asked me to be here for the CME. I was very happy. At the same time, I was stressful also. What to speak in front of such luminaries, I don't know anything about the mental health. But I appreciate the organizers for choosing such an important topic, because mental health is a state of mental well-being that enables people to cope with the day-to-day stresses. Madam has already stated, we should be able to cope with this day-to-day stress in our life and realize our own abilities and learn well, work well, and contribute to the society. So this is what is mental health according to me. It is an integral component of health, because all of us know WHO definition of health. Health is a state of complete physical, mental, social well-being, and not merely the absence of disease or infirmity. But most of the times, we only bother about physical health. Even the doctors always consider physical health. But according to me, mental health is more important than the physical health. A physically strong person may be mentally weak, and a physically weak person may be mentally strong. So you compare which is better. So therefore, and even the WHO says the majority of the health problem in the world are psychosomatic. The origin is in the psyche and manifestation in the soma. But when we go, most of the doctors say, okay, they examine you, they investigate you and say NAD. Okay, what is NAD? Any postgraduate? Not able to diagnose according to me. Okay, it is not validly detected. They are not able to diagnose correctly. So therefore, we have to think that mental health is more important than physical health, and we must consider mental health as a priority in our life to be able to contribute positively for the society. Now, how do we maintain our health, particularly the mental health? I am not an expert in mental health, but I am a trained yoga teacher and a trained Bhagavad Gita teacher. So I always fall back on Bhagavad Gita. See, we have stress, anxiety, worry every day in our life. Stress has become modern days. Stress is everywhere in every aspect of life, and we should be able to handle. Is it that stress has come only now, or was it not there? It was existing there also, as evidenced by Arjuna's state when he came for the battlefield. Okay. See, in the first chapter of Bhagavad Gita, Arjuna is telling how nervous he is, how anxious he is, how worried he is, how tense he is. He says, Sidanti mama gatrani mukhancha parishushati vepatuscha sharire me romaharashascha jayate gandivam srausate hastat tvakchaiva paridahyate nacha shaknomyaham yatum bhramati vacha me manaha. So the meaning is, Sidanti mama gatrani, my hands and legs are trembling. Okay, why they are trembling? Okay, is it that he came from rising from the bed and came for the war? No, there was a preparation for the war. Everybody knew that there is going to be a war. He is standing in front of the battlefield, the opposite army. There was stress building up. So we do not realize that stress is building up in our life. There may be a trigger factor which may precipitate the signs and symptoms. So here, the signs and symptoms Arjuna has explained. So, Sidanti mama gatrani, trembling. Mukhancha parishushati, my mouth has become dry. Vepatoscha sharireme, my whole body is becoming weak. I can't even stand. Okay? So I am not able to hold my Gandiva Dhanusha. So these are all typical signs. So that means stress was there also, anxiety was there also, but it has become more common nowadays. So we will have to understand how to deal with this stress. So Bhagavad Gita, while it addresses the various aspects of life, it provides an invaluable insight into the realm of the mental health. Its core, the Gita teaches how to find inner peace, manage stress, and overcome emotional turmoil. So, just for example, so in the Bhagavad Gita, in the chapter 6:34, so again, after lot of explanation, Krishna convinced him to go to war because he did not want to go to war, seeing his gurus, seeing his grandfather, classmates, everybody. So he was confused. So after convincing also, he says, Chanchalam hi manah Krishna pramati balavadhridam tasyaham nigraham manne vayo rivasudushkaram. Mind is very difficult to control. Okay, how to control the mind? I don't know. It is very, very chanchal. So this is the reason. Unfortunately, after so many years of experience also, being a doctor, honestly I have to admit, I don't know what is mind, where it is, okay, whether it is in the brain or whether it is somewhere else, what is its real function. But Bhagavad Gita and yoga give you some insight into the mind much better than the modern medical science. So there are a lot of chapters in Bhagavad Gita. I suggest youngsters particularly, because they are the ones who are going to face a lot of stress in their life. So we have to understand the importance of our scriptures. So there are 4 important things that I want to tell you to fall back on this Bhagavad Gita. The first is mental health tips are very, very important, and that is there in Bhagavad Gita. The first one is you have to do your work without any expectation. Karmanyeva adhikaraste ma phaleshu kadachana ma karma phala heturubho ma te sangostu karmani. Doing your job is your right, but expecting the result is not your like in the examination, answering the questions is the duty of the student. Reading, answering the questions, but giving the result is in the hands of the examiner only. So you cannot have the right to give the results yourself. So that is what is the first thing. Second one is you have to live the life of moderation. Okay? Ati sarvatra varjayet. Extreme things anywhere and everywhere is not good. So we have to have moderation. There also they have said yukta ahara viharasya yukta cheshtasya karmasu yukta swapnava bodhasya yogo bhavati dukkha. That means everywhere the word yukta. Yukta is appropriate. Okay? We have to have appropriate things in everything. Your entire lifestyle has been given in Bhagavad Gita. I think because of shortage of time, I will not go into details. So I only request all the students at least have a glance at Bhagavad Gita. Whatever good in our scriptures, okay, retain those things. Whatever good in the modern science, add it to that, and that will help you to retain the mental health. Thank you.
Thank you for your inspiring words, sir. Moving on, let's extend our heartfelt congratulations to Dr. Rajni P. and Dr. Anna Rao G. Kulkarni for their exceptional contributions to medical education and patient care. Their dedication and innovative work inspire us all. We are honored to celebrate your achievements today.
For this, I would like to call upon Dr. SNVL Narsimharaju Garu Sir, Chairman, the Oxford Educational Institutions, for felicitating Dr. Rajni P. and Dr. Anna Rao G. Kulkarni. I request all the dignitaries to join them.
There's a switchboard there, on it, no? Varun, switchboard is that side, on the switch, no? Center light, ra. On it. Don't ask, sir. Do we need that projector? Center projector. Sir, ask, sir. Varun. Sir, Bible, sir. Do we need the projector in the middle? Projector in the middle. We still have work with that. Presentation. That's what he is asking, whether to switch off or keep it like that. No, tell him. After tea break. Tell him. Tea break will do.
I now wish to invite the man of principles who works with utmost sincerity for the growth of this institution, Dr. SNVL Narasimha Raju Garu Sir, to deliver the presidential address.
ಎಲ್ರಿಗೂ Namaskara. Good morning, ladies and gentlemen, boys and girls. It gives me immense pleasure and a great honor
Outside everything is ready.
to be here on this Temple of Learning, the Oxford Medical College Hospital and Research Center. Dr. Jayanti, the Dean, the Principal, the Oxford Medical College, the Medical Superintendent, Dr. Gowda, the HODs of the two departments where we are all conducting, celebrating continuous development program, the community medicine and the psychiatric medicine, community medicine HOD Lalita Hiremat, Dr. Sapna, the HOD of the psychiatric department. It is a very good thing to note and acknowledge that these two departments have come together in conducting this continuous development program. First of all, I'd like to congratulate these two departments coming together. It's a great honor lighting the lamp and nice invocation which has lifted the emotions of each one of us by our students and staff, and it was very impressed. Great learned people like Dr. Kulkarni is a very well-known man in the field of medicine, Dr. Rajani, and it is a great honor for all of us to felicitate these two great people who have contributed to this medical education and the upliftment of the clinical training to the students, and especially the clinical materials, that is patients, are being benefited by their efforts. I congratulate both of you in this Temple of Learning, and not only it is a great honor for us to honor this great personality. Continue doing the same thing, contribute to the society, and let us all move forward. And Dr. Jagajeesh and Dr. Chandrasekhar, a very experienced elderly person, they had a very nice coordination between the Dean, Jayanti Madam, and Chandrasekhar. It's a very nice to note. Other speakers who have taken time out and physically being present in this Temple of Learning, I immensely thank on behalf of the Children's Education Society and on behalf of the Oxford Group of Institutions, myself, my trustees, my students, and the teaching fraternity for accepting the invitation, gracing today's function. Especially one thing, sharing your learned knowledge to the students for the benefit of the clinical materials and the staff. It is the greatest thing to know and acknowledge. I immensely thank you for this wonderful opportunity and feel good. I think to the best of abilities of the students community, and especially I feel happy that the PG students, you have to put in your efforts. One thing I like to share, that all our departments which have gone for recognition is recognized. I like to congratulate the teaching fraternity and the students, all the PG departments which has gone for recognition. All the departments have been recognized. We are waiting official letter. I think I will take that opportunity, but because in front of August gathering, this is a very happiest moment which I wanted to share and express. That is why I think students especially PG and UG students. Your insight and whatever the upgraded knowledge the teachers, the speakers have shared, I think you have taken into your heart and mind, and you have to apply thoughts. When I always say that it should benefit the clinical materials, that is the patients by large. I think I once again repeat that Dr. Sapna and Lata had taken a great initiative. I immensely thank including the principal and the superintendent for organizing and inviting the very learned people. I think subject-wise, they are the best who can talk to you. Sir, we have created a great infrastructural facilities, and we are moving forward on the track and take this institution to the next level, where the visionary Sri S. Nasaraju, who was established as a teacher, this great institution, and we are looking forward. A lot of other activities which is coming up. I think in another 1.5 years maximum, we will be all celebrating the CME programs, our PG convention, our UG convention, department-wise in our bigger auditorium capacity and a bigger seminar room capacity, which has already been planned, and soil test has happened, drawings are ready, we started executing the construction facilities. This is what it is a very healthy competition. Lot of institutions are coming up, we have to catch up with, we have to be always on toes. For this, the student community and teacher community play a very, very important role in taking the vision of this institution forward. I thank the organizers for giving me this wonderful opportunity to be here. God bless you. I pray Almighty to sprinkle His best wishes in all your endeavors. Thank you. Thank you very much. This is a shawl from Tirumala. Don't know how many of you are aware. We have built a guest house on Hapil in Padmavati Nagar in the name of Shri Sheshachala Nilayam. This is built by the Oxford institution, and I take this opportunity to put them the shawl from Tirumala, Tirupati, Sri Venkateshwara.
Thank you, sir. Today, we have the honor of felicitating our esteemed chairman, Dr. S.N.V.L. Narasimharaju Garu, sir, the chairman, Oxford of Education Institutions, the guiding force behind our organization. His leadership and vision have been instrumental in driving our success and innovation.
I would like to call upon Dr. Murli, President, Indian Psychiatric Society, Karnataka Chapter, and Professor, Department of Psychiatry, the Oxford Medical College, Hospital and Research Center, for felicitating our chairman, sir. I request the other dignitaries to join, sir.
Keep it aside. Break.
Thank you, sir. Thank you, madam. We now take a break for tea. I request all of you to join us in the auditorium by 12:20 for further sessions. I request the students to stay back.
Third year students and second year students, please stay back. Attendance will be taken.
ఇదే బాగుంది, ఇదే బెటర్. ಇದೇನು ಮಾಡೋದು? ಪಾಸ್ ಮಾಡ್ಬೋದು. ಇನ್ಸ್ಟೆಂಟ್ ಡೋಂಟ್ ಗಿವ್ ಇನ್ಸ್ಟೆಂಟ್, ಡೋಂಟ್ ಗಿವ್, ಜಸ್ಟ್ ಕೀಪ್.
ಶೇರ್ ದಿಸ್ ಡೌನ್ಲೋಡ್ ಮಾಡ್ದೆ, ಮೀಡಿಯಾದಲ್ಲಿದೆ.
ಹಾಂ, ಇದು ಮೇಲ್ ಮಾಡಿದ್ದೀರಾ?
ಮಾಡಿದ್ದೀನಿ.
ಅದು
ಡೌನ್ಲೋಡ್ ಮಾಡಿ.
ಅದೇಸಿ ಯೂಟ್ಯೂಬಲ್ಲಿ ಬರ್ತಾರೆ ಮೇ ಬಿ. Go from that side, no? Go from that side. Everyone go from that side. Don't come this way.
ఎడిట్ చేసామా?
కాదు వాడు వస్తాడు, ఏదో చేస్తాడు.
ఇది నొక్కు క్రియేట్ హైలైట్ వీడియో. అది కాదు, ఇక్కడ నొక్కు. ఇక్కడ ఏదో ఉంటుంది సెట్టింగ్స్ నొక్కు. క్వాలిటీ 480 ఉంది అంటారా? స్ట్రీమ్ సెట్టింగ్స్
ಆಗ್ತಾನೆ ಇದೆಯಾ? ಸ್ಟಾಪ್ ಮಾಡೋ
ಲೈವ್ ಸ್ಟಾಪ್ ಮಾಡಿ ಅದು ಡೌನ್ಲೋಡ್ ಮಾಡಿದೆ.
ಸೇಮ್
when you downloaded OBS ಪಾಸ್ವರ್ಡ್ ಕೇಳಿಲ್ವಾ?
ಅದೇ
ಕೇಳಿಲ್ವಾ?
ಡೌನ್ಲೋಡ್ಸ್ ವೆರಿ
ಡೌನ್ಲೋಡ್ಸ್
ವೆರಿ
ವೆಬ್ಸೈಟ್ ಇಂದ ಓಪನ್ ಡೌನ್ಲೋಡ್ ಮಾಡಿ.
ಮೇಲಿಂದ ಮಾಡಿ. ಮೇಲಿಂದ ಡೌನ್ಲೋಡ್ ಮಾಡಿದೆ. ಇದರಲ್ಲಿ ಡೌನ್ಲೋಡ್ಸ್ ಮಾಡಿದ್ದೀವಿ.
ಅದೇ
ಆ ಪಿಕ್ ಕಾಣಿಸ್ತಲ್ಲ,
ನೀವು ಅಲ್ಲಿ ಸರ್ಚ್ ಕೊಟ್ಟಿದ್ದೀರಾ? ಸರ್ಚ್ ತೆಗೀರಿ, ಅದು
ಇದೆಲ್ಲ
ಇಲ್ಲಿ ತೆಗೀರಿ, ಅದು ಇಲ್ಲಿ ಇದನ್ನು ತೆಗೀರಿ.
ಓಕೆ, ಆಲ್ ಫೈಲ್ಸ್
ಕೊಡಿ.
ಆಲ್ ಫಾರ್ಮ್ಯಾಟ್ಸ್ ಅಲ್ಲ, ಆಲ್ ಫೈಲ್ಸ್.
ಕೆಳಗಡೆ ಇವಾಗ ಬಂದಿರೋದು ನೋಡಿ.
ಮೇಲೇನೆ ಇರಬೇಕು.
ಫಸ್ಟ್
ಡೌನ್ಲೋಡ್ ಮಾಡಲಿಲ್ಲ.
ಏನು ಡೌನ್ಲೋಡ್ ಮಾಡಿದ್ದೀರಾ? ಇದು ಇಲ್ಲಿ ನೋಡಿ, ಅದೇ ತಾನೇ
ಡೌನ್ಲೋಡ್ಸ್ ಕವರ್ ಪಿಕ್ 1
చూడరా
ಕವರ್ ಪಿಕ್ ಡೆಸ್ಕ್ಟಾಪ್ ಅಲ್ಲಿ ಕಾಪಿ ಮಾಡೋಣ
ಹೇಳ್ದಾಕೆ
ಡೆಸ್ಕ್ಟಾಪ್ ಸಿ
ಅಲ್ಲಿ ಬಂದು ನೋಡಿ ಕೆಳಗಡೆ CMA ಅದು
ಕವರ್ ಪಿಕ್
ಯಾಕೆ ಸಿಗ್ತದೆ
ಅಲ್ಲಿ ಸರ್ಚ್ ಕೊಡಿ ಅದು ಅದೇನಂತ ಹಾಕಿದ್ದು ಫೈಲ್ ಅದು
ಕವರ್ ಪಿಕ್
ಫೋಲ್ಡರ್ಸ್
ಇಟ್ಸ್ ನಾಟ್ ಶೋಯಿಂಗ್
ಫೈಲಲ್ಲಿ ಡೌನ್ಲೋಡ್ ಆಗುತ್ತೆ ಸಿಗಲ್ಲ
ಡೌನ್ಲೋಡೆಡ್ ಬಟ್ ಇಟ್ಸ್ ನಾಟ್ ಶೋಯಿಂಗ್
ಒಂದು ನಿಮಿಷ ನಿಮ್ಗೆ ಇವಾಗ ಎಲ್ಲಿ ಯಾವ ಫೋಲ್ಡರ್
ಡೆಸ್ಕ್ಟಾಪ್ ಅಲ್ಲಿ ಹಾಕಿ ಎಲ್ಲರೂ ಒಂದು ಕಡೆ ಅದು ಡೇಟಾ ಫುಲ್ ಮಾಡಿ
ಎಲ್ಲಿ ಇದೆಯೋ ನೀವು ಬಂದಿದ್ದು
ಅದು OBS
ಶರತ್ ಅದು ಇದಾಗಿದ್ದಾರೆ ಮೇಡಮ್ ಒಂದು 75 ಆಗಿದೆ ಐಡಿಯಾ ಇಲ್ಲ ಬಟ್ ಅದಕ್ಕೆ ಗ್ರೂಪಲ್ಲಿ ಮೆಸೇಜ್ ಮಾಡ್ತಾರೆ ಪ್ಲೀಸ್ ಲಾಗಿನ್ ಅಂತ ಶರತ್ ಸರ್ ಸ್ವಲ್ಪ ಗ್ರೂಪಲ್ಲಿ ಮೆಸೇಜ್ ಮಾಡ್ತಾರೆ
ಮಾಡ್ತೀನಿ ಮಾಡಿದ್ದೀವಿ
ಹಾಂ ರಿಪೀಟ್ ಮಾಡಿ
81 127 99
ಡೆಸ್ಕ್ಟಾಪ್ ಅಲ್ಲಿ ತಾನೇ ಪೇಸ್ಟ್ ಮಾಡಬೇಕು
ಹಾಂ ಬೇಗ ಮಾಡಿ ಸ್ವಲ್ಪ ಯಾಕಂದರೆ ಮಿಡಲ್ ಪ್ರಾಜೆಕ್ಟ್ ಚೆಕ್ ಮಾಡಬೇಕು
123 128
ಎಲ್ಲಿದೆ
ಕವರ್ ಪಿಕ್
ಇಲ್ಲೇ ಇದೆ ಅಲ್ಲ
ಹಾಂ ಇದೆ ಬಟ್ ಇದ್ರ ಸಿಗ್ತಲ್ಲ
దాంట్లో చూపించట్లేదు
121 105
డౌన్లోడ్స్ లో కానీ ఇక్కడ చూపించట్లేదు
105 95
ఇది 2 ప్లేసెస్ అనుకుంటాను ఇది డిఫరెంట్ ఇంటర్వ్యూ ఇది
130 104 84 108
రీసెంట్స్
159 71
difficult to find
62 61
ಆಪಲ್ ಅಲ್ಲಿ ಬಹಳ ಹಿಂಸೆ ಕೊಡುತ್ತೆ
125
ವಿಂಡೋಸ್ ಇಸ್ ವೆರಿ ಯೂಸರ್ ಫ್ರೆಂಡ್ಲಿ
40
ನಾನು ಅಷ್ಟೊಂದು ಇದು ಎರಡು ಇಲ್ಲಿ ಯಾಕೋ ಡಿಫರೆಂಟ್ ಪೇಜ್ ಇದು ನನಗೆ
90
no we want image
I know Jay but ಇದು ಯಾಕೋ ಡಿಫರೆಂಟ್ ಇದು ಬರ್ತಾ ಇದೆ
12
ಡೌನ್ಲೋಡ್ಸ್ ಅಲ್ಲಿ
10
ಅಲ್ಲಿ ಆಲ್ ಫಾರ್ಮ್ಯಾಟ್ಸ್ ತೆಗೆದ್ಬಿಟ್ಟು ಆಲ್ ಫೈಲ್ಸ್ ಅಂತ ಕೊಡಿ ಇನ್ನೊಂದು ಸರಿ ಕೆಳಗಡೆ ಆಲ್ ಫೈಲ್ಸ್
ಕೊಟ್ಟರು ಬರಬೇಕು
ರಾವಟ್ಲೆಸ್
145
ಅಲ್ಲಿ ಚೇಂಜ್ ಮಾಡಿ ಅಲ್ಲಿ ಹೋಗಿ ಅಲ್ಲಿ
32
ಇಲ್ಲಿ ಶರತ್ ಅಂತ ಯೂಸ್ ಮಾಡಿ
65
ಹಾಂ ಅದರಲ್ಲಿ ಇರಬೇಕು ನೋಡಿ
83 152
ప్లేస్
158
ఇంకేం ఫోల్డర్లు ఉన్నాయి చూడు ఇక్కడ ಇಲ್ಲಿ ನೋಡಿ
34
ಇಲ್ಲಿ ಒಂದು ನಿಮಿಷ ಹೋಗಿ ಇಲ್ಲಿ ಇದ್ರಿಗೆ ಬನ್ನಿ
ಮ್ಯಾಕ್ಬುಕ್
ಏರ್ ಬನ್ನಿ
54 53
ಇಲ್ಲ ಇದು
77 64 117
ವೆರಿ
90 126 151
ಏನು ಕಾಂಪ್ಲಿಕೇಟ್ ಆಗಿದೆ
131
ಐ ಆಮ್ ಕಮಿಂಗ್ ನೋ
135
ನಿಮ್ದು ಮಾತ್ರ
ನನಗೂ ಐಡಿಯಾ ಇಲ್ಲ
31 73 102
ಈಗ ದಿಸ್ ಇಸ್ ಆಡೆಡ್
102
ಸಿ
73 okay 102
ಹೋಗ್ಲಿ ಅದನ್ನ
ಇಲ್ಲಾಂದ್ರೆ ಸೇವಸ್ ಏನಾದರೂ ಮಾಡ್ಬೇಕಂತ ಓಪನ್
ಡೆಸ್ಕ್ಟಾಪ್ ಬಿಡಿ
ಆಮೇಲೆ ತಗೊಳ್ಳೋಣ ವಿ ವಿಲ್ ಟೇಕ್ ಲೇಟರ್
142
ನೋ ವಿ ವಿಲ್ ಟೇಕ್ ಲೇಟರ್
ఏమైనా సేవస్ చేయలేము
ఈవినింగ్ ನಾನು ಕೊಡ್ತೀನಿ
70
ఇదా
ಮೇಡಮ್
55
షేర్ కదా సార్ సేవస్ ఏమైనా ఉందా
124 96 141 141 140
ವಿಲ್ ಯು ಚೆಕ್ ಐ ಚೆಕ್ ದ ಮಿಡಲ್ ಪ್ರಾಜೆಕ್ಟ್
110
ಮೇಡಮ್ ಈಗ ಬೇಡ ಅಂತ
146
ಅಟ್ಲಾಸ್ ಎಂಡಲ್ಲಿ ಎಲ್ಲ ಒಟ್ಟಿಗೆ ಕೊಟ್ಬಿಡು
130
ನೋಡ್ತಾ ಇರ್ತಾರೆ ಕೂತ್ಕೊಂಡು ಒಂದು ನಿಮಿಷ ಮಿಡಲ್ ಪ್ರಾಜೆಕ್ಟ್
సార్ ఇది మళ్ళీ సేవ్ చేయడమో ఏదో ఒకటి చేయాలి ఒకసారి ఏమైనా ట్రై చేయండి
160, 149, 144,
ఓపెన్ విత్ అనండి ఒకసారి
97, 38, 48, 147,
లేదు
68, 153, 155,
జేపీజీ ఇమేజ్ కానీ అక్కడ చూపించట్లేదు
43, 26, 29,
మొత్తం
136, 30,
మొత్తం డాట్ జేపీజీ అది కూడా తీసేయండి
32,
డిలీట్ చేయండి
82,
ఓబిఎస్లోకి వెళ్ళండి
23, 98,
ఇక్కడ
ఇక్కడ
డౌన్
వచ్చింది.
వచ్చిందా ఇప్పుడు వచ్చింది
60,
ఓపెన్
60, okay, 56, 114, 21, 107, 41, 57, 36,
వచ్చేసాయి
113, okay, 132, 87, 148, 111, 101, 69. Everyone go back and call out the auxiliaries again. 96. 69. 69. 25. 'Okay.
వెళ్ళాలి మన క్యూతో ఏమైనా వెనక్కి వెళ్ళి
So she asked for water bottle.
का कंपनी खोल दी है लैपटॉप बराबर
Look, mine how it is working. Full clarity.
रेटाइना डिस्प्ले इसमें क्या यूट्यूब चल रहा है
Lunch, how you go on cooking actually?
You got last week.
Last until our next session already is like now.
only one session then lunch
I think we need to skip. ಇವಾಗ half an hour ಮುಂದಕ್ಕೆ ಹೋಗ್ತಾ ಇದೆ ಎಲ್ಲಾನು. If we have to start correctly the lunch, you cannot attend the lunch. ಹಾಫ್ ಅನ್ ಅವರ್ ಆಗುತ್ತೆ ಇವಾಗ 15 ಮಿನಿಟ್ಸ್ ಡಿಲೇ ಮಾಡ್ತಾರೆ ಒಂದು ಸೆಷನ್ ಮುಂದಕ್ಕೆ ಹೋದಂಗೆ ಆಯ್ತಲ್ಲ
One session you have ಎರಡು session ಮಾಡೋದು
ಅಲ್ಲ ಮ್ಯಾಮ್ ಇವಾಗ 30 ಮಿನಿಟ್ಸ್ ಹಿಂದೆ ನಡೀತಾ ಇದೆ ಲ್ಯಾಗಲ್ಲಿ ನಡೀತಾ ಇದೆ ಇವಾಗ ಒಂದು 15 ಮಿನಿಟ್ಸ್ ಲೇಟ್ ಆಗುತ್ತೆ ಸೊ ಒಂದು ಸೆಷನ್ ನಾವು ಲಂಚ್ಗೆ ಹೋಗ್ತಿದ್ರೆ ಒಂದು ಸೆಷನ್ ಒಂದು ಸ್ಪೀಕರ್ ಕರ್ಸ್ಬಿಟ್ಟು ವಿ ಹ್ಯಾವ್ ಟು ಕ್ಯಾರಿ ಆ ಥರ ಅಲ್ಲ ಒಂದು ಸೆಷನ್ ಲ್ಯಾಗಲ್ಲಿದೆ ಅಂತ ಅನ್ಸುತ್ತೆ ನನಗೆ 45 ಮಿನಿಟ್ಸ್ ಲ್ಯಾಗಲ್ಲಿದೆ ಇವಾಗ 30 ಮಿನಿಟ್ಸ್ ಇದ್ದೀವಿ ಫುಡ್ ಈ ಬ್ರೇಕ್ ವಾಪಸ್ ಬರೋದು 45 ಮಿನಿಟ್ಸ್ ಲ್ಯಾಗ್ ಹೋಗ್ತೀವಿ
Auditorium this is first, right? ಅದು ಹೋಗ್ಬಿಟ್ಟೆ ಇಂಟ್ಲಾಗ ಟೀ ಚಾ ಬರೋಂದರು ಎರಡು ಸಿಕ್ಕಿಲ್ಲ
ಹಾಂ ಹಲೋ ಹಾಂ ಗುಡ್ ಆಫ್ಟರ್ನೂನ್ ಹೇಳಿ ಮೋಹನ್ ಜಿ ಸಮಾಚಾರ ಚೆನ್ನಾಗಿದ್ದೀರಾ ಮೊನ್ನೆ ಮೇಡಮ್ ಫೋನ್ ಮಾಡಿದ್ರು ಶುಕ್ರವಾರ ಮೇಡಮ್ ಫೋನ್ ಮಾಡಿದ್ರು ನಿನ್ನ ಹತ್ರ ಮಾತಾಡಬೇಕು ಅಂದ್ಕೊಂಡೆ ದಯವಿಟ್ಟು
ಆಮೇಲೆ ನೆಕ್ಸ್ಟ್ ಕಾಣಿಸ್ತಾ ಇಲ್ಲ ನಾನೇನೋ ಹೇಳಕ್
ಮ್ಯಾಮ್ ನಾನು
ಅದಕ್ಕೆ ಒಂದೊಂದು ಫೋನ್
ಅಗತ್ಯ ಬೆಳೆಯೋದು ಗೆಟ್ ಒನ್
ಶರತ್ ಒಂದಕ್ಕೆ ಆ ಫಸ್ಟ್
టూ అంటున్నా.
Switch it on. Switch it on.
5-10 minutes when everyone comes. People they should start. No, sir, it will also get heated up. That's why. Huh? తీసుకోండి అదే తీసుకెళ్ళి పెట్టేస్తాంటే కార్లో పెట్టి లేకపోతే దొరకదు. అట్లా పట్టుకొని వెళ్ళిపో. సీరియస్గా చెప్తున్నా. మ్యామ్ చెట్టు మాకు ఇస్తారా? చెట్టు ప్లాంట్ ఫర్ us also one. I'll grow in my home, ma'am. I have
You go to your home and grow. Okay?
Here in my home only I
We
have.
don't want in Atibele.
You want oxygen?
That's why we don't want.
More natural oxygen. On will come.
Okay. Total 8 ribbons. Sure.
Sharat, you have tea, man?
I had.
Agastya.
Will not drink tea. Coffee.
Or coffee, man. Sorry, coffee.
ఏది ఎక్స్ట్రాసియా ఏది జీనియసా? ఏంటో సార్?
ల్యాండ్ ఆఫ్ గోల్డ్. Play just instrumental.
దీనిలో చాలా ఉన్నాయి సార్.
వెనక్కు అక్కడ ఇన్స్ట్రుమెంటల్ అని ఫస్ట్ వన్
డౌన్లోడ్ చేస్తే యాడ్స్ రాకుండా ఉంటాయి. సరిగ్గా సెట్ చేయాలి దాన్ని. చెప్తా. ఇదా?
ಇರ್ತೀರ ನೋಡಿ
ಅక్కడ ರೆಡ್ ಮಾರ್ಕ್
ಯಾಕಂದ್ರೆ ಬಿರು ಕಷ್ಟ
ಇದೆ
ರೆಡ್ ಮಾರ್ಕ್ అక్కడ ఆ ప్రొఫైల్ సెలెక్ట్ చేయి, అక్కడ కమ్యూనిటీ మెడిసిన్ లేకపోతే సైకియాట్రీ యూస్ చేసుకో, శరత్ అనేది యూస్ చేయకు, లేకుంటే గెస్ట్ యూస్ చేసుకో.
లేదు సార్, ఏం శరత్
మీడియాది
నందు లాగిన్
TMCH మీడియాది వాడుతున్నాం.
ఓకే,
దాంట్లోనే స్ట్రీమింగ్ ఇదంతా వస్తుంది.
ఓకే.
లేటర్ ఆన్ ఐ లాగ్ అవుట్ ఫర్ యూ.
అదే ప్రాబ్లం లేదు.
ఇప్పుడు ఇది వాడుతున్నాం, మీడియాదే వాడుతున్నాం. దాంట్లో నుంచే కదా సార్ ఛానల్ అది వేరే విండోలో వచ్చింది. మేము ఈ విండో వాడుతున్నాం, అది వేరే విండోలో.
ఆ విండోని క్లోజ్ చేసి
అది క్లోజ్ చేస్తాం.
ఎట్లా చేంజ్ చేస్తాడు ఆ పిక్ రావడం ఏం చేస్తాడు?
ఏం లేదు, ఇది OBS ఉంది కదా, దీనిలో ఇమేజ్ ఇప్పుడు వీడియో క్లోజ్ చేసాం. వీడియో ఓపెన్ చేసి చేస్తే
कंपनी भी खोल ले, कंपनी खोल के बैकेंड टीम पार्टनरशिप विद ऑक्सफोर्ड इन कोलैबोरेशन विद ऑक्सफोर्ड. ఏంటి ನಾವೆಲ್ಲ ಸೇರ್ಕೊಂಡು ಕಂಪನಿ ಕಟ್ಕೊಂಡು बैकेंड टीम ಮಾಡ್ಕೊಂಡು कंपनी ತರ ಮಾಡಿ बैकेंड टीम खोल लेते हैं. वी विल डू डेफिनेटली. ट्रैक में जाके लैपटॉप लगा के
डेफिनेटली वी कैन डू सर. ಏನಾಯ್ತು?
ಚೆಕ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ, ಅಡ್ಜಸ್ಟ್ ಮಾಡೋಕ್ಕೆ.
ಅಡ್ಜಸ್ಟ್ ಆಗಲ್ಲ ಅದು. ಆ್ಯಕ್ಚುಲಿ ಇದು ರಿಮೋಟ್ ಬೇಕು ಅಡ್ಜಸ್ಟ್ಗೆ, ಝೂಮ್ಗೆ
ರಿಮೋಟ್ ಇಲ್ವಾ?
ರಿಮೋಟ್ ಇದ್ದಿದ್ರೆ ಇದಕ್ಕೆ ಈಗ ಬರ್ತದೆ ಅಲ್ಲ, ಹೆಂಗೆ ಬರ್ತದೆ?
ಫೆಲಿಸಿಟೇಷನ್
ಅನೌನ್ಸ್
ವೈಭವ್ ಸರ್
ಫೆಲಿಸಿಟೇಟ್ ಡಾಕ್ಟರ್ ವೈಭವ್.
ಅದು ಕ್ಲೋಸ್ ಮಾಡಿ.
ಬರ್ತದೆ
ಪಾಸಲ್ಲಿದೆ.
ಡಬಲ್ ಟೈಪ್ ಹಾಕ್ಬಿಡು ಕೌಶಿಕ್, ಇದೆಲ್ಲ ಇತ್ತು ಡಬಲ್ ಟೈಪ್.
మాట చెప్పు, నువ్వు చెప్పు, నేను పెడతా. అయిపోయింది వాళ్ళ పాట, అయిపోయింది కాబట్టి ఇబ్బంది. ఏది ఇదా? అయిపోయింది ఇది. ವೀಣಾ ఏంటి
ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತೀಮಾ?
ವೀಣಾ ఏంటి
ಮೈಕ್ ನಿಂಗೊಂದು ಎಕ್ಸ್ಟ್ರಾ ಆಯ್ತಾ?
ಸ್ಪೀಕರ್ ಇಸ್ ಹಿಯರ್.
ಒಂಥರ ಮೈಕ್ ಇತ್ತಲ್ಲ, ಯು ಹ್ಯಾವ್ ಒನ್ ಮೈಕ್.
అదే వీణా ఏంటి? వీణా ఇన్ విఎన్ అన్న, అది చెప్పు. వీణా ఇన్ వీణా కాదు, అదే కదా వటతాపియా. గణపతి వీణా వీణా
Start, sir?
wait. You start. Feed on mobile.
पॉडकास्ट ब्रो पॉडकास्ट बेटा 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 पॉडकास्ट स्टार्ट ओके
Slide down to change, slide up to back.
Welcome back everyone. Moving ahead, let us all learn a little more about telepsychiatry tomorrow, revolutionizing mental health delivery in the comfort of home with Dr. Kasturi Pandey, Professor and Head, Department of Psychiatry, MVJ Medical College and Research Hospital.
To chair the session, I would like to call upon Dr. Harsha JT, Honorary Secretary, Indian Psychiatric Society, Karnataka Chapter.
I request Dr. Harsha JT sir to introduce the speaker.
Sir,
I don't think Dr. Kasturi Pandey needs a lot of introduction. We all know her as Kasturi ma'am. She is currently heading the Department of Psychiatry, MVJ Medical College and Research Center. She has many national and international papers to her credit. She was 4 times Honorary Secretary of IPS Karnataka Chapter, Chairman Election Committee South Zone, Secretary Member of ANSIPS 2018, Organizing Secretary of WPR in 2020 in Bengaluru. She's also had a lot of awards to her credit. Best Psychiatrist Award by Yadavanahalli, Best Psychiatrist by BMTC, Best Secretary 4 times by IPS Karnataka Chapter, and Best Senior Psychiatrist Award in 2023 by IPS Karnataka Chapter. We welcome you, ma'am.
ಇದು ಕಾರ್ಡ್ ಇನ್ಪುಟ್ ತೆಗೆದುಬಿಟ್ಟು ಹಾಕ್ತಾರೆ ಬರ್ತಿದೆ ಅಲ್ಲಿ ಔಟ್ ಹೋಗ್ಬಿಡುತ್ತೆ ಆಟೋಮೆಟಿಕ್ ಇದು ತೆಗೆದಾಡಿ ತೆಗೆದ್ಬಿಟ್ಟು ಇಲ್ಲ ಅಲ್ಲಿ ಇಲ್ಲ ತೆಗೆದ್ಬಿಟ್ಟು ಇಲ್ಲ ಅಲ್ಲಿ ಸರಿ ಕ್ಲಿಕ್ ಇದನ್ನು ಯೂಸ್ ಬಿ ತೆಗೆದ ಇದನ್ನು ಇವಾಗ ನಿಮಗೆ ರಿಫ್ರೆಶ್ ಮಾಡಿ ಇಲ್ಲದೆ ಆ ಕಾರ್ಡ್ನ ಟೀಮ್ಸಲ್ಲಿ ಟೀಮ್ಸ್ ಅಲ್ವಾ ಟೀಮ್ಸ್ ಓಕೆ ವಿಡಿಯೋ ಸೆಕ್ಷನ್
Good afternoon, everybody. At the outset, I extend my thanks to the Department of Psychiatry as well as to the chairperson, chairman, and to the college who has invited us to this talk. And I also extend my gratitude towards the department because they have asked us to talk on a subject which is evolving. Now you have heard about so many talks regarding the community. You heard about how dementia is taking you, and I think you all have also heard what are the problems a patient has to be brought to the hospital. So you know that there was a trajectory in psychiatry where there were treatment which started with a lot of difficulties, then we came with a lot of policies, plans, then there's a community psychiatry looking into community psychiatry. Then we knew the issues like though community is not the thing, and the psychiatrists are facing in spite of all these plans to get into the crux of the core of this, that the patient. So this, and we heard last time also how a patient relatives have to sell something to bring the patient. Now you know that in a house we have only a nuclear family. That means even we don't have the sons or daughters to look after them, and only the parents are left. And you expect the parents to be brought to a hospital where they don't have a means. And you know that 2,500 PHCs are there where there are no doctors. So in this scenario, we wanted to, how are we going to treat these patients? So the whole crux is to address this issue in the future. How are we going to treat the patients with no avenues, nobody to bring them, and nobody to treat them? There, we are going to revolutionize this mental health delivery in the comfort of your home. So this talk is that how are we going to use our gadgets? Every in and out, everybody, in every nook and corner, we have a computer, or everybody has a cell. So using this cell, using this commodity, how are you going to revolutionize this mental health? So this is going to be a delivery in the comfort of their home. So the use of electronic communication and information technologies is to provide support and a clinical psychiatric care at a distance. So the Drago et al., what he said, telepsychiatry will improve the healthcare, it will interact with the patients and the family, and also it will help in the psychiatric care at a remote place. So what has we learned from COVID-19? So COVID-19 has taught us we don't need to go, we don't need a patient to come to you, but we can reach them. So COVID-19 pandemic has provided us with both the need and an opportunity to use this technology as a means to improvise the access to the mental health care, and also not only now, but the future. There are many challenges on this road of telepsychiatry, but because there is a lack of knowledge, but still we can utilize whatever the available technology in the field of mental health. Now, we spoke about the Mental Health Act. So the Mental Health Act says us in 2017 aims to protect, promote, and also fulfill the rights of a person with mental illness. Are we able to do this? See the scenario now. Psychiatrists are only 0.2%, and India is opposed to a global of 3 to 9 population. The number of psychologists, social workers, and nurses. See the gravity of a situation. We are short of so many. And assuming India would say the same, we need to have 44 to 42 years to fulfill the demand. We need 74 years to say that all the nurses will be filled. 70 more years for the clinical psychologists and psychiatric social workers. See, assuming this magnitude, and when we are talking about mental health for everybody, are we able to reach this with this scenario of shortage of the fraternity? No. So there is a challenge. But can we just sit and be quiet with thinking about this challenge? No, we have to find a means. So here is a means, a critical area where telepsychiatry can bring about a revolution in this capacity, which builds this leverage in a digital technology. So first, we have a mental health app. So they have come out with a lot of apps. These apps, website, they will avail mental health services at the comfort of your home. They have a mobile phone. This application is very specific for any individual. So all these apps, when you can see, they can be used for persons. So this is a role in a psychiatry practice. So what do? This mental health app will personalize the telehealth. Now, smartphones. So you know that everybody has smartphones. So we can use this phone and you can personalize them. Now what do you do with this? They can register. Then what next? From the safe of their house, we can take the clinical details like their duration of the illness, their clinical features, course of the illness, their medication status, if they have any comorbid illnesses, and also you can check their adherence and side effects by this e-prescriptions. So we have found a means that using whatever smartphones, we have certain mental health apps which we can use them. Next is that LAMP. The specific is to there are specialists. See, we need a specialist, but as we say, the specialist can't go to their homes, but you can monitor that. So the specialist is to monitor, manage the patients remotely. So what you do is to learn, to assess, to manage, and also prevent. There's a platform which is being developed by Tortoise et al. It will manage all the patients' related data, and also not only the patients, but the sleep pattern, their physical activities, and even the stresses. Aren't we very close to monitoring all this? Yes. Next, this platform will formulate a relapse also. So not only that, we can monitor from sitting from your place, we can predict whether there is a relapse by formulating a risk algorithm. And this is a very, very personalized care plan. A real-time behavioral data can be also provide the information as to how the symptoms will differ across different dimensions. So these apps are very, very needy, and they are customized, and their hardware is while at the same time offering a real-time data. So this is what we are trying to do with it. Now, the US Food and Drug Administration, they found another one. It is called as a reset. So the reset applications has provided an innovative application for substance use disorders. So you know that there are a lot of substance use, and it has to be formulated, and this is as means of using along with routine outpatient. This management of reset, it is a pure pharmaceutical. They have this tool. It is a part of a comprehensive care plan for a patients with substance use disorder. So there are means by which we can also trace them and also trace this substance use disorder patients. So what are we going to look in the future? So in the future there can be a different applications, not only for an application which can help in diagnosis, which can offer also be the disease specific. So the reset is going to be a challenge, and it can be looked into for a future psychiatrist. Application to monitor this adherence. So not only that, we can also look into the patients whether they have an adherence to this treatment, and whether you can also put the reminders to the patients regarding the medications. So this application is to collect and store individual health records. So these applications, when combined with artificial intelligence, will bring about the possibility of a tailored treatment to the patients. So now we are going very close to every patient. So we are going to tailor the patients, tailor the treatment, and also we are going to tailor their adherence and future, even the reminder. So this is going to be a very, very innovative thing from a psychiatric point of view to a patient's mentally ill, where we are talking about the stigma. So stigma is because of the stigma, the patients are not coming to us. So by this we can address and we can overcome the stigma. Now, what is the future of telemedicine? Yes, there is an answer. Virtual reality. Now, virtual reality and artificial intelligence is changing the future and the course of telepsychiatry and the practice also. So what are we going to do? So AI in psychiatry, there is a use of lot of things we can do. Automated language processing, machine learning, and then multiple domains like diagnosis, their prediction and management of psychiatric illness. There are a lot of monitor through AI, and this pattern of smartphone usage, and it can detect an individual at risk for who is going to develop a mental illness. So now we are moving away from treatment also to the prevention. So by AI, we can also monitor whether the patient is susceptible or is going to come to mental illness. So this is where AI is going to predict to us. Now, AI-based techniques have also become very useful, predicting psychiatric symptoms including psychosis, which presents a manifestation of disorder through. We can make out whether the patient has a thought disorder, disorganization of his behavior, or is going to have a catatonia, and predicted what are the type of treatment we can render to them. So machine learning algorithms have also aided in reducing the false negative, false positive diagnosis. Again, so we have a lot of patients. A patient will be seen by different type of doctors, and different type of diagnosis will be endeavored to them. So there comes artificial intelligence can help us to make a diagnosis universally throughout all the patients, and we can render a same diagnosis throughout all the psychiatrists whomever the patient goes. Now, virtual reality is a computer. Now, what this computer is doing? This is the computer generated simulation. So a patient is given like images and sounds that a patient can interact with wearing a special equipment. So why this is used in these patients? So from the home, one can go and we can give it to them, and they will overcome the evidence that prove that they can make interactions with this virtual reality, and this can be very good use for a PTSD patients, anxiety patients. See, these patients may not like to come to you. So they don't want, and there may not be any patients or anybody to bring them. So these PTSD patients, anxious patients who are not able to come to you because of somebody's not there, or it is due to stigma, or due to the monetary, or to socioeconomic status. So these can be even, and when we were talking about dementia, last speech was that a wife has to sell a sheep and then she has to get some money to bring them. And so all this can be tackled. The future of nobody is there. So we are going to be left with a lot of dementic patients in future. So this is an answer. Can we use this virtual reality to these patients? Yes. Virtual technology can increase not only to this, but vivo therapy, particularly when the vivo exposure. So a lot of exposures, see, we may not be able to do. But with this virtual technology, we can even address this PTSD and specific phobias. See, a patient has a social phobia, is not willing to come to a psychiatrist. So we can treat them this virtual technology. Soon, machine learning can increase the likelihood of patient receiving a personalized treatment. See, many of our patients like to have a personalized treatment. They don't want to tell anybody. So this can be a tool where this virtual reality can bring them a personalized treatment to their home. See, all can even change the psychiatric classifications. So we are looking into, are we going to change every time we are going to look into different classificatory system in psychiatry? Yes, we are going to have a lot of overview application of the psychiatry tool, where even the classificatory system in terms of what is their associations between the symptoms, neurobiological status, and what is the function of process diagnosis, we can come across through the system. So what is this? All AA is a very, very important, all of us have looked forward to artificial intelligence. In future, artificial intelligence is going to be an answer. So a clinician in a diagnosis patient can work, and also you can analyze a host of data of his past history, risk factors, side effects, analyze his treatment guidelines, and also you can come across to a plan of the treatment and analyze the demand of the drugs, and taking into account a stock of the automatically place an order also to the patient from this. So this is a very good innovative thing which we are looking forward to. So is it possible along with medication a doctor may also prescribe usage of a specific application for each disorder? This will serve as different purpose, like even monitor a patient's symptoms, generating up e-prescriptions, psychoeducate him, and altering both even the stakeholder and the patient by comprehensive care which can be delivered with the fingertips. Now, next is we have a chatbots. What are these chatbots? Chatbots are an interesting addition in the field of artificial intelligence. They are conversational. See, now we can converse with the patient sitting in your clinic. So you don't want the patient to come to you, neither you want to go to them. And as we know that there is shortage of our professionals, so by these chatbots you can converse with the patient and play a very important role in screening them, diagnosing them, treating the mental illness. And this is also very, very useful in suicide. See, many patients, when they are in a dilemma, they might say, I am feeling very depressed, I would like to commit suicide. There are a lot of helplines, but how many helplines can offer this? But when you have this chatbots therapy, they can talk to you, and you can even soothe them. See, the suicide is a fractional decision at a moment. So this can be postponed when a psychiatrist talk to them or any therapist talk to them. So this chatbot is going to be a very innovative thing. We can use this for the patients at home. Now, all of us are doing online therapy. So over the past years, many are doing this therapy. So this is an increase after the COVID. These groups will cater to every individual, not only so we can address any drug, any psychiatric like depression, suicidal, and substance abuse, or patients even with malignancy. If you wanted to talk to you, you can talk to them. So this we can use an online therapy, and even the eating disorders. When a patient has a problem who cannot address to them, they need somebody to talk to. So they can talk to us through the online therapy. Now you know social media. So the social media has revolutionized in every aspect. So why not we use it in mental health also? So the mental health recovery to reduce stigma. It is social media has played a very tremendous role in reducing the stigma. And also they can even access to a lot of information and providing the support. Now this online platform can be used even for the occupational functioning. As you know, you see a lot of Instagrams where people put up what are they doing, what they're doing. So you can use this even for their occupation, whatever they wanted to do, what they want to sell. They can use this social platform for the therapies and even to generate money for them. And I will be failing in my duty if I don't talk about telemanas. So telemanas is a mental health care to everyone. It is started in hands. It is in a collaborations with the Ministry of Health and Family Welfare and also with the Government of Karnataka. And this is a very innovative and it is reaching the unreached. So telemanasa everybody should use, and most of you should also address them to the public as well as to the other patients. If they want any treatment or they want a challenge, they can use this telemanas. So telemanas center, where is it? Demands Bangalore and IITB Bangalore have initiated development of it's a very comprehensive portal for prevention of suicide, and it is across titled as the Niman Center for Suicide Prevention. So this is again one more very good initiative. It has been happening. Now what is the aim? The aim is creating an awareness in mental health and stress. So we were talking so much about stress. So every student, if you talk, they said I'm stressed. Everybody who comes to us, they say stress. I don't know, even to read they become stressed, even to talk they become stressed. So stress has become the talk of the town. Okay. So stress is something all of us has to feel. So as psychiatrists, we are becoming stressed by talking to students, they talking to us about stress. Even when we would tell them to read, they become stressed. They giving them any talk to them becomes a stress. So how are we going to deal with this stress? So again, for small talk, even there is a small HOD calls them, they want to attend like. So this is something which is happening not only here, towards what we are realizing and seeing towards the student community and also the working populations. So we have to do something about it. So this prevention of suicide really needs a tremendous help from the psychiatric group. Now we have a care management system. So this is a very innovation solution. So NIMANS has started this. It is a e-Manasa thing, and it is with the collaboration. So e-Manasa has taken this initiative to help in a mental care management system, and it is a very innovative technology system. So we have health records. So can we make any health records? Yes. We can maintain health records of all these patients. Again, it has to be based on the MHCA 2017 Mental Health Act. We have to follow. It is the first initiative in the country completely free of cost. It is funded by the government of Karnataka. This may play a very crucial role during the times of emergencies, and we have to maintain the medical records. So medical records, what do we have in this? We have the patient's physical file. We keep a copy on online prescriptions. We have to comply into all of them who are practicing telepsychiatry. We will have to have medical records in terms of whom you are prescribing, what you are prescribing, but comply with the MHCA 2017. It should be in a prescribed format. and you have to prohibit unauthorized access to this record. Patients' records to be available to the patients only, and as and when they require, this has to be accessible to the patient. Information should be very secure, and anti-theft precautions should be taken. So this medical record, whoever is practicing now, many psychiatrists are practicing this. So you will have to maintain a medical record which is very much to the, you will have to follow, comply with the MHCA 2017. Now we have electronic medical records. So this is a format to which to be followed. All of you should maintain a medical record, which everybody is doing. When the patient, even at home, you can have this record with you. See that you have this record and maintain this record. So these portals are owned and maintained even in a healthcare institutions. So it need not be a private psychiatrist. It could be also, we can maintain from an institution with few psychiatrists, maintain whoever the patient talks to you and maintain this e-records to them. Unless these portals or institution provide patients with a web-based limited access to their clinical data provided in the health record. So you will have to be very, very careful, and this should not be access to the everybody. It is only to the patient and to you. Now, what is that? You will have to have even the appointment, the scheduling of the medicines, even the guidelines as to how to take. All this can be done by the medical records and maintaining from your side. Now, other new things which we are going to come out is the implanted chips. So there is an increase in the concern about storing a data in the cloud. So I said there are a lot of things in the cloud. There has a e-medical records, there is a patient's records, then you're chatting to a patient, you don't know whom you're chatting, and all these things, it can come in a long way into the interpersonal problems, their problems. So all these things can be there. Now we are coming with something called as an implanted chips. So what is this implanted chips? So they are going to implant, there is an increase in the concern. So what they do is, there are reports of implanting, it is already started being used in Sweden. So there is this patients are daily routine is by storing a unique ID. So every patient will be given a unique ID, and emergency contact details is also will be given, and their health records, the financial transaction, and every detail will be provided by this implanted chips. So there might come a day in which every citizen can store his entire clinical data in his implanted chips, which will be a game changer in the healthcare, but not only in healthcare, but even in mental health. So further, there may be a national regulations of implanting this chip. Every citizen, immediately after the birth itself, you will be given a unique ID, and this can be stored, and even this can be as from the birth to health. So in future, we are looking forward for a chip on every person, so that will contain everything about the detail of. So even the mental health can have a revolution regarding this. What are the future opportunities and challenges? So we do have, we have so many. When you have an opportunity, you have a challenge. So currently, women of child sexual victims, so they will be abused and they will have to run from pillars to poster. So whom should they run to? There will be an involvement of a gynecologist, a psychiatrist, a pediatricians, and a local counselor. So we are looking for one roof. So this is called as this one-stop center. So in future we can have a one-stop center. The patient don't need to come to you. The patient can be at home, even if it is a rape case, a sexual abuse. You will have this by a video conferencing. There will be a video conference of all these fraternities, like all of them will be there, and you can access them, and they can even counsel them. And mental health and social support can also be given to them. And not only these patients who have been abused, even alcohol anonymous patients or narcotic anonymous patients, you can have access to them through this one-stop center. Now, there is something called as a wearable devices. So now we are looking for some devices. These are one other than this, which can be rapidly, they can spotlight the use of this wearable devices in telemedicine. What are these devices for? These devices will be used in digitally transmit the patient's detail. Isn't it nice? You wear a watch, all your details are in your watch, not in your fingertips, but it will be in your watch. And the time, whenever there is a time that psychiatrist, you can get this. And not only that, he can also access what is the side effect of the patient's wearing that. See, if a patient is already on some drug, wearing these devices, we can monitor, we can even say what is the side effect of this drug which is taking, what is the drug level through the body fluids and electroencephalograph or electric cardiac changes. All this can be accessed through the automated reminders to the patients also to take medicine. So this is going to be a wonderful device to all the patients. Now we are going to have not only this, we are going to have an e-physical examination. What is this e-physical examination? Is going to the limitation of seeing a patient. See, a patient is, all of you think that psychiatry is only talking. No, it is later after physical test and physically all the illnesses being ruled out, we think of psychiatric problems. So you need to have a very good physical examination. So we are going to come out with e-physical examination. Owing to the limitation of this examination during teleconsultations, so we may not be, will be talking. So during your teleconsultations, psychiatrists may not be able to do a physical exam. So now they are thinking of coming out with an e-physical exam. So the Telemedicine Center of NIMHANS has proposed a novel concept of virtual video-based physical exam. It is a part of a systemic physical exam and which can be done from sitting at home, or a consultation can do a physical exam. So this, what are we doing? You buy physical exam of, this is called as a e-physical exam, and you will inspect whether the patient has ictus, cyanosis, skin lesions, and also everything about the patient has a side effect of a drug, or he has a difficulty in gait, difficulty in swallowing. So the side effects of the drug can also be done through this, and not only that, we can also administer them the scales. So what are the relevant scales we would like to do, we can do through this examination. So this concept needs further evaluation and expansion and validations. So there, all this can be used with the wearable devices, and all this can be done and decrease. What is the thing we are looking for? We are looking for the decrease in the cost of the patient who can be at home and we can monitor from sitting in your clinics. Now, what is the future? So futuristic use of this telepsychiatry is to minimize the infrastructure to practice telepsychiatry, decreasing the need of the patient to travel to you. The consultation charges can come down significantly and also decrease the out-of-pocket expenditure to the patient. The cost effectiveness, ability to get an expert consultation sitting from their home with a minimal effect cost, and which will eventually improve the quality of life of the patient. Now we were talking about mental illness, but even mental health can be addressed by the consultant when the patient is sitting at home. So telepsychiatry is going to be a revolutionary thing which is going to happen, and this is going to be a result of the future. So this futuristic uses will be with all the recent advances. Technology, we will transfer psychiatry. So how psychiatry will be practiced is going to depend on this and future. It may even result in the development of bedless hospitals. Now we are talking about so many hospitals coming. We want a clinic, we want a hospital. Yes, we don't want the beds. So we are going to talk in terms of bedless hospitals because of the telepsychiatry. However, as with all the revolutions ahead, we must have some problems. See, always when there is something good, there is something bad. So what is the bad thing we are going to reach? So we are going, challenges will be, the main challenges that can arise. In a country like India, there is a digital divide. Existing in the country across the world with certain rural areas, we cannot reach them. There is no proper internet connectivity. Say so, not only rural, even us, we don't have a good internet connectivity. So this is going to be a major challenge, and compound this, using all this application and devices will become some skill and knowledge. How many of your technical savvy? Most of doctors, most of us may not be. So there is a challenge to us. How should we become? Are we to become very skillful and knowledgeable in the field of all these gadgets? All these advances will also pose a challenge from people who are less educated with the background which is not very good to them, and which might hinder them from using. So many patients in a rural setup, they won't know how to use it, and you ask them to do this, it's going to be a fault. So overall, despite this shortcoming, the benefit of psychiatry should be utilized to the fullest as it is. It has got a very immense potential to reduce the health and care burden as well as the efficiency of managing the psychiatrist for the patient from their home. Thank you.
Thank you, ma'am, for a very informative presentation. You made us understand how we have moved in from doctor not available to doctor easily available. So how we use this cutting edge technology to ease the diagnosis, management, and follow-ups as well. We will open the session for discussion. We can have a few questions.
It was really very comprehensive talk on the telepsychiatry. But my concern had been the breach in the confidentiality. You mentioned about the digital divide, but how much will be just the data, whatever we have stored in the cloud or anything? If it is accessible to many other people, then how we are going to avoid that? Or if it is available to other people, then how it can be used in a different way? That's all.
See, that is why we are going to come out with these specific IDs and specific devices only reachable to the patient. See, as you say that now, even when we are practicing, we don't taking consent also. So many times the breach of consent is there, breach of confidentiality is also there. And now when we are talking, actually, it's a big challenge which we are facing. So now HIMS has come and we have accessing, and now we are trying to look into, I think, the whole of what you can say, the department of MCHA to access, it is how are we going to maintain this confidentiality and also not to breach their personal things. So they are going to work on it. So that is why they are trying to come out with devices personalized to the patient so that they may not be accessible to anybody. And another thing is that Sweden has come out with the chips. So chips, it could be a solution to this. So we are looking forward to these comprehensive personalized devices which cannot be accessed to anybody because you have a special ID. Like we have an Aadhaar card. So Aadhaar card is also accessible. So any devices when you have a pros and cons. So we say Aadhaar card is very personal, but there are means to people can also access them. So like this, there are breaches in this map. So breaches in all these, it's in a cloud. And so one thing is that how are we going to preserve this for a psychiatric patient with a psychosis? Because in the patient, if he doesn't have a insight, the way we depend on the caregivers. See, we are talking mostly towards of the patient. But can everything be taken or told to the patient? No. There are instances which has to be referred to the caregiver. Understood? So that again, we have to address many things to the caregiver also. So this breach of confidentiality, even the concern for the treatment, it is going to be an immense challenge, and they are looking forward as to how we can overcome this, to be personalizing this one. And that ID cannot be accessed by anybody.
Just to add on, ma'am, if we look into the Delhi Psychiatry Practice Guidelines, it says that it is our responsibility to see that there is no breach of confidentiality. And they also say not necessary that you have to digitally store all this data. You can use the good old way of writing prescriptions and keeping it confidential. So that is, till we are very sure about how we can digitally safeguard all these things, the traditional record keeping would be a better thing.
And coming to your answer, even record keeping, see, we do maintain the record. Do you think our record is not accessible? See, when you ask your PG to take a record, you take this information, we collect information from many students, then later it come to a consultant. So many stories will be there. And this can be, the confidentiality is not to one person. What do we talk about confidentiality? It is only one. Are we maintaining the confidentiality even now? No. So this is a challenge. This is going to be, so when we are in this field, this issue of confidentiality is going to be a challenge. Then how are we going to treat this patient? So who is going to treat the patient? Is the patient is going to treat himself? No. There should be an access, and the caregiver are the one who are going to treat the patients. So we'll have to look into this confidentiality issues. I think it's a very, very vague symptoms in terms of treating our patients. We might see consent is yes, but confidentiality, we talk about confidentiality, but I doubt whether we maintain it, because there is some amount of leakage somewhere, ma'am.
Any other questions?
My name is Sainath of second year, and ma'am, other than the confidentiality security concerns, one of the most basic concern of the person would be suspicion. The non-believers, since it's first of all a very sensitive topic, for example, the one-stop solution which you told, where you mentioned the rape victim would approach it for all of her problems. Do you think the person would first of all be open to it, and also how well do you think the treatment would be, because there's no human interaction involved a lot, so there's no physical interaction involved. Do you think that would really apply a lot? And as I see that psychiatry is trying to replace the current system, do you think it will be effective?
See, the effectivity is not we are talking here. See, even when we are talking about a rape victim, when they come to you, what you are going to talk? So the rape victim come to a psychiatrist not for a treatment here. After that, first it will go to, if you're the lady, she'll go to a gynecologist, then it will go to, first it will be in emergency, then gynecologist, then she will come to, if she's a child, to go to pediatricians, then she'll come to, after the examination, then the child will be referred to psychiatrist for consultation for counseling. And if there is post effect of that, again she'll be coming for the post effect, right? So when we are doing telepsychiatry, these things, when we are giving from our side, it is only a counseling, or if she goes in for depression. So in this context, when we are doing it on telepsychiatry or others, so why not to this patient? And your other thing is this, you had a waste of things like that, suspiciousness. Suspiciousness is a disease, and it is, why should they be suspicious? They are seeking for help. So nobody comes to a doctor with suspicious, that's what she's going to do. So she goes to a doctor, see, they want a help. See, the mother doesn't want to bring the child because she's been raped. So many times they don't tell you that child has been raped. So this could be a place where they can call confidentially. Madam was talking, so they can talk one-to-one. This has happened, they will note it. So it will be a teleconference, televideo between the obstetricians, the psychiatrist and the pediatricians, and also the emergency doctor, where they can take a call. Video conference, you can see the face. So there is nothing like, they are suspicious about it. So you see them, and we can also, they will tell their problems, okay. So in case, if they want, then we'll ask them to come to them. So see, there are so many things that can happen, and this can be recorded. See, this video conferences are...
ನೀವು ಸ್ಕ್ರಾಲ್ ಏನೋ ರೆಡಿ ಮಾಡಿದ್ರಲ್ಲ, ಅದನ್ನು ರನ್ ಮಾಡಿ ಹೋಗಲಿ.
ಬರ್ತಾ ಇದೆ.
ಸಿಸ್ಟಮ್ ಎಲ್ಲ ಇಲ್ಲೇ ಇರಲಿ, ಎಲ್ಲ ಪರವಾಗಿಲ್ಲ, ಏನು ಯಾರು
ಯಾರು ಬರೋದು. You will off it for time being. No lunch. You got the internet back.
Internet for
Internet you're sharing or what? No, you're not sharing.
Third years will take attendance now. We'll be taking attendance again after lunch, like 2:30. So please come back. 92, 94, 81. Just shout like that. 127, 99, 133, 123, 128, 121, 105, 105, 95, 139, 95, 139, 130, 104, 84, 108, 159, 71, 88, 62, 61, 125, 40, 157, 131, 79, 90, 13, 12, 10, 52, 145, 52, 145, 32, 65, 72, 83, 152, 158, 161, 34, 34, 35, 33, 54, 33, 53, 77, 64, 117, 90, 90, 126, 151, 135, 28, 31, 73, 73,
Ask them to put the room
102,
once again spray everything.
138, 138, 46, 20, 142, 91, 22, 70, 66, 55, 137, 124, 96, 96, 141, 96, 141, 140, 110, 110, 146, 150, 118, 118, 160, 149, 149, 144, 97, 38, 48, 48, 147, 68, 155, 43, 36, 29, 30, 26, 26, 39, 29, 136, 30, 82, 23, 98, 129, 129, 60, 56, 114, 21, 107, 41, 57, 36, 113, 44, 87, 87, 148, 111, 101, 69, 25,
staying here or are you going?
Actually, you were also there. One person little bit. ಯಾರಾದ್ರೂ ಊಟ ಮಾಡಿರೋರ್ನ ಈ ಕಡೆ ಕಳಿಸು.
Sir, आप नहीं जा रहे हो खाने?
He's there.
वैभव sir.
But please, not for you. Not for student. Student is good. Sir, just to take care of all this. We
ಟಿಫಿನ್ ಬಾಕ್ಸ್ ಇಲ್ಲ ಇಲ್ಲಿ ಕೂಪನ್ ಬ್ಯಾಗ್ಸ್ ಫೈಲಲ್ಲಿ ಕೂಪನ್ ಬ್ಯಾಗ್ಸ್ ಅಂತ ಹೇಳ್ತೀವಿ ವೀಕ್ಲಿ ಫಾರ್ಮಟ್ ಅಟ್ಟ ಬಾಕ್ಸ್ ಇಲ್ಲ ಈಗ ಯಾರು ಕಳಿಸಿದ್ದು ಅಪ್ಪ ಬಂದ್ರಲ್ಲ ಸಿಕ್ಕಿದ ಅಪ್ಪ ನಾವೇ ತಗೊಂಡು ಬರ್ತಾ ಇದ್ದೆ ಸರ್ ಮತ್ತೆ ಅಪ್ಪನೇ ಅಪ್ಪ ಹಾಕೊಂಡಿದ್ದು ಲಿಫ್ಟಿಗೆ ಕೊಟ್ಟಿದ್ದಾರೆ ಪ್ಲೇಟ್ ಅವ್ರು ವಾಪಸ್ ನಾನು ಹೇಳಿದ್ದಿಲ್ಲ ಅವಳಿಗೆ ಅರ್ಧಕ್ಕನೇ ಮಲ್ಕೊಂಡ್ಬಿಟ್ಟಿದ್ದಾರೆ ಮನೆಗೆ ಹೋಗಿ ಬಂದ್ರೆ ಆಕ್ಚುಲಿ ಹೋಗಿದ್ದು ಬೇರೆ ಪರ್ಪಸ್ ಏನು ಮಾಡಿಲ್ಲ ನೀವು ತಗೊಂಡ್ರಂತೆ ಅವಳು ತಗೊಂಡ್ರಂತಲ್ಲ ಅವ್ರು ಬಂದ್ರು ನಾನು ಫಸ್ಟ್ ಟೈಮ್ ಊಟಕ್ಕ ಅಂದ್ರೆ ಟೋಕನ್
ಅಷ್ಟೊತ್ತಿಗೆ ಕೊಡ್ಬೋದು
ಮತ್ತೆ ಅವ್ರು ಫಸ್ಟ್ ಬಂದ್ರು ಸರ್ ಸ್ಟಾಫ್ ಯಾರು ಬಂದಿದೆ
ಕೆಲಸ ಮಾಡ್ತಾರೆ ಅಷ್ಟೇ ನೀವು ಊಟ ಮಾಡಲಿಕ್ಕೆ 2 ಗಂಟೆ
ನಾನು ಹೋಗಿಲ್ಲ
ನಿಮ್ದು
ಪ್ಲೇಟ್ ಮಾಡ್ಬೇಕು ಸರ್ ಕೆಳಗಡೆ ಇಟ್ಟಿರಿ ಮ್ಯಾಮ್ ಆಮೇಲೆ
ಹೊರಗಡೆನೇ ಇಡ್ಬೇಕು ಅಷ್ಟೇ ಒಳಗೆ ಸ್ಮೆಲ್ ಬರೋದ್ರಿಂದ
ಎಲ್ಲ ನಾನು ನಿಂದ ಆದ್ಮೇಲೆ ಇದು ತೊಳಿಲಿಕ್ಕೆ ಮನೆಯೊಳಗೆ ನಾನು ಚಾಡ್ದಲ್ಲಿ
ಅಲ್ಲಿಲ್ಲೂ ಅಂತ ಕುಡಿಯೋದು
ಬಾತ್ರೂಮಿಗೆ ಹೋಗ್ಬೇಕು
ಬಾತ್ರೂಮ್ ಇಲ್ಲೇ ಚೇರ್ ತಗೊಂಬಂದಿದೆ ನೋಡಿ ಈ ಚೇರ್ ತಗೊಳ್ಳಿ ಹಾಂ ಅದೇ ತಗೊಳ್ಳಿ ಕೂತ್ಕೊಳ್ಳಿ
ಟಿಶ್ಯೂ ಪೇಪರ್ಸ್ ಅಲ್ಲಿ
ಟಿಶ್ಯೂ ಪೇಪರ್ಸ್ ಯಾರೋ ತಗೊಂಡು ಹೋದ್ರಿ ಸರ್ ಅಲ್ಲಿ.
ಎಲ್ಲ ಇಟ್ಕೊಂಡು ಹೋಗ್ತಾ
ಆಯ್ತಾನೆ ಯಾವುದು
ಹೌದು ಸರ್ ಚೆಕ್ ಇದು ಈಗ single company. Volunteers
ಯಾವುದು ಸರ್ ಇದು ಯೂಸ್ ಮಾಡ್ತಾ ಇದ್ದೀರಾ ಇಲ್ಲಿಂದ ತೊಗೊಂಡು ಹೋಗ್ಲಿಕ್ಕೆ ಆಗೋದಿಲ್ಲ
ಅಲ್ಲಿಂದ ನಡ್ಕೊಂಡು ಹೋದ್ರೆ ಅವಾಗಲೇ ಆದರೆ ಅದು
ಬೇಡವಾ ನಿಮಗೆ?
ಯಾವುದು? ಅದು ಅಲ್ಲಿಂದ ಬೇಕು, ಆ ಕಡೆಯಿಂದ ಬೇಕು. ಇಲ್ಲ ಚೇರಲ್ಲೇ ಕರ್ಕೊಂಡು ಹೋಗ್ಬಿಡಿ ಅಪ್ಪ ಇವಾಗ. ಸ್ಯಾರಿ ಜೊತೆ ಮ್ಯಾನೇಜ್ ಮಾಡೋದು ಕಷ್ಟ.
ಎಲ್ಲಿದೆ? ಎಲ್ಲಿ ಇಟ್ಟಿದೆ ಅದು?
ಅಲ್ಲೇ ಹೊರಗಿಟ್ರ ಅಂತಂದ್ರೆ
ಚೇರ್ ಅಲ್ಲಿಂದ ತೊಗೊಂಡೋಗ್ಬೇಕಾಗ್ತದೆ. ಅಲ್ಲಿ ಒಲೆ ಮೇಲೆ ಇದೆ ಬೇಡ.
ಇಲ್ಲಿಂದನೇ ತಗೊಂಡು
ಇಲ್ಲಿಂದ ತೊಗೊಂಡೋಗ್ತೀವಿ.
ಹಿಂಗೆ ಹೋಗುತ್ತಾ?
ಸರ್ ಇದು ಇಟ್ಟಿದಾರಪ್ಪ, ಅದು ನಂದಿದ್ದು ವಾಕರ್ ಎಲ್ಲಿ ಇಟ್ಟಿದ್ದಾರೆ ಇಲ್ಲಿ? ಅಯ್ಯೋ ಹೊರಗೆ ಇಟ್ಬಿಟ್ಟಿದಾರ. ಜಸ್ಟ್ ಸಿ ನೋ ವೆದರ್ ವಾಕರ್ ಇಸ್ ದೇರ್ ಔಟ್ಸೈಡ್. ಐ ಟೋಲ್ಡ್ ದೆಮ್ ಟು ಗೆಟ್ ವೈಭವ್ ಹುಷಾರ್.
ಏನಾಯ್ತು?
ಊಟ ಮಾಡಿಲ್ಲ ಸರ್, ಇಲ್ಲೇ ತಗೊಂಬಂದಿದ್ದ. ಇಟ್ಸ್ ದೇರ್, ಕ್ಯಾನ್ ಯು ಗೆಟ್ ಇಟ್? ತಗೊಂಬಂದಿದ್ದ
ಇದು ಆಯ್ತಾ?
ಇವಾಗ ಹೋಗ್ಬೋದು. ಅಲ್ಲಿಂದ ನನಗೆ ಇಲ್ಲ, ಅಲ್ಲಿಂದ ನಾನು ಮತ್ತೆ ಹೋಗ್ಬೇಕಲ್ಲ. ಕರ್ಕೊಂಡು ಹೋಗ್ತೀನಿ. ಹಾಂ, ಕೈ ಬೇಕು ಸಪೋರ್ಟ್. ಇಬ್ಬರು ಕರ್ಕೊಂಡು ಹೋಗ್ತೀನಿ.
ಕೆಳಗೆ ಹೆಜ್ಜೆ ನೋಡ್ಕೊ.
ಅಯ್ಯೋ
ಇಲ್ಲ ಇಲ್ಲ, ಈ ಕಡೆ ಬರ್ತೀನಿ ನಾನು. ಈ ಕಡೆ
ಕರ್ನಾಟಕ ಎಲ್ಲ ಇದು ಉಂಟು.
ಸ್ವಲ್ಪ ತೆಗಿಬೇಕಾಗಿದೆ.
ನಮ್ಮದೇ ಹೋಗ್ಲಾ?
ಹಾಂ ಹೌದು.
ಬೇಕಾ?
ಇಲ್ಲಿ ಕೊಡ್ತು.
Projectors. Projectors. Sir? Introduce. Later you can do come.
Yes, sir.
All the speakers. Mics.
Should I call now? Yeah, call now.
ఒక్క నిమిషం
Very CV. Very CV.
Varun.
Calling name important. Where is it? Has he left here? Has he left the CVs here? Ask him.
ನಾನು ಕರ್ನಾಟಕ ಎಲ್ಲಿತ್ತು? ಥ್ಯಾಂಕ್ ಯು.
ఇటు క్లోజ్ చేసేసి అటు జరుపురా దీన్ని.
Good afternoon all. Welcome you all. Advancing onward, let us move on to our next topic, mental health legislation, exploring the implications of the Mental Health Care Act 2017 by Dr. Mahesh Gowda, Consultant Psychiatrist, Director, Spandana Healthcare.
To chair the session, I would like to call upon Dr. Veda N. Shetagiri, Professor, East Point College of Medical Sciences and Research Center, and Dr. Kiran GT, Professor and Head, Department of Forensic Medicine, the Oxford Medical College, Hospital and Research Center.
I request Dr. Kiran GT to introduce the speaker.
అక్కడ ఎవరో ఒకళ్ళు నడిపిస్తారు, నందకిషోర్ సార్ వాళ్ళు ఉంటారు. నేను ఇప్పుడే వచ్చేసా, అక్కడ ఇప్పుడు దాకా ఉన్నా. సరే అక్కడే ఉన్నావు, ఆగు కనుక్కుంటా, పంపిస్తా. కింద ఉన్నావా పైన ఉన్నావా? పైకి వెళ్ళు, లావణ్య అని ఉంటుంది, నేను చెప్తాను.
Thank you all, welcome all delegates. Thank you Dr. Sapna and Dr. Lalita Madam for giving this opportunity. And I would welcome the speaker Dr. Mahesh Gowda of Spandana Healthcare, MBBS from Bengaluru Medical College 1999, DPM from Imhans 2002, set up rehabilitation center in 2001, DLN Murthy Rao Award for the best outgoing student, consultant psychiatrist at Spandana, direct Spandana Healthcare, direct council member IPS, past president IPS KC, past treasurer IPS KC, honorable editor, 70 publication. Sir, you look too young. Welcome, sir. With so many awards and achievements. Welcome, sir. Hope you enlighten us with your this.
నేను ఇక్కడ సీఎం వచ్చేసాను, అందుకని అవును మ్యామ్ అక్కడికి వచ్చేసిందంట.
I thank the organizers for this opportunity to call me for this discussion on MNCA. It's been a topic of interest for me.
more so simply because I was in trouble. Most admission I used to get into conflict with law, issues with consent, issues with police, issues with family who didn't want the patients to be treated. So that was bare necessity that I had to read and understand the act, and that's how my interest in this topic started. I was in dilemma about how I should pace this presentation because there are a lot of students who are new to this mental health legislation. The people in the first row are all my colleagues who are actually practicing this act for the last 7 years, and most of them are fluent and understand the nitty-gritties of practicing this act. So I'm trying to keep it basic to make sure the students here would actually get to understand the trouble with legislation that we deal with when we are treating people with mental illness. So if you look at world over, most of the legislation earlier was treatment based, like you would give treatment based on the illness and most of the patient would consent. But if you look at the specialty of psychiatry, here we are dealing with people who will not be having capacity to consent at times in particular scenarios. We need to take consent of somebody else, their family member, near relative. And during treatment and delivery, they believe that a lot of rights will be violated. So this act was specifically designed to protect the rights of people with mental illness during treatment, delivery and care outside. So what happens here is once this decision has come, for the first time it becomes a rights-oriented legislation because the patient becomes the center of the whole legislation where he's going to decide what's in his best interest and he's going to communicate his decisions. In case he cannot communicate his decision, his nearest relative or the family member who is authorized or who is nominated as representative is going to give us consent, and this is a special scenario for psychiatry. Rest of the specialties take consent from the patient and they don't have a problem. So here in psychiatry, we have to have a special legislation because of this sort of needs. The moment the patient has capacity to decide what's good for them, his consent only matters. Rest of the time, you can say the patient is incapacitated and take the appropriate consents. Coming to admission that happens in psychiatry is broad-based. So these are voluntary admissions, and we say this section 86 where the patient is in the best of his capacity to decide what's good for him, and he decides when he gets into the system and he gets out of the system, and he decides what's the mode of treatment. It could be injectable, it could be oral medication, it could be ECT, it could be psychotherapy. He decides what is needed, and you can discuss with him, and once he consents, you can administer all the sort of treatment requirements. The next important section here would be section 87 where you're treating minors less than 18 years of age. Section 86 deals with people who need supports to make decisions. So these are the incapacitated patients or the involuntary patient because they by nature of the illness have lost capacity and they're not able to make decisions, and the nearest family member is going to make decisions in their favor. So section 89 deals with people who become incapacitated, and you can treat them under the section for up to 30 days. And beyond 30 days, if you need to take the pain pill for treatment, it has to be continued in section 90, which can go up to 90 days. And with subsequent approval, you can extend the admissions also. All admissions that you're doing and treating people without capacity and people people who are minors also are assumed they are incapacitated because of the nature of their age, and they feel that people above 18 years of age can give consent. So all minors and all incapacitated patients need to be informed to the mental health review board, and they have timelines here. Anybody who's a minor and a lady, the timeline given is 72 hours, 3 days to report the admission that happens in your mental health establishment. If it's a male, adult male, up to 7 days is what you have the duration. So when you treat a person with less than 18 years of age, it's just not admission and usual procedure like any other specialty. They have to give an application to us saying that this is a person, these are the details, this is the ID proof of this patient, and this is the symptoms that he has, and why is that they are actually asking for admission is what they can specify. And this sort of request has to come from the nearest relative, nominated representative, caregiver, guardian, or whoever is authorized by the law. So once they give the application like this, the psychiatrist who's going to be treating this people in the mental health establishment will have to certify that admission is the only way forward to manage this person who's less than 18 years of age, and is the least restrictive form of treatment to make sure that people with this sort of illness are able to reach the recovery stage. So it's very important that it's just not an application. There has to be an associate certification to say that this is illness, and this is the mandate required because of the illness and the nature of the symptoms that they have, to make sure they treat this patient effectively with the least restrictive option possible. Coming to section 89, so here what we need to understand here is just not psychiatrists who have to know about the provisions of this act. Non-psychiatrists and other fellow professionals in police also need to understand, because there will be a lot of interface of people with illness, the person with mental illness, who will have other medical comorbidities, surgical comorbidities. They may present to their departments for treatment. So if at all the primary indications for treatment is something else other than psychiatry, you can go ahead and treat. Suppose he has psychiatric illness, there is a specific provision, section 116, which says that only people authorized by the act are allowed to treat people with illness. So for example, it's a neurology specialist or a physician, or it could be an obstetrician who's dealing with people, and if he has mental illness, this person has to be admitted only in a mental health establishment and not in either hospital. And person authorized by law are only people who are authorized to treat incapacitated patients. It could be a person with delirium, it could be a person with fracture trauma and eventually getting delirium. So you can have multiple medical comorbidities. So we need to understand that in incapacitated patient, there are certain thresholds that we need to remember, and we are
Current view is 37.
So,
57.
having capacity is not the only criteria to treat people with
and that's the average duration of each person is 3
They also have specified certain dangerousness criteria here. So there are three important criteria that you need to remember here. One is he should be at risk to harm himself, he should be at risk to harm others,
Actually,
and
we
also he should be showing
put this link in that.
neglect
So
or
all those
inability to
people
take
who
care of
have
himself
joined
to a
this
degree that
YouTube,
poses him at a risk of
so
harming himself. or
you'll get the
others.
views and this thing.
Those
So these are the
viewers
three
and all the
important
payment
criteria
part.
that you must remember.
So
he
they
makes an
required us some
application
If we
to say
give
that
them the
this is
link
the,
also, they would have
this is a
used
person with
both
this sort of background who
this
needs
one
illness
and
because of these sort
they
of
would have
symptoms.
shared that also.
Next there has to be certification. For section 89 there has to be two
Correct, they
certificates.
want some
by two
attendance,
mental health
everything,
professionals. One
overall
could be a medical
joined,
officer, one has to
those
be a
things, everything
psychiatrist,
they
or it has to
required.
be two mental health professionals, that is two psychiatrists,
Remove it.
or one mental health professional, psychologist,
Remove this,
or
remove
a
this.
social worker, and one has to be a psychiatrist. So section 89 gives you the power to treat people in a hospital for 30 days without their consent, based on these sort of provisions that we have. So suppose you can treat this patient effectively, then he's better, he becomes capacitous. So once he becomes capacitous, he has to be moved to section 86 because he's an independent person who decides what is good and bad for him. So once he becomes capacitous, he can decide when he can get discharged and get out of the system, and he can decide the date of discharge. He does not even need the consent or the person admitting him to get discharged. Suppose he does not regain capacity, suppose he is not well enough, and you want to continue treatment, so you have an extension arm that allows you to treat them against their wish up to 90 days. So this is section 90 here. And if you were to remember the timelines again here, once the person goes to section 90, you have to inform the board, take their permission to approve. In 89, what happens is you just have to inform the board that he is admitted with mental illness and these are the symptoms, and it is deemed approval. You don't have to wait for the approval process, because you just have to get an application and send it to the mental health review board. Whereas in section 90, you need a formal approval by the board. So he's going to look at the criteria for admission. Why do you need to extend his admission? Why do you need to curtail his liberty? Why is that you want to prolong his admission? Is it really warranted? Can't he be treated in the community? Is this the least treatment restrictive option available? Based on that, he may approve, he may reject it. He may also come and inspect and see this patient before approval. So again, when you are admitting people with high support needs, this is a particular form here. Again, you need two certifications. And once you are admitting under section 90, the timeline starts. 7 days is the timeline that you will have to inform the board. And when somebody is admitted, we have to periodically do capacity assessment. So at the time of consenting process, at the time of admission, every week during section 89, and during section 90, every 15 days is what is specified. The moment the patient has gained capacity, it is very simple that he has to be moved to section 86 and he decides what has to be done with them. So these are application forms. So there are various forms of admission that happens in person with psychiatric illness. So section 86 we talk about independent admission. He decides everything for himself. He does not need any sort of support. He does not need a family member to consent. Nobody needs to stay with him. He can come and get himself admitted, get himself discharged. There's no time limit for the duration of stay here. This is the admission that most of the people are comfortable doing with, because consenting is no big deal. He signs up for everything for himself. We don't have to deal with the board at all, simply because he's authorizing his own treatment and consent. And generally, you are in less conflict with law, and most practitioners are comfortable to treat people with Section 86 because it's a very comfortable phase of treatment, recovery. Most of the time, you are having good results. Patient is happy, family members are happy, everybody is happy here, and most of us resort to treating people with Section 86. Of course, next one would be the people who are vulnerable. So the minor population here. Here the nominated representative of the family member authorized admission, and here it's very clear that you need 2 psychiatrists or 2 mental professionals or 1 medical officer here to authorize this sort of admissions here. In Section 86, any medical officer or any mental health professional, it could be a psychologist or a social worker who can authorize admission. This is the deviation compared to what we had earlier. All admissions were considered medical, and only medical officers or psychiatrists were allowed to make admissions. But here, for a medical institution, even a mental health professional is allowed to make admissions without a discussion with the medical officer. And in minor admission, there is no time specified. You can take as long as time that is needed to establish that the patient is recovered enough and he can be sent home. I'm not sure how many of us are comfortable to admit minors, because again here is a vulnerable population. A lot of restrictions are there. You need to have a special ward. What the law has also done is here you need special ward for a child, you need special ward for a woman who's pregnant, you need a special ward for people who are elderly and geriatric population. So people with special needs are categorized separately and make sure that they have special wards because of the special requirements. Suppose you don't have special wards, how do we tide over the crisis? Because in a medical college, like typical example, getting 20-25 beds under psychiatry itself is a challenge. How do you get special wards? I'm not sure how my colleagues here are managing. Do you have special wards for this indication? So suppose we don't have a single room or a private room, can be considered as a separate accommodation for people with this sort of indication. So that would be considered okay by the law, because you just need to ensure that they have kept separate and not mixed with the general psychiatric illness population. So I think that's the only way forward, because most of us don't have this sort of designated wards. NIMHANS, Institute of National Importance, Institute of Mental Health across the country in various cities all have larger wards. They have larger population that deal with a lot of faculty, a lot of beds are there, so they are able to segregate these sort of wards, and I don't think it's possible in a general hospitals or in a medical college settings. And when we need to extend, Section 90 makes us sure that we're getting approvals from the board, and we have to document and make sure we get this. If at all we don't get, I think it's good to chase this sort of admission, get approval, simply because we are going to be at loggerheads, because this mandates the requirement of inspection, approval, and mandate of actually written approvals from them. So other than parents and family members asking for admissions, we have a special situation here simply because police can ask for admission. So if at all a police person finds somebody with mental illness roaming around his police station limits, it is his responsibility to identify such people. If he can diagnose and feel that he is a person with mental illness with some sort of understanding that he has, and if he knows that he is a person with mental illness, he can go and take this person to the nearest public mental health establishment and admit them. He cannot take it to a private medical establishment. That's the conflict generally we have, because family members want him to be picked up and put him in a private medical establishment as per their choice. But here, the police have responsibility only to take them to a public mental health establishment, is what we must remember. So many times we send requests to the police asking for assistance. So they say that I have the responsibility only to take them to public mental health establishment. I will not get them to your hospital. They're denied. But as a policy, we send requests to them. They acknowledge and say that we are aware of this sort of admission procedure that is going to happen, because we try to intervene and do house visits, go mobilize this patient from home. So when we are mobilizing patients from home, generally we are going to violate rights, because he is not willing to come. He has made it obvious he does not want evaluation, he does not want treatment, does not want admission also, but we have to mobilize them. So we are going to get into his house. In the process of mobilizing him, it could be counseling, discussion, convincing, coaxing him, sometimes sedations to get him into the hospital. So when you're trying to sedate, it also involves physical force here. There has to be physical restraint here, and then only you're going to sedate. So we're going to have a lot of violations. So best thing is what we do is we send a prior intimation to police, and we say that under Section 94 we are making this sort of house visits, and this is what the Section 94 authorizes me to do it, and this is the responsibility of a police officer to help me in mobilizing this patient. But he says that he will not accompany me because of whatever reasons. So it's good to inform them. So police have a lot of responsibility. If it's a person with wandering mental illness, he takes and admits in a public mental health establishment. Suppose he's not sure whether he has a person with mental illness, he's just wandering around, he has no past records, somebody in the public complains and we don't know whether he's really a person with mental illness, so what does the police do here? He cannot really assume because he has no diagnostic skills, he has no understanding. You cannot just pick up a normal person and go put him in a public mental establishment. This happened in one of the public mental health establishment. A foreign visitor, tourist was picked up from the streets and put in a public mental health establishment under the magistrate order and kept there for 6 months without a person having a diagnosis of mental illness is what they contested finally, and the court had to look into all this thing and take cognizance. Any stranger can be picked up. So to make sure this does not happen and protection is there, if a police officer does not have skills to diagnose, he has to produce this person before a magistrate and ask for a period of observation. So magistrate is authorized to put them into public mental establishment for 10 days to make sure his evaluation and assessment and diagnosis is complete, and if at all the treating doctor feels that there is a need for treatment, he has to put him in section 86 as a voluntary patient or as an involuntary patient in section 89. Of course, we have prisoners with mental illness, so they take them to the nearest public mental establishment or other centers here. So they have the respective Prisoners Act, Air Force Act, Arms Act, Navy Act, all those things, the respective heads can authorize admissions and the transfer is possible. And here also there is no limit for the duration of admission and treatment here. I was talking about section 94, very useful here because earlier act and earlier laws that was there never allowed and legalized a doctor visiting home, because there is no law to allow me to go and visit a person who is not willing to come. It is definitely violation of privacy, violation of his individual rights. He does not want consultation. I am forcing upon a consultation here. So we did not have any laws to authorize this. Because of section 94 of the Mental Health Care Act, we are allowed to make house visits, go discussion, have discussion, assessments can be done, evaluations can be done, and even ambulance services can be provided. This also includes mobilization of this patient from home. So this is a very important section that we have which authorizes us to make house visits. And the criteria here for using section 94 is that you should have some evidence from history, records, or from a complaint from the police and things like that to say that he is at risk of harming himself, harming other people, and destruction of property. So 3 things I have evaluated here as per the section 89 and 90 requirements. These are 3 criteria where he should fulfill. Only then we should go and intervene. You get so many complaints like, the person has delusion disorder, where it's only restricted to one area of delusion, rest of the things is alright, he can be considered capacitous, he's functioning normally, attending work, he's attending all his house responsibility, but only one area of delusion is affected, and family members keep coming and asking us to do house visits. But under section 94, he does not meet the other criteria. So you must remember that he's not at risk of harming himself, he's not at risk of harming other people. If he's actually demonstrated violence and hit people, yes, you can use this criteria B here. If he's destroyed property, again here you can use criteria C here. But the issue here is he'll be capacitous. You must understand, you can mobilize them, get them to the hospital, do an evaluation, and once you do an evaluation, you'll know that he may have all the broad headings under which he will be considered capacitous, so you cannot force upon treatment there. He can be considered section 86 if he is willing to get admitted, if not, he has to be sent back home. So transfer of persons with mental illness, there used to be a lot of discrimination. People with mental illness wouldn't be admitted or mobilized by ambulance. 108 would say that he is person with mental illness, I will not take this patient, I will not transfer this patient, and they would refuse. So because of the new act, it is made sure that he is not subjected to any discrimination. He has right to equality, and section 21 talks about it. And here he has equal rights like any other person with medical illness, so he has every right to use the ambulance facility. And they have to go and put them on admission under 86, 89 or 90 as per the requirements. However, there are no broad established guidelines from the government or any other protocols here. You should have your own protocols to make sure you're violating the rights of people the least. Be open to public scrutiny and scrutiny of law. So in case you're mobilizing somebody from home, make sure your colleague or somebody is actually recording the whole process of evaluation and process of injection, all this mobilization that you're doing and putting them in ambulance should be recorded just for public scrutiny and review, just to make sure that you didn't overuse your authority as a treating doctor or a professional here to mobilize this person from home. So this is, suppose you have to discharge a patient, so you have an additional provision here. Section 91 talks about leave of absence. So if you're not sure that the person is completely recovered enough, if you think that he's not ready to go and live in the community independently, you can use this sort of provision of section 91 here. You can allow them to just go back home 1 day, 2 day, 3 day, 4 day. There's no limit here. You can allow them to go leave them in the community and see if he can function well without being at harm to himself, others, or destroying any property. If the dangerous criteria is not met, you can actually call them back and review the whole contracts details that you had when you're sending them on leave of absence. You can put in terms and conditions. You can say that he has to take medications, he has to come for follow-up, he has to attend psychotherapy, counseling sessions, he has to work. All these terms and conditions which you think is important can be actually specified in this sort of contract, and he agrees to this terms and conditions, then he goes back home. If he does not meet the dangerous criteria, he can live in the community. So in case he is fit for discharge, again this is a separate request form. Earlier we just discharge on request with family, discharge again medical advice. So here there has to be specified forms under which they ask us for discharge, and this is the only way in which we can authorize, and he has to be requesting you by way of a form here. So the additional burden as a treating doctor that we have is the discharge planning process here. Earlier it was just like any other profession, so we should say discharge counseling done, patient can be discharged. But here discharge planning is important. The discharge planning starts from the day of admission. He may get into the system here, he may be incapacitated, but till he regains capacity, till he is safe enough to live in the community, you have to constantly evolve a discharge plan to say where he's going to stay, how he's going to manage himself, in terms of his safety, place of stay, place of supervision that can be established, in terms of follow-up in case he's going to go to a different city. It has to be a follow-up under different doctors. So all those things can be planned. So we have sufficient time from the day of admission till the day of discharge to do discharge planning. It is applicable to all forms of discharges. It can be section 86 or a minor or a section 89. So all form of discharges need to follow this sort of discharge planning. Are the students getting bored because so monotonous, right? How many of you want to take up psychiatry after knowing that you have to do all these things when you're treating patients? You can treat anybody else with just one signature, but here is psychiatry, right? So we're treating a vulnerable population, you don't want to violate rights. So there's so many legalities involved here, there's so many procedures and processes that you have to follow here. So how many of you here are keen to take up psychiatry? I wish I had asked you before I actually began my talk. So in spite of all the hurdles, not everybody gets into trouble. So you may have not actually followed so many things, but if you're treating the person with the best interest of the patient and just followed the basic principles of medical ethics, you would have done wonderful recovery and treatment possible. You may not get into problem with the law, you may not be supervised, you may not be checked, you may not have any complaints also. But there is one unlucky person who can get into trouble when you're not followed, if you're not informed the board, if you're not got approvals, if you're not taken the valid consents, you're not discharged according to timelines that's been allowed here, he's the one person who will be penalized, and penalty is very harsh. Nobody's going to look at that point of time whether you did it in good interest, were you ethical. They are only going to ask you whether were you a legal psychiatrist, did you follow the provisions of law. So this one unlucky person will get into trouble, so we have to be aware of law. Most of the principles are general, it is applicable to all specialties, but in psychiatry this is more specific and we are going to be monitored. So there's a special thing called capacity assessment. All specialties take signature because law assumes that everybody has capacity to make decisions and everybody can sign for themselves. But in psychiatry, there's a special indication here. You have to do assessments and make sure he satisfies all these sort of criteria, then only he can sign up your consent. If he does not have capacity, somebody else signs for you. So this is one procedure which has become a backbone for all treatment decision related making here, and this is one thing that you must remember. It has to be done at every step whenever the patient is authorizing any form of treatment. It could be ECT, it could be admissions, it could be discharges. You have to make sure he is capacitous. It's not a very difficult way of assessment. It should become a part of a routine. When we are asking him to consent, there should be three headings under which we should evaluate.
does he have the required understanding to understand what the illness is about? It is about comprehension. Can he really understand what the illness is about? The next one would be, can he foresee the risks or the disadvantages and the benefits of making a decision for treatment or against the treatment? So does he have a reasonable ability to make this sort of distinctions? The second thing. The third one is, can he communicate a decision? So this is a three basic things that will do assessment. And each time you are assessing capacity, it's specific to that task alone. If you are doing it for ECT, it is only for ECT. If you are doing for admission, it's only for admission process. It's not that his capacities and you assume that he's got capacity for everything. So make sure you're doing it only for those specific tasks here. And there are specific forms approved by the government, and you use the specific forms. If you don't use the specific forms, at least capture the responses in this sort of headings here. It may take around 10 to 15 minutes, but it's worthy to do it, and there are timelines for it. Suppose you say that you have all professionals will have to do capacity assessment before you do treatment. Won't you complain? What do the students here think? Suppose everybody has to do assessment and it's mandated by law, will you not protest? No, doing capacity for the assessment is specified and mandated for psychiatrists. Suppose they say all specialists have to do it. Will you protest or will you not protest? Because right now we're just finishing our discussion with just one signature and we are assuming his capacities. I also protested because I didn't want to do it. I kept complaining and I went to the Ministry of Health. We had a petition, we filed a public interest litigation saying that this is a draconian act and it is not good for us and against the best interest of patient. But court very clearly said that these are in the best interest of the patient and you may be put at discomfort or consuming more time, but it's in the best interest of patient, you have to do it because it's world over. The rest of the world is following this, and so you have to follow what they say. And we lost it because patient interest gets the prime importance here. So the next way to adapt is, how will you adapt? If all these things is forced on you, for example, consumer law is forced upon all medical professionals, how did they adapt? They put so much of onus and they put us under civil liabilities under Consumer Protection Act. So how did the doctors adapt? They started investigating every patient who comes. If it's fever, cough, earlier he would get a prescription, now he gets a list of investigation. The patient is going to bear the cost of it and it's going to be a huge bill on them, but still this is the only way you can protect yourself because you've done every possible investigation to assess and find out the other comorbid illnesses, other contributing abnormalities, and actually looked at the possible etiology for an illness that he's come to you. So you investigated. Because of investigation, patient stands to lose, and physicians and hospitals do well because revenue for them. So that's the only way you can adapt. So when this is thrown on us, I'm a private practitioner, so for me time is money. So I can see 10 patients if at all I don't have to follow all these things. But if I have to follow all these things, I can see only 2 patients. So it's a lot of revenue, loss of revenue for the hospital, for the practitioner here. So we'll have to adapt. So how will you follow all these things? So in the same way, I said that all capacity assessments are paid assessments. So everybody who goes through consenting process is a paid process now. Earlier I used to do free for the patient. So now I made it a paid process. So it's a billable quantity here. The moment he gets into admission, there is 86, 89 or 90. It's a billable quantity, so there's an item capacity assessment, there's an item for informed consent, and the admin will make sure that all my staff follow it. So as a nominal fee are kept as 500 rupees, there are people who charge 2,000 rupees, 3,000 rupees. You have to adapt and make sure you follow this, but there's no scope for escaping the wrath of the law if you fail to do all this. So with psychiatry, you have newer documented procedures. You have a lot of forms here. You have a lot of applications that you want to get here. If at all he wants his basic medical records, there's a specified form. He gives you a specific form and says these are the basic medical records that I want. If it's an outpatient, then I have 8 to 9 headings under which you should capture the data. If it's inpatient, 16 to 17 headings under which you have to capture this data. And anything more than that, you're welcome to record, but what is mandated is these basic headings. It could involve the laws of social demographic details, personal complaints, provisional diagnosis, the plan of management, the section under which you're going to admit, whether there's any differential diagnosis, the discharge process, what you have followed, timelines, all those things are specified. So you have to have basic medical records. So if you don't have basic medical records, you're penalized. So all requests come as a form, all assessment comes as a certification here. capacity assessment as a certificate again here, and in case he wants to go for leave of absence, he gives you a form. So all these are specified forms which only psychiatry profession has. And all of us have to store records. Outpatient records, there is no mandate from the NMC for the duration period, but it's a good practice to have it for 3 years. Inpatient records is mandated for 3 years. Medical legal cases is indefinitely holding the records. So we admit patients in all other specialty. There's only one time that the patient absconds from hospital when it comes to paying the bills. The family members and the patients who cannot afford slowly, promptly escape and leave the hospital without completing discharge formalities. But here in psychiatry, they leave the hospital for other reasons. They don't want to be admitted here. They don't believe that they have illness here. They don't believe that we can make a difference in their life. So they would abscond from the mental establishment. Earlier, there's a lot of onus put on a treating doctor to say that I have to help them trace this patient, I have to give a police complaint, make sure I go do house visits and find out all those things. But in this act, it believes that doctors are here for treatment, and you don't have to criminalize all this admission process. Though you're saying that he's sectioning under 89 or 90 and treating against his wish, it's not that he's done some offense. He's not a criminal. He's not under the law for wrongful doings. Here he's only come for treatment. So if he leaves the hospital without permission and completing formalities, it's just that he's left the hospital. You don't have to criminalize the whole process. So there's no onus for a doctor to go and trace his patients back. But it is a good practice to inform the family, to inform the police here, do whatever possible that you can do to trace his patient back to the family. So we have admissions into various mental establishments for rehabilitation purpose, de-addiction homes, halfway homes, shelter workshop, daycare centers. But whenever you are doing all these things, the same principle applies to all other centers also. Only if it's a person who has a record of crime, he's under the law for wrongful doings. If he's a prisoner, if he's referred by the prison authorities for treatment, you have a duty to file a complaint. The police have to register FIR, and it's their duty to trace this patient and put him back into the hospital. So again, the onus is put on the police to trace this patient, but we have to follow this sort of timelines and guidelines there. Of course, when we are treating people, we have to have a lot of policies here, because when they're admitted under Section 89, they're not cooperating, so there will be a special form for restraints. So it's just not that tie up this patient, it's not that you have to sedate this patient. There will be a specified forms here. Who is authorizing the restraint, whether it's chemical or physical, and how long you want him to be restrained, and the reason for it. Every 15 minutes there has to be an evaluation. At the end of every month, you have to give a list of all the restraints that you have done on patients by tying down, but not chemical restraints, to the mental health review board for review. Suppose you are excessively using physical restraints and tying him down to bed and keeping him immobilized for whatever reasons, the mental health review board will have an opportunity for you to come and inspect, and if you are using excessive restraints, they can actually prohibit you from doing admission, because they feel on an average a psychiatrist in Bengaluru has only authorized 2 restraints in the whole month, but you are authorizing 2 restraints every day. So they want to see what exactly is happening in your center. So they have a log of all the restraints that you do, so they can come and inspect this. I thought I'll just give an example of a case scenario. We all treat people with alcohol dependence, chronic liver disease. They come for admission. So generally when they come for admission, they are people who are delirious, people with chronic case of psychosis, who can be confused. At this point of time, they have no insight, no motivation, they are disoriented at times. They may not have a capacity to make decisions. So we treat them as people with high support needs and put them on involuntary treatment. Once they become capacitors, it could be the second day, third day, you have to keep repeating the capacity assessment to make sure you know that he's capacitors and move them into respective categories. Once he's capacity, he decides what he wants to do. This is a real life scenario where a patient had severe hematemesis at night, and he actually died. So there will be a scrutiny on what is the form of admissions. If you have done involuntary admission, did you inform the board, did you have approvals? So if at all everything is in place, and if you follow the best possible practice for resuscitation and taking care of this patient during the rehabilitation process, even if you have failed, nobody can guarantee the treatment outcomes as 100% success every time. But there are evidences from CC footage and evidences from your documentation to say that you're taking care of this patient. So the conflict here could be consent, conflict here could be attending to the patient in emergency. You have the required protocols to manage a patient in emergency, like hemodialysis, and you have medical person supervising this sort of program. Have you investigated adequately? So it can become a medical legal issue. A simple all-call case can become a medical legal issue. Suicide attempts is also a very common scenario. Here again, we have somebody with severe depression. With severe depression, most of them will be capacitors. If at all they have delusions, they can still be capacitors. There will be a small sect of people who are incapacitated because of their nihilistic thinking, and they may not be able to appreciate the foreseeable advantages in treatment. So they fail the criteria B there, and so they can be put on section 89. So they can also attempt suicide during the admission process here. So though you have taken all the precautions, there was a lady who had attempted suicide by hanging by using the leggings here. So you cannot take away every precaution, only ensure certain amount of safety, but this patient attempted harm by using the leggings, but because of CCTV monitoring, you cannot monitor patients in single rooms, but in general wards, common shared rooms, you can only monitor. Anybody who's suicidal, the protocol should be, they should have a 24 hours attender supervising from the hospital, from the patient side. There has to be always some sort of supervision. So the other important boon that we have because of the new Mental Health Care Act is that we have insurance here. Earlier to the Mental Health Care Act, it used to be an exclusion that people with mental illness are excluded, people with suicide attempts are excluded, people with substance abuse are excluded. Nobody wants to treat and reimburse these sort of bills because they feel it turns to a large amount of bills, and they don't have mechanism for assessment. They don't know what's the premium that has to be given. But because of the courtesy of this new act, it's mandated that everybody has to provide. I was just doing a review of literature, looking at around 30 insurance companies. Out of 30 insurance companies, it could be private, it could be public center funded, or it could be a combination of both. There are 7 companies which are yet to adapt in spite of 7 years of this implementation of the Act, and they don't reimburse psychiatric illness. 23 companies actually reimburse psychiatric illness. They have distinction saying that the waiting period is 4 years in some policies, the waiting period is 2 years in some policies. Some are saying no OPD treatment is reimbursed. Some are saying suicide attempts are not reimbursed, and except for only one policy. I think New India Assurance actually reimburses, even New India Assurance does not reimburse. There is no policy which reimburses suicide attempt, even though suicide attempt is a psychiatric illness. Substance abuse, again this sort of differentiation happens with substance abuse. Substance abuse is also not reimbursed except for only one policy. So we are lucky to have Auditorium Karnataka here, that is PMJAY across India. Ayushman Bharat is what they call here, and here they are reimbursing normal admission up to 1,500 rupees per day. Serious conditions which need some sort of sectioning could be 2,500 rupees a day. ECT package is also being given, pre-ECT workup is being reimbursed, so it's very nice. The difficult part, if at all you don't remember anything of my presentation, at least you must remember my last slide here. The Mental Health Review Board, you are under constant monitoring with this review board. If you don't follow the review board and the provisions here, you have a lot of penalties here. You must remember that you may have 10,000 rupees as an initial penalty, which can go up to 50,000, and in case of repeat penalty, can be penalized by 5 lakhs. It is all being specified under section 107. So you have to be careful of penalties. Of course, you're going to earn and pay back this penalty, but you can also have a reputation harm. You can be imprisoned up to 2 years. So minimum imprisonment that specified is 6 months for violation, and if you violate it further, it could be 2 years. And if you have worked in a hospital which is not licensed, you have a fine up to 25,000. So ignorance of the provisions of the law will not actually stand as a defense here. So you are expected to know, when you practice psychiatry, you know all the provisions of law. There are a lot of rights given to a person with mental illness, and all these are specified rights here: right to community living, right to access mental health care. So he has a right to access mental health care from a public mental health establishment. It's a duty of the government to provide services free of cost. Suppose he cannot afford rehabilitation program, government has to reimburse his cost of rehabilitation program also. Right to personal contact and communication is to restrict contact. Now it has been a right. He has to have a right to access his contacts, and the right to make complaints about deficiency in provision of my services also. So a lot of rights have been provided. We have to do a lot of work to avoid medical legal issues here. Adequate documentation will really serve as a test of time. We can take second, third opinion if you're not alright. You can take a lot of consents. If you're not comfortable, take a second consent from the impartial witness also in case it's needed. You need specified forms for sectioning. You have to be in tune with the Mental Health Care Act, and all admission has to be in the specific act itself. Keeping a family member during admission will ensure a lot of rights are protected. Liaisoning with police, law enforcement agencies, NGOs, all those things becomes important and more specified to psychiatric practice here. I think that's it from my side. Thank you so much for patiently listening. I didn't wish to scare students here, but this is followed the rest of the world. So we have laws. We have to be law-abiding psychiatrists, and if at all you decide to take up psychiatry, first course that you have to do about psychiatry would be the legal psychiatry. Then you can do practice of psychiatry outside institution, because in institution you're protected. You have a lot of protocols set in, but outside you can explore everything independently. That's what we need to catch up. Law can have an overreaching effect on your practice, so we need to know about law before we practice psychiatry.
Thank you, Mahesh sir, for such a comprehensive and lucid presentation. We had audiences from various sectors, I would say, PGs, then practitioners as well as UGs. Your talk has definitely benefited all three people. I'm sure that sir has evoked some knowledge into UGs as well about Mental Health Care Act. And just now I was just interacting with sir. Sir said that even in forensic medicine, it is a 10 marker, it seems, for all of you. So if at all of you were alert, then maybe some points you can definitely write from the presentation that sir has made. So many new terms that sir introduced to you all. Like, for example, Mental Health Review Board, nominated representative, then this advanced directives, and these many things which probably you might have not heard even before today. So I'm definitely sure that this talk has benefited each one of you. I leave the floor for discussion now. If at all you have any questions, you can definitely ask.
Yes, ma'am.
This lady also.
I think the broad principles. Yeah, see, the broad principle of consenting for across indications is similar. Every person needs to understand what he is signing up for. So he has to know, for example, if he is going to sign up for ACT, here there is a mandate that you have to explain that he has a nature of illness, what is the nature of illness, what are signs and symptoms, what is your diagnosis, what are the forms of treatment that's available for this sort of diagnosis. In case you have proposed ECT, what is the indication why you are proposing ECT? What are the alternatives to ECT that he has? What are the side effects of ECT? What are the benefits of ECT? And in case he wants any sort of scientific references literature, you have to provide all the relevant literature to make sure he has an access to the best possible information available. After having understood all the risks and benefits involved, he has to voluntarily agree to sign up for this sort of process. To make sure it's transparent and clear here, you ask the family member also to sign up, because you may think that people with psychiatric illness are vulnerable population. You may be capacitous. Taking additional consent is always protective, so you take additional family members' consent. In case there's a language barrier and you used a translator, you have used an interpreter here, you have to take additional consents from impartial witnesses. Because if I'm using, I don't know Telugu, I'm not very fluent, so I would have used a translator there, so he becomes an impartial witness for us to make sure this process is done. So the broad principles are similar. We assume the patient with mental illness also understands everything, and in case he is proved by assessment that he is incapacitous, you do all the explanation with the family member after having assessed that patient with mental illness is not able to understand. So it's good to always attempt a consent with a person with mental illness, and still involve him in all the consent process, because it's his life, his well-being, and his recovery process, so he should be a part of it. Broad principles are similar.
So these sections do they follow the rehabilitation homes and halfway homes?
Yes, basically what they've done is they have not made it based on the mental health establishment. Mental health establishment can be anything, but they made it on threshold of illness. For example, if he's reached a threshold of being incapacitous, whichever institution he stays, this is the form of admission he has to follow, and this is the form of reporting to the mental health review board he has to follow. So this illness based and severity based and capacity based. Not based on the type of centers. Of course, there are a lot of centers which don't follow anything this that we are talking about. In Karnataka, Chandrasekhar sir, when you are Dr. Chandrasekhar sir, the number of licenses that you issued in Karnataka were close to 400. 250 to 300, I think it's earlier. Now, if you look at the current assessment, it must be much more than that because so many people have applied. And if you look at 300 to 400 centers, I'm not even sure if at least 10 or 20 are following the exact requirement for the law. None of them are penalized. But if there's a bad case, there's a death, if there's a public scrutiny, if there's a scrutiny by the law, that's when you look at all the provisions. If you're not followed, you cannot fall back on any of your good practices that you've done. You will be penalized. Yes, sir.
No. Only that there is two independent psychiatrists have certified for an involuntary high supported admission. Now, what does it mean? Is it that two psychiatrists from the same institution, or two psychiatrists from another institution, or one psychiatrist, psychologist, one psychiatrist, and a doctor? Now, I had written a question which I shared with you, to the chairman of the review board, and he had written that even in a medical college, in a unit, you can have two psychiatrists in the unit who can actually independently evaluate and tell that. So I just wanted to have.
Yes, sir. What the law says is these two assessments has to be independent. It does not say it has to be outside the institution. For example, if it's two faculty from same department, assumption is that you people have, you don't have to have the concurrent assessment. It has to be sequential assessment. You assess now, then he goes to second assessment, and both of you agree independently that he needs admission. That's what is meant by independent assessment. So this independent assessment can be within 7 days of each other. For example, today you have seen the subsequent assessment can be within 1 week's time. So both of you independently agree that he has to be admitted for his best possible recovery process.
That's right. Other sir has asked about this halfway homes and rehab centers. There are a large number of rehab centers which are run by not by psychiatrists or psychologists or any professionals, by NGOs, so trust ordinary people. So Kerala, Tamil Nadu, Karnataka to some extent, Andhra, all these places are having a large number of centers. Kerala also has got around 120. They give some of the places are having 500 to above patients, and they do not have any relatives or things like that, or assumed to be not related. So none of these organizations are following completely the Mental Health Care Act, but at the same time, they could not take these patients to any of the government facilities because government facilities and the medical college facilities are completely full. So this is a current situation. So where do these organizations come into the picture? Because we are also facing the same problem with our center in Yadavanahalli, where we rescue people from the roadside. So we do not know where we fall into.
So basically, if you look at the law, there's no law separate for a private psychiatrist and a government psychiatrist. There's no law separate for an NGO also. The spirit of treatment is same across the indications. So if at all they do any sort of dilution and they want to say this sort of rules and regulations can be relaxed, it has to be through a government order to say that if people with homeless persons with mental illness have been treated in NGO and Finland, assessment can be done every 1 month instead of every 1 week. So there has to be a government order to authorize it, otherwise it's illegal, sir. There cannot be a separate provision just because it's 100% mental illness, just because the NGO is doing. You cannot dilute the concept of number of beds, number of manpower, number of feet of distance between two beds. All those provisions remains the same. Everybody has to get the same standard of care. Yes, it's the government responsibility. It's not NGO's responsibility at all. Government has to make sure they're providing all these things. They provide a place, sheltered workshop. They provide an extended care facility for all these people at their cost. Out of a lot of passion and humanitarian requirements, a lot of NGOs are doing it, but they have no special laws. I wish there were special laws, but there's no special laws.
But judges are also there to give adalats in that case.
Yeah, they will be compassionate and look at this as an NGO and not for a profit organization the way that we all run. They may be considerate, but the law and interpretation will be similar. If you have capacity or not is the question. Was he given a chance to right to community living is the question. If you violate all the rights, you are still penalized the same way and it won't be penalized.
Very excellent presentation was very informative, that's one thing. To clarify the doubts of my students, further the question of what sir had asked. These laws, all the things all is applicable for the establishment or the psychiatrist, because most of the establishments are run by the non-psychiatrists. That's what one of the questions sir was, private rehabilitation centers where an ordinary person just hates that one. Some consultant from psychiatrist gives cover from hundreds of kilometers away. This is happening. In any failure in that type of things, who is liable? Is the establishment or the psychiatrist? Because I want more and more of my students to go take psychiatry as their subject, because future disease load will be the psychiatric problems.
You're right, sir, when you're asking it whose liability it should be, but I'm going to say this as a patient. So if I'm a patient with mental illness, if I'm to go and get admitted, I'm getting admitted under you, but it's going to be under an establishment. So as an employer, as a person, as an administrative head from the employment side, he has additional responsibility to make sure he's employed a qualified psychiatrist. Not only a qualified psychiatrist, he has to be registered with the state mental health authority. I'm a psychiatrist by qualification, but I have to be additionally registered with the authority to make sure I can admit people in Karnataka. Suppose I move to Maharashtra, I have to take the respective registration then in that state and then only admit. If at all something goes wrong, for example, a person who's admitted under me, something goes wrong, I'm penalized as number one accused, or medical administrator can be number one, I could be number two. So both of us have independent responsibilities and liabilities here. We cannot escape, and each will not put it on the other person. Both are responsible and will be liable, sir.
So that means if they choose psychiatry, it's not that scary.
Definitely not, sir, because all of us have occupational hazards. If you look at any surgical specialty, there are even much more hazards. But what's very clear about surgery is that they know it's a specified procedure. They know all their alertness in terms of the litigation and in terms of the hazards they get into. They're in the highest form of alert. They do extensive documentation for consenting process, and everything is explained in detail, and everything is so clear. They're less likely to get into trouble even though there's a bad outcome. But in psychiatry, what happens is we don't have so many procedures, but every other step of treatment is a consenting process for us. Every other step can be a litigation. Every other step can put us into trouble. So we don't have so much of documentation unless and until we are trained to be a legal psychiatrist and we document everything in person. So that's where we are more liable compared to other specialties.
Thank you.
If there are no further questions, we'll end up the session right now. Okay? Thank you.
Now I request the chairpersons to present a token of appreciation to Dr. Mahesh Gowda.
Thank you, sir.
Let us move on to the last session for the day, Embracing Positivity, Advancing Mental Health Care Through Positivity Psychiatry by Dr. Manju Ashwar, Professor and Head, Department of Psychiatry, Kempegowda Institute of Medical Sciences.
To chair the session, I would like to invite Dr. Pallavi A. Joshi, Consultant Neuropsychiatrist, Manipal Hospitals, and Dr. Lakshmi V. Pandit, Professor and Head, Department of Psychiatry, Shri Atal Bihari Vajpayee Medical College and Research Institute.
Thank you.
I request Dr. Pallavi A. Joshi to introduce the speaker.
Dr. Lakshmi ma'am wants to introduce our esteemed speaker as she was a student. So I'll hand over the mic.
Good afternoon, everybody. Welcome to this session. The presenter today is Dr. Manju Ashwath. She has completed her MBBS from Davangere and her MD Psychiatry from KIMS, Bengaluru, where she was my student. So it gives me great pleasure to have her present and all of us listen to her. She's currently the Professor and Head of KIMS, Bengaluru. She has a vast experience in the field of psychiatry. Her areas of interest are child and adult psychiatry, women mental health, and medical education. Her work encompasses therapeutic services in adult psychiatry, child and geriatric psychiatry, alcohol and other substance de-addictions, and psychosocial interventions. She strongly believes in integration of biological, psychological, and social approaches in the care of patients and their families. Involved with the teaching of psychiatry to undergraduate, physiotherapy, psychology, and pharmacy students, along with the postgraduate students in the department, she has successfully guided many postgraduate students. She is a member of various committees in the college: Gender Harassment Committee, Alignment and Integration Committee. She has publications in various leading journals. She has been appointed as a member of the expert committee formed by Government of Karnataka regarding menstrual leave policy. With this brief introduction, I think we shall start the session.
Very good afternoon, everybody. Thank you, ma'am. From a very anxiety-provoking MHCA discussion, because a number of questions which came through, realized that we have got so many queries, and asking me definitely is extremely anxiety-provoking after this MHCA is coming to picture. So let's move on to something more positive. Let's move on to positivity and well-being. Now, since a lot of students will go from the basics as such, I will not be taking too much time. I know it's postprandial and there's literally cognitive overload. So I think you'll have to bear with me for some time. So if we talk about what is health, I think all of you will definitely know it is a state of complete physical, mental and social well-being, and not just the absence of disease and infirmity. Now coming to the definition of mental health, what do you know what is the main important aspect of mental health? It's a state of mental well-being that enables people to cope with stressors of life and realize their abilities to learn well and work well and contribute to the community. Now, if you just bring them down to three core components, it's mainly one, there has to be a well-being. Second, there has to be an effective functioning of the individual. And third, there should be effective functioning for the community. Now, whenever you talk about any disorders, be it mental disorder, mental illness or physical disorders, you know that there are always three interventions. Primary is mainly preventing the illness. Secondary, where you try to maintain health, that's early detection, prompt treatment and limitation of the disability. Tertiary is mainly, it is in the later stages of the disease, which is aimed mainly at the recovery, rehabilitation and restoration of the functioning. Now, keeping this in mind, let's just go to the definition of psychiatry as such. Since many students, all of you are UGs, I just want you to understand what psychiatry actually means. Here, it is a branch of medicine which is mainly focused on three important aspects. One, it is the diagnosis. Second, treatment. And third, it is the prevention of mental, emotional and behavioral disorders. But what you all need to understand is, there's a lot of work and research has happened in the first two aspects, that is diagnosis and treatment, because it is more, the psychiatry traditionally is more entrenched in the disease-centric model. And every time you talk about mental health, it is always viewed with the lens of mental health problems. Okay, so it is much of importance has not been given to the broader aspect of mental health. So that is where positive psychiatry comes into picture. So that is prevention aspect. But at the same time, what you all need to understand is, it is just not preventive psychiatry, it is even promotion of mental health in patients who are also mentally ill. Now, coming to what is positive psychiatry? It's the science and practice of psychiatry that seeks to understand and promote well-being through assessments, intervention, and a main aim of it is mainly to enhance behaviors and aim at mental wellness. So the main important aspect of positive psychiatry is to make people realize their potentials throughout life, so that they can lead a very prosperous and life which is filled with well-being. Just a brief note on the evolution concept of it. Positive mental health is not a new term. Now when you look at it, it was the psychologist William James in 1906 actually spoke about the healing powers of positive emotions and beliefs. However, it was ignored till the mid-20th century. Then it was when the humanistic psychology movement started, that is by Maslow, wherein he actually worked on understanding healthy, creative individuals and their growth. Now the term got more importance in around 1988 when Martin Seligman actually discussed about this in the presidential address, where he told that there is importance to shift focus towards the positive aspects of human experience, positive individual traits, and more generally the positive features that make life worth living. Now, actually there is no arbitrary difference as such, because this is a part of psychiatry. But to make it a bit more clear to you all, what exactly do you feel, what are you targeting, what are you working on in case of positive psychiatry is, usually in psychiatry what we do, the main targeted patients are the ones with mental illness. You usually go and assess psychopathology. The research focus here is mainly on risk factors and psychoneuropathology. Treatment goal is symptom relief and relapse prevention. The main treatments, yes, are your medication, psychotherapy aimed at symptom relief, and again it is relapse prevention there. And the prevention aspect is largely ignored. But same thing when you talk about positive psychiatry, here it is not just normal people, it is also people who are having mental illness, people who are suffering from physical illness, they are the target patients. Then you usually look at, the assessment is mainly for the positive attitudes and strength, and the research focus is mainly on the protective factors and psychoneuroplasticity. The treatment goal is mainly recovery, increased well-being, successful aging and post-traumatic growth, and the mainstay is usually psychological interventions. And what's so important is that this prevention aspect can happen throughout the person's lifespan, especially during the transition period. So it is not that it happens at a younger age or in the adulthood or in old age. So all this can happen throughout the person's life. Now whenever you talk about he's talking about positive psychiatry, you need to have some dimensions and measures. Because if you want to make this approach, which is, you have to work on this interventions. So these are called as positive mental health outcomes. So what are they? The first one is well-being. Now what is well-being? It is not just the mere absence of mental and physical disorders, but also the presence of positive psychological states. So here it is mainly the eudaimonic type of happiness. See, you have got two types. It can be hedonic and it can be eudaimonic. Eudaimonic is usually a pursuing happiness by finding meaning and purpose, which is usually long lasting. In contrast to hedonic, wherein happiness is usually, secondary to some experiences, some pleasure. Okay. Now the second important positive mental health outcome is the low level of perceived stress. Now what do you mean by perceived stress? It's mainly the contemporary demands. This is your ability to cope. And studies have shown that perceived stress is more critical than the objective measure. So it is how I look at it rather than how much I have been stressed. So that is extremely important. Successful psychological aging. This is one more aspect which we usually see. that it is the ability to adapt and have a positive attitude about future, and this is found to be more important than the absence of any physical disease. Now, post-traumatic growth. So whenever there is a severe stress, so the person either they can be decompensation or they can be personality growth. Now, how do you tell that there is personality growth? It is usually, it depends on the person's resilience. Now, how do they, you see a person who's had a personality growth following a stress or a traumatic event, there's more of appreciation of life. They start having closer interpersonal relationships. They're having recognition of new possibilities and altered priorities. These are some of the ways in which you see that the person has had a post-traumatic growth. Prevention and recovery of mental illness. What you need to remember is there can be periods of wellness within illness. So you need not be totally, if you're having a mental health disorder, does not mean that you cannot be well. At the same time, a person who is well need not, cannot tell that he's not having any mental health problems. So you have seen that many people have got chronic illnesses and they've also led outstanding lives. So when we spoke about positive outcomes, what affects the positive outcomes? These something called as positive psychosocial traits, characteristics, that is PPCs. Now they again can be divided in two. One is at the individual level, that is positive psychological factors, and the second is usually the environmental factors. Now coming to the positive psychological traits, these are actually very strong predictors for well-being than physical health. The first one is resilience. So resilience is ready recovery from or a positive adaptation to illness or other diversities. I think you're all used to this term, isn't it? We use the term so comfortably, oh, the person is extremely resilient. We tell that children are having extreme resilience. So this is their capacity to adapt to certain changes. And what is it? It has been shown, studies have shown that these people who are having good resilience, they have a lower risk of all cause of mortality. These people have got a better physical health. They have got a better quality of life, better self-care, and these are people who usually follow the treatment well, they are adherent to medications, and they are having a better emotional health and higher longevity. Next is optimism. Now, as you all know, optimism is tendency to expect a good outcome. So, these people who are more optimistic, it has been found, be it cardiovascular disease or malignancies, people with a higher optimism, they have found a better health outcome. And the reason being, these people are more likely to engage in healthy behaviors, and they have got less illness-related distress, and similarly higher quality of life and lower incidence of depression and serious medical conditions. Personal mastery and coping self-efficacy, these are again some of the positive psychological traits, wherein personal mastery means one's expectations of personal effectiveness in achieving a desired outcome. So sometimes what happens, a person has chronic stress. Some people promote specific adaptive and goal-directed behavior and help in maintenance of their life well. So this is also found that having more of a personal mastery, they are protective from the negative health effects of stress. Coping self-efficacy is again self-preserved ability to activate specific coping strategies to overcome life's challenges and to influence the outcomes. Now, social engagement. Social engagement is mainly your integration into the society. You are having a good social network. So how is it usually assessed? It is assessed with the number of quality and close relationships, the frequency of which you socialize, and very important, it is the degree to which one feels pleasure from social interactions and integrations. And it has been found that people who have got a better social engagement, there's decreased morbidity, especially chronic medical illness. Spirituality and religiosity, yes, this definitely has a role to play. So when you differentiate it, spirituality is nothing but a personal beliefs and thoughts, and the behaviors are focused more on some transient topics like meaning of life and being of a higher being. Now, religiosity is again has got a social connotation. But what it has been found that these people have been associated with greater well-being and have got a better health outcome. Wisdom, I think in the morning Dr. Shukma did talk about wisdom as such. There are various definitions of wisdom, but when you talk about what are the core concepts or what are the important elements of wisdom, it's mainly pro-social behaviors, good social decision making, acknowledgement of uncertainty, emotional regulation, tolerance to the divergent value system which is changing, openness to new experiences. And this is definitely useful for self and to others. And this is something what they tell, especially when you look at the elderly people. These people with more wisdom or who are more wise, they're able to survive despite worsening of the physical health in old age. And yes, a beneficial effect is can be transmitted to the younger generation. Now coming to the second aspect of positive environmental factors, as you know, they play a crucial role. Now family dynamics is extremely important. Now you know how the family dynamics, we talk about small regular interactions also, a good parenting style, how you discuss with the child, what type of parenting you have got, so and whether the closeness, spending of quality time with your child. We talk about all these things. I think it is actually having a beneficial effect on the child. Now that becomes with the normal. Even dynamics as such, most of you will know family dynamics is extremely important as it has an impact on when there is illness as such, on the symptoms, on severity of treatment, response and recovery, and this for both physical and mental health disorders. Next is social support, extremely important. We usually consider when we treat patients with mental illness, when we ask our students what are the good prognostic indicators and bad prognostic indicators. So this social support is one of the good prognostic indicators. Now what exactly do you mean by social support? Social support is where when in time of distress or problem, when I can turn to somebody, it could be family, it could be friend, from wherein I can get some amount of support. It could be an emotional support, it could be financial, anything. So there's somebody whom I can fall back to in the time of crisis. So this is extremely important for every person. The others, as you know, we spoke so much, just discussed about what do you mean by health and what do you mean by mental health. So as you know, there is no health without mental health. Similarly, what we need to understand is for a very good mental health, you should have a good physical health. So what are the other environment factors which is important? It's important to have availability of regular medical care, adequate nutrition, opportunities of social, physical and cognitive activities. So this which will bring about a good physical health because it is definitely having an interaction. Now just a brief note, though we spoke about all the psychological issues, this positive psychological characteristics have definitely got a biological underpinning. Now it has been found that perceived stress, so depending on how the person perceives stress, studies have been shown that there is an increased oxidative process in the body and there is a release of increased free radicals. This is actually found to accelerate biological aging and associated with greater morbidity and mortality. Then when you talk about resilience and optimism, there have been a lot of related genes in the HPA axis which affects the limbic activity and prefrontal limbic connectivity. Now coming to the coping and self-efficacious behavior, it has been found that these people who got a better coping and are having a self-efficacious behavior, there is a decrease in sympathetic activity. How is it seen? It has been seen that these people have got a lower blood pressure and lower pulse pressure, and this is definitely good for the body in terms of stress. Pleasant social engagement is found to decrease the inflammatory biomarkers and decrease catecholamine response to stress. Inversely, people who have got decreased personal mastery, who have got decreased coping and decreased self-efficacy, again it gives rise to a cycle of chronic stress, increasing activation of the ANS and increasing pro-inflammatory markers and has a hazardous effect on the body. Talking about the neurocircuitries as such, resilience and coping is tied to adaptive changes in brain circuits for reward, fear, emotional reactivity and social behavior. It has been found that when there is increased optimism, there is increase in activation of the amygdala and the rostral anterior cingulate gyre. Now, compassion and empathy, the seat here is the anterior cingulate cortex and the bilateral insula. It's been found that increased activity in the prefrontal cortex and the limbic stratum, especially when we talk about increased wisdom. Now, Coming to the mental wellness focus model. Why do we need to do this? The most important thing, we need to empower people. We need to make the person in charge of his or her own mental wellness. So how do you do this? Making them more self-aware, making them more resilient, enhancing the coping. So what do you expect from this? When we do this, we can feel that there is a sense of autonomy. So I am responsible for myself. When I become responsible for myself, I will take proactive behaviors to become better. Next, by doing this, definitely you will be reducing the burden on the healthcare system. And last but not the least, it will be destigmatizing mental health issues. Now, with all this, why is there a need for positive psychiatry all of a sudden? From morning we have been discussing, isn't it? I think somebody just spoke that around 30% of people, 30 to 40% of people usually don't need medication. Now, if you ask me in my practice, if I see around 10 people in a day, 3 to 4 people or clients whom we see will just have some mental health symptoms. So they will not come under the purview of a diagnosable psychiatric disorder. So these are people whom you can work on when enhancing all these with the positive psychological traits which I just told you. So this way we will be helping them out. Now, why is it so important now? The scenario is changing. See, we're talking, stress was not there before, stress was there, stress is there now, but till now we see that the stress level has increased drastically in people, whether where their level of handling is changed or the other inputs. So it is, I cannot put it on one particular person that the person can't handle stress. It can be the other associated factors, and just an interaction with that is actually causing a lot of issues. Now, as you know, it is a lot of competition in today's world. There's a need to excel. It's not just in education but also at workplace. Second, work-life balance. People are not able to handle it because a few years back there could be some joint family system where somebody is there to help them out. Now that support system is not there, and now it's both. It's like both the people at home they're there, they start working. So this is something which we are seeing regularly. Next, physical health. Very early onset of lifestyle illness. Before, if you talk about diabetes, it was like, okay, 60-year-old person is having diabetes, like, okay, God, diabetes, he has developed diabetes, but now it is not like that. It's like brought forward. Even at the age of 30, 35, people start becoming diabetic, people start becoming hypertensive. If we talk about cardiac illness, it was like, okay, if he's had an MI, then he's an elderly person. But now it's not like that. You can see people as young as 25, 30 are actually, they are developing MIs. And if you ask the people, in what a cardiologist, they will tell mainly lifestyle changes, their stress, smoking. So all these things are changing. So that's the main reason why we need to introduce this concept here. And environmental factors, which I definitely would agree, because most of the adolescents and young adults we see definitely hooked on to social media. See, it's at your fingertip, your Instagram, your WhatsApp. How many of you would have checked your phones now in this 1 or 2 hours? No, it has become a habit because it has become a part of life and you cannot live without it. And what they tell, each time you flip your Instagram, there's some site like a dopamine high and you feel good. So you would have started to see on 2 to 3 reels on Instagram, but you'll end up seeing from 10 minutes, 15 minutes. That's exactly what is happening. And what you all need to remember is something, what is set in is something like a comparison what starts happening. People in social media usually try to project always the positive. And what we are seeing people is they see that, okay, I'm not like that or I need to become like that. So this lot of self-inadequacy started developing of late, especially in youngsters. Okay, and low self-esteem. So this is the changes what is happening now, and the need to work on this particular aspect is extremely important. Now, if we look at this, what you can understand is, see, there is what we call as well-being is there. So mental health problems is what I just told you, maybe 1 or 2 symptoms, but not a disorder, and mental illness, but they are overlapping. So what should be our aim? So well-being is not just for normal people. Well-being is for everybody across the population, with all, whether they're having problems or not. So our work is mainly to merge this and see to it that they have a feeling of well-being. Okay. Now what can be done at the individual levels? Now mainly interventions designed to promote your cognitive and emotional resources extremely important. Now for example, we discussed about self-esteem, resilience, enhanced coping skills and behaviors to prevent and protect and promote mental health is needed. How do you do this? Training in life skills and social competencies. Like how? It could be effective communications, it could be the way of changing the cognitive style, problem solving and enhancing coping and feeling of a sense of control. And again, this is important, it is relevant across lifespans, more so especially during transitions. You see a lot of change happens from adolescence to adult, from adult to older age. So this is very important. Community levels, focus should be mainly on social participation, social inclusion and civic engagement. So how does this happen? Mainly improving the person's sense of social belonging, building on the social capital, promoting self-help groups and strengthening community services to support mental health. And very important, whenever we need to bring in these type of strategies or interventions to the mass, there are some barriers, isn't it? So this is at the structural level. So what are the structural barriers that have to be reduced? Important, yes, other aspects are reducing poverty, discrimination and inequality, promoting access to education, meaningful employment housing, and providing services and support for those who are most vulnerable. So these are what can happen at the individual level, at the community level. Okay. Next, just a brief note on evidence. So as I told you, though it is not a new concept, work has been done, but some more research or it has to be put into action. Like in the morning, as they were discussing, Dr. Abhay Matkar was talking, it is in the incessant stage and they have done some pilot studies. It has to be, it has to make a bigger, it has to reach a larger population. So for that, lot of effort has to happen. Now, though there are positive psychiatric, where we spoke about positive psychiatry till now, there has been its effectiveness, that is evidence that in various disorders. So it has been found that the significant recovery from mental illness is seen if there is effective intervention to strengthen the psychosocial characteristics. Now this is one study which was actually, it is done on hope, optimism and resilience and self-efficacy. It was found that work on this has definitely positively reduced the reducing the depression level. Now this is one more study about association of resilience and psychosocial functioning in patients with schizophrenia, and it has been found that psychosocial functioning, there is improvement in that, definitely improves the resilience. Yoga, effectiveness of yoga, this is found that addition of this, see, this is a very safe and wide patient acceptability, and it was found that this improves depressive symptoms and anxiety in patients with MDD, that is major depressive disorders. Now, working on physical activity programs and sleep hygiene promotion to reduce the risk to develop psychiatric disorders. And it was found that when you integrate these psychosocial interventions along with your pharmacological therapies, it has found to reduce the disability and improve the quality of life of affected patients. Yes, this is again an inpatient, outpatient intervention of diet and exercise. Its effect on physical and psychological health, and it has been found that there was statistically significant improvement was seen in physical as well as global functioning of quality of life. The study about religion and social integration, which I told you about, one of the factors, it was found that more religious a person is, the more integrated and lesser chances of that person developing depression when compared to minority. Now coming to the exercise intervention, again it is now coming, this is a meta-analysis, so a lot of studies have been reviewed. So this is for patients who are having just some symptoms of depression but not depressive disorders, and it has been found that exercise has got as a beneficial effect on depressive symptoms. And this is again a review of 31 articles which was done on adolescent mental health. It has been found that optimism is a predictor, mediator as well as a protector of mental health during adolescence. So the most important here I am talking, I just showed you a few evidence for disorders. Now it is just for some just about regular normal functioning children also. Yes, again, optimism in relation to resilience and perceived stress. So optimism was associated with better resilience and decreased perceived stress. So the more optimism they were more able to handle their stress. When we come to aging, identifying, understanding and intervening upon psychosocial well-being. So rather than focusing exclusively on reducing risk factors, found to have help in enhancing healthy aging at the population level. Now, as we know, with all this evidence, as every time for any study or you discuss about any issue, there's some critical evaluation is always there. Now, critical evaluation for this lacks novelty. Definitely agreeable. As I told you, it is not a new concept. Positive mental health is not a new concept. But why are we doing it now? Mainly because though we knew it was not structured, there was no structure in which we were able to handle it and deliver it to the masses. So that is one thing. Second, they have told there's a false dichotomy between positive and negative. Now what you all need to remember, our genetic disposition and our life circumstances will usually affect largely about how we experience life. At the same time, how we process it and how we respond to these experiences. Now, when we talk about negative emotions, if you talk about sadness, anger, anxiety, they're all considered as negative emotions, but they are all normal emotions which everybody feels in their lifetime, isn't it? I think you all agree with me. So, here we are not discussing about going through all these negative emotions. It is a part of life. But what are we discussing here? We're discussing about how we handle it, how we process it. So we have to have behaviors which will actually help us manage it rather than allow them to rule us. And yes, constructs are vaguely defined, which needs more research. That's the reason why we tell there has to be more research and there has to be more proper validated assessments to be handled. And yes, it is not universal, agreeable, because whatever we talk our life, it is usually influenced by the culture and society. So it may not be the same. So well-being for me may not be well-being for the same person in some other country. So definitely we should work on having culture-specific norms also. Challenges after critical evaluations, yes, resources, and I think all of you will agree with me. It has always been an issue. Resources to handle this and how we have to deliver it to the population. That is a Herculean task. And as I told you, mental health is not got single determinant. It has got multiple determinants. So it could be at your economic level, it could be at your level at home or school, occupation. So there are multiple determinants for the mental health of that particular individual. So what do we need to do? We need to work on a multi-sectoral approach, which is quite tough, and we need everybody to get involved. And as we told, now we are talking about traditional psychiatry. I just told you how we are so used to one particular way of handling issues. Now there's going to be a paradigm shift, and this is quite overwhelming, and it can actually has a lot of impact on the existing system. From morning we have been discussing, isn't it? The number of psychiatrists are so less, the number of mental health professionals are less. Now with that, we have to start working on the extended population. It is going to be tough. So what is the reason why this is to be present, especially when we're discussing with the community medicine we're just having? Because this has to happen at every aspect. So it is not just the work of the mental health professional to work with this. It should be in all the clinicians should be involved. They should be researchers, policy makers, but last but not least society. So every single individual in the society should take it up as owners to work towards this. So what is the way forward? See, it should be, as I told you, more structured assessment of the PPCs and outcome measures, and as I told you, teaching as a part of the curriculum, which is more like a didactic teaching and clinical practice. But now things are changing. Now, though it is quite tough for us in, I think Madam and all will agree with me, we are having students coming in the 5th term, then 8th term, we are having 3 times they have a psychiatry posting, we need to teach it. See, though it is bit of work for us, but definitely this is a positive change, wherein psychiatry is being given so much of importance. So you are trying to train the minds at such a young age, and they realize the importance of it. So this is what should be inculcated. So inculcate positive psychiatry also as a part of curriculum, not just for UG, even for postgraduates and such. Here its more focus is mainly about treatment, response, course, outcome. This is usually what is the normal way. But I think we need to work on not the disease-centric, but the person-centric. So I keep telling you, you're not looking at a disease, you're looking at the person. So I keep telling my PGs, take some time off, sit with the patients, talk to them. It's not the case of depression or not the case of schizophrenia. It's more important that you handle everything because each person is different. So you will need to tap various other potentials. Each person's potentials may be different, which you have to work on. And as I told you, it's not just targeting the vulnerable population, it is both. As you all know, when you talk about preventions, you talk about selective. So selective examples, maybe I can tell that high-risk children, okay, children of alcoholics, so they are at high risk, so I need to start working with them at an earlier stage. Indicative example I could give is a group of pregnant women. But what is so nice, what has happened is of late, this we have got what is called a TAI card, which is an ANC. I think Dr. Rajni's really has worked hard for that, wherein they have included one question about asking the mental health. So it has come to this level where we're trying to sensitize the obstetricians that they need to ask, how is your mood? There are a few questions in that. So that itself is a big, achievement. So there, once they find there's any issue, they will refer to the psychiatrist. So that is your indicative. Universal is when you start working with the whole population or you work with target population. For example, your whole population is working examples would be like talking to them about reducing the ill effects of substances or stop cessation, don't start. So these are some of the things. Our universal target population, now elderly, which it talked to, isn't it? Stimulating activities like social, physical, cognitive. So elderly people being given these type of opportunities. So next would be building healthy public policies, strengthen community action, develop personal skills. Very important to reorient health services. Try to promote mental health in settings where people live their lives. So instead of waiting for them to come to psychiatric OPD, we go to where they are. So that is what I am telling you, it should be the other way around. Wherein you go to the schools, you go to workplaces, you go to homes and try to work on their mental health there. So important, just not to focus on illness, try to start focusing, shift the focus from illness to wellness, and it has to be progressive, inclusive, preventive and a holistic approach. So at the last, what I want to tell is, it has to be a synergistic action from micro to the macro level to bring about a tangible and an enduring change. Thank you.
Thank you, Manju, for that wonderful topic, extensive topic being covered in such a wonderful way. We who work on the purpose of treating patients to move into a stage of wellness, I think is a very massive shift, and it's something very, I would say, quite frightening to all of us, but something that we should start looking at, given all the changes that are happening in the world today, like you accurately pointed out. So thank you so much for raising the topic and putting it as an issue in our mind so that we can think and plan as to what actually needs to be done.
Hi, thank you. So, as I have left academics long back and working exclusively in corporate and corporate MNCs, you really brought me back to the days, where a teacher can teach. So thank you for making the topic so easy. PTCs, we talk a lot and resilience a lot in corporate, but this dimension, I remember Dr. Dilip Jeste's statement, what I had read some time back, was to incorporate positive psychiatry in mental health. The mental health becomes a topic for everyone, not only for the people who are affected. Again, the topic is so relevant for community medicine people also, as it's aiming primary prevention. And thanks a lot for the lucid presentation. We really enjoyed a lot. If there are any question answers, let us open it. Opinions, feedbacks also.
Is there a possibility of changing the name of the department? Place for wellness. Because our problem is that they say that we are referring to a psychiatrist, we are going on. First thing that we should ask is, why should I go to a psychiatrist?
non-medical mental health person. And they also do not want to go, okay, they do not want to go also to a youth psychologist. They said, can you send me to a counselor? So from that angle, I think all these counselors are very, very interesting. And really, rightly pointed out, you see 10 patients. I think people who may not require any medication. I think everybody is doing that. What is happening is that most likely when you get a patient referred, people feel that, okay, I have to write something. Then something will be written. And that something can be either an antidepressant or anything, which nobody stops subsequently. And it goes on for years together on 10 milligram of methamphetamine or 20 milligram of methamphetamine. And things like that. So that's something which is very, very important. Because only a recent study demands also HP Yadavanahalli doing that study of how when to stop antidepressant in a real setting, not in a controlled setting.
Thank you.
It was a very good presentation.
Why both, sir?
That people who follow religious, who are religious, will end up in more depression?
No, it's just nothing but a thing of a sense of social integration. Social integration in one aspect, so studies have shown that. So the fact that you are integrated, so there is a chance that you meet people, you have communities. So that is a positive support, and they are usually there. So it is just a study which has been done.
That's my literature search says that blind believers, they do end up in psychiatric, more fortunate. Whereas people who are more of socio-cultural or spiritual people, they have a better positive health status. So there is a slight thin line differentiation between the religion and spiritual aspect. Luckily, we are from that part of the world that we are more spiritual compared to the rest of the world. Thank you.
Thank you, ma'am. Now I request the chairpersons to present a token of appreciation to Dr. Manju Ashwath.
చూడేసి ఇట్లా గెలుపుతుందా కానీ ప్రొజెక్టర్ని వరకు వాడు తీసాడు బాగా తీసాడు బాగానే తీసాడు
Thank you, ma'am. Without much ado, let us move on to the last session of today's CME. The topic being equilibrium of the psyche, unveiling the role of yoga therapy in medical health restoration. Due to unforeseen circumstances, Dr. Hemant Bhargav could not join us today. He sends his sincere apologies and regrets for his absence. The session will be instead carried forward by Dr. Naresh Kalakota, Senior Resident, Department of Psychiatry, the Oxford Medical College, Hospital and Research Center.
To chair the session, I would like to invite Dr. Vijay Kumar S. Rao, BSAM, BAMS, Integrated Medicine, and Dr. Anand P., Associate Professor, Department of Community Medicine, the Oxford Medical College, Hospital and Research Center.
Feedback. Yes, sir. Speak.
I request Dr. Anand P.
Screen close చేసిందా చూడు. Hello.
I feel very lucky
It's gonna complete it.
chairing the session, last session, and I got a tough job of controlling the speaker, plus allowing him to speak the relevant things so that take-home message is taken in the right spirit. Before I introduce the speaker, I have got a co-chairperson, Dr. Vijay Kumar, integrative medicine specialist. He's been practicing in our city,
Madam, come this side. Madam.
near Yeshwanthpur for last 36 years. Allopathy plus Ayurveda, naturopathy plus yoga. He is an expert in that particular field, and we are lucky to have you, sir, here with us. The speaker for this session is Dr. Naresh, Senior Resident, Department of Psychiatry. Department of Psychiatry is passed his MD Psychiatry from Mamta Medical College, Telangana State.
This is the last.
With his current position, he is doing an enormous job of helping the people who are coming with mental illness. Much of interactions between me and him in the department, very positive and very forthcoming, upcoming specialist who has got a great future. Over to you, Dr. Naresh.
Thank you, sir. Good evening. I am Dr. Naresh Kalakota, currently pursuing my senior residency, Oxford Medical College, Department of Psychiatry. So today's topic will be yoga and psychiatry. Outline will be introduction to yoga, yoga for depression, anxiety disorders, schizophrenia, mild cognitive impairment, neurobiology of yoga, and the last, limitations of yoga. So this image, it depicts the Ashtanga, that is called as the 8 limbs of yoga. It is given by Patanjali Maharshi. So the first 4 are Yama, Niyama, Asana and Pranayama. They are considered as external limbs. They are Bahir Anga. It is for behavior, physical well-being, control over the body. And the next 4 are internal limbs. They are Pratyahara, Dharana, Dhyana and Samadhi. They are for mind, inner awareness and spiritual development. So this is Panchakosha model. It is from Taittiriya Upanishad. So in this model we have total of 5 layers. So the inner layer, it is called as Annamaya Kosha. The second layer is Pranamaya Kosha, that is layer of energy. The third is Manomaya Kosha, layer of emotions. Fourth is Vijnanamaya Kosha, layer of knowledge. The last is Anandamaya Kosha, that is layer of bliss. According to Yoga Vasishtha, he has classified diseases into 2 types based on origin. They are Adijavyadi and Anadijavyadi. Adijavyadis, they are because of internal cause, for example like stress-borne diseases in Manomaya Kosha, that is the 3rd layer. And Anadijavyadi, it is because of external cause, example external injuries and infection in Annamaya Kosha. Annamaya Kosha is the physical body we are living in. Now let's discuss about Panchabhutas and 3 doshas. As we know, the Panchabhutas are air, space, fire, water, and earth. The three doshas in yogic literature are Vata, Pitta, and Kapha. So these are the Vata, Pitta, and Kapha personalities. So in these patient with Vata, they have low body weight. Pitta, they have moderate body weight, and Kapha people, they have over body weight. And sleep, it is scanty in Vata, it is little but sound sleep in Pitta, and heavy sleep is noted in Kapha people. The four pathways of yoga, according to Bhagavad Gita, they are Jnana Yoga, Raja Yoga, Karma Yoga, and Bhakti Yoga.
ಪಕ್ಕ ಬರಲ್ಲ ಸರ್, ಬರೀ ರೀಡಿಂಗ್ ಅಷ್ಟೇ, ಬರೀ ಮಕ್ಕಳು ಓದ್ಕೊಳ್ಳೋ ಜಾಗ ಅಷ್ಟೇ.
According to yoga literature, they are
ನನಗೂ ಈಗಲೇ ಮೇಡಮ್ ಹೇಳಿರೋದು, ವೀಣಾ ಮೇಡಮ್, ನನಗೇನು ಗೊತ್ತಿರಲಿಲ್ಲ.
So Sattvic gunas, people of this guna, they have enthusiasm in performing his duties.
ಸರ್ ನಾನು ಅದನ್ನೇ ಹೇಳಿದ್ದು, ನಾನೇ ಇವತ್ತು ನನಗೆ ಗೊತ್ತಾಗಿದ್ದ ವಿಚಾರ.
And they prefer Sattvic food which is juicy, sweet, and nourishing in nature. And Rajas, these people, they have intense ambition with an anticipation of food. They actually prefer Rajasic food which is spicy, salty, and Tamasic people, they are lethargic, stubborn, deluded, and revengeful in their actions. They tend to give up all their duties, and they prefer food which is cold. They prefer the food which is cold, which lacks freshness, which is preferred long back, tasteless, and unhygienic foods. So, as exercise and yoga both are physical activities, both are considered as same, but there is a lot of difference between exercise and yoga. If you see the heart rate, respiratory rate, blood pressure, and metabolism, all these parameters they increase in yoga, whereas they increase in exercise, whereas in yoga they decrease. That means sympathetic activation happens in exercise and parasympathetic activation it happens in yoga. So, yoga-based management for depression. Home chanting. By this chanting, there is a stimulation of auricular bunch of frequencies. Shavasana and Prataka Kriya, they are useful for symptoms like easy fatigue. Depression patients, they require Rajasic and Sattvic food, and they must avoid Tamasic. Producing humming sound A during the daytime is also useful. Brahmari Pranayama, it also helps in quality of sleep for patients with insomnia. Other yoga asanas are Surya Namaskara, back bending poses like Bhujangasana, Ardha Chakrasana, Bhastrika, Kapalabhati are useful. And right nostril breathing, that is Surya Vedana, and at last ending with Om chanting for 3 minutes, it is useful. What does our guidelines say about yoga? According to Canadian Network for Mood and Anxiety Disorders, CanMAD, it is stated that yoga can be used as an adjunctive therapy for mild to moderate depression. They have found a significant reduction in Hamilton depressive scores in various studies, and there is an increase in brain-derived neurotrophic factors and significant reduction in serum cortisol. So let's take a picture of various yogasanas. So these first 12 poses, they are Surya Namaskara. The second one is Ardha Chakrasana, Bhujangasana, Ardha Chakrasana, and Surya Vedana. So the last two images, they are Kapalabhati and Bhastrika. In Kapalabhati, inhalation is slow and normal, but exhalation, it is quick and forceful. Whereas in Bhastrika, both inhalation and exhalation, they are forceful and rapid. Effect of yoga on various depressive symptoms. This is an meta-analysis and systemic review. So in this research, they have included 19 studies in the review and 13 studies in the meta-analysis. They have shown, so it is noted that there is a greater reduction in depressive symptoms, and greater reduction in depressive symptoms were also associated with higher frequency of yoga sessions per week. So there is another systemic review and meta-analysis of depression. So in this total 12 RCTs were taken with 619 participants. So they have concluded that yoga can be considered as an adjuvant therapy for patients with depressive disorders. Yoga for anxiety. Anxiety it is considered as chitta udvega, that is restless state of mind. Charaka has mentioned it as manasa vikara. So various yoga practices for anxiety disorders are slow breathing and longer exhalations, hands in and out breathing, tiger breathing, Shitali pranayama, left nostril breathing, Brahmari pranayama, Shavasana. So these are various yogic postures for anxiety disorders. Yoga for PTSD. So various asanas useful for PTSD are Ardha Kati Chakrasana, Pavana Muktasana, Trikonasana and Trataka. So in these PTSD people, they can do inspiration, holding and expiration in the ratio of 1:4:2. And Shavasana at bedtime is also useful. In a systemic review and meta-analysis for post-traumatic stress disorder, they have found yoga has been significantly better than no treatment. Yoga for OCD, left nostril breathing, loud Om chanting is useful. Breathing slowly in Shavasana and avoiding long breath holding is also useful. Yoga for schizophrenia and other psychosis. Simple warming exercises 5 minutes before the yoga session to be done. Then patient can start with sun salutations, that is Surya Namaskara. Later Bastrika and alternative nostril breathings can be done. So according to NICE guidelines, it is stated that yoga can be used as an add-on treatment for the management of psychosis. So according to a study by Shivarama Varambali, NIMHANS, they have found in patients with schizophrenia, after 4 months of yoga therapy, there is a significant improvement in social functioning. It's an also similar finding. Yoga significantly improves social functioning in schizophrenia patients. Yoga for mild cognitive impairment. Short sessions with Brahmari pranayama, left nostril breathing, slow Kapalabhati, that is 20 circles per minute rate for 3 minutes, Om chanting and Trataka Kriya are useful. Now let's explore on neurobiological aspects of yoga. So Om chanting and limbic deactivation. So a sensation of vibration is experienced during audible Om chanting. So this has the potential for vagus nerve stimulation through its auricular branches. Using functional magnetic resonance imaging, the neurohemodynamic correlates of audible Om chanting were examined on right-handed healthy volunteers. The Om chanting condition was compared with the pronunciation S. These are controls. So in this study, they have found significant deactivation was observed bilaterally during Om chanting in comparison to the resting brain state in bilateral anterior cingulate, parahippocampal barrage and hippocampus. And right amygdala too also demonstrated significant deactivation. No significant activation was observed during Om chanting. In contrast, neither activation nor deactivation occurred in these brain areas due to comparative to task, that is S pronunciation sound. So Kapalabhati enhanced prefrontal activation in healthy subjects. So in these frontal hemodynamic responses to high frequency yoga breathing techniques, that is Kapalabhati, they were compared between the patients of schizophrenia and healthy subjects using functional near infrared spectroscopy. Here they didn't use functional MRI because of various other reasons. Because patients are schizophrenic, they are not able to stop in a single place. And in these, chest pressure transducers were used to monitor the frequency and intensity of the practice regularly. In the frontal hemodynamic response in terms of the oxygenated hemoglobin and deoxygenated hemoglobin was tagged for every 5 minutes before the session, 1 minute during the session, and 5 minutes after the session of Kapalabhati. So within the group comparison, it showed that there is an increase in bilateral oxygenated hemoglobin from the baseline, which was highly significant in healthy controls during Kapalabhati, whereas schizophrenia patients didn't show any significant changes in the same on both the sides. Comparison between the groups showed that schizophrenia patients had reduced bilateral prefrontal activation during Kapalabhati as compared to the healthy controls. So these are various major findings in clinical neurosciences. They are from immense studies. In depression, they have found decrease in serum cortisol and increased plasma BDNF factors. Schizophrenia, increased oxytocin and mirror neuron activity. Cognitive impairment in elderly, they have found increase in hippocampal gray matter volume. Other psychiatric disorders like opioid dependence, they have found increased plasma beta endorphin levels. So there is one more study by Hari Prasad et al. So they have found after 6 months of yoga therapy in healthy elderly people, there is a significant increase in gray matter. So this is a review. It's a review of 34 neuroimaging studies. They have found increased gray matter volume in insula and hippocampus, and increased activation of prefrontal cortex, and function connectivity changes in default mode network. Now let's discuss about heart rate variability and yoga. So for this they have used Brahmari Pranayama, the effect of Brahmari Pranayama on heart rate parameters. So they have included a total of sample 520, that is 260 plus 260 adolescent people. So in the yoga group, they have taken practice of 5 days a week for 6 months. And in the control group, they have been told to continue daily routines without any interventions. After 6 months of yoga breathing, they have found significant improvement in parasympathetic domains. So it is also same study, heart rate variability and yoga. They have found increase in parasympathetic activity after yoga. Conditions where yoga practices are to be avoided: migraine and other headaches, Kapalabhati and Bhastrika; moderate to severe depression, Pratyahara; schizophrenia, Pratyahara and Vipassana; BPAD. In BPAD, various practices can be done, but in between they are supposed to have Shavasana. Epilepsy, Kapalabhati, Bhastrika and Jyoti Taraka are to be avoided. So the most common injuries we see in yoga, they are with asanas. So the neurological and vascular injuries seen with these asanas, like example Sirsasana, Sarvangasana and Halasana. And the ligament injuries are also common, but all these injuries are rare when practiced under supervision. So these are my references. Thank you.
Before my presentation, right from the basics of yogas, and you went up to the level of happenings. If someone practices yoga for a period of time, what are the changes brought in the brain activities, especially the centers? Okay, and about the Om was very impressive. In fact, the Om has got 3 components. One is it is related to the pressure changes intra-alveoli, okay, pressure changes. E3 components is R. R component is like you are going to go for negative pressure intra-alveolar region. O is like neutral pressure, and when you coming to the end phase of the Om is that is of more of constricting your laryngeal apparatus and increasing the pressure inside the alveoli. You can imagine what will happen if there is an increase in pressure in the alveoli, oxygenation, okay? Not only that one, at the other side of the alveoli, the lung, the impact of these pressures on intrapleural region. Intrapleural, again, there are three phases there. Okay, when there is a negative pressure, more and more blood is sucked into the thoracic cavity, and that is called as venous return. And venous return, increase in venous return, stroke, it again influences the stroke volume. That helps in the better oxygenation and distribution of oxygen, delivery of oxygen to the each and every cell. That's more important thing. It was a very nice presentation, Dr. Naresh. I open the session for any questions, please, and we are here to answer to your any queries. I request Kalaivanan one question. One question. What have you understood? What have you not understood? To Dr. Naresh. Next one, you have to decently ask at least 2 questions to the speaker. You do justification for it. Yeah, okay. Now it's become an in-house CME, okay? We can extend the time also, no problem. Please go ahead.
Last session you said like religious beliefs will have some effect on the mental health. So Om is a kind of Hindu thing or Hindu religion associated thing. So what to follow?
Okay, there's a reminder. Okay. Anyhow, I did not tell that religious. I did not come out. Religious thing will have a negative thing. Blind believers among the religious people. Okay. Okay. Luckily, I mean, what is clarified also. This part of the world is not religious. If you see thousands of years back, no, we are not religious because someone came and told that you are Hindu. We have been considered as Hindu religious people. No, not so. It's a spiritual. We are not spiritual. We are more of a socio-cultural practices. There's a difference between the religious practices which is based on the blind belief. Okay, understood. If someone is hard-pressed, okay, who is very blindly believer of something without scientific basis, when it comes to the socio-cultural activities of people who are living in this part of the world who are spiritual, there is a science behind it. Each and everything we can explain the science behind it. Unfortunately, the literatures were lost, but now it's re-emerging. Yeah, any other question, please? Very well, that 3 gunas, that one we told about Sattvic, Tamasic and Rajas. Okay? And Sattvic one has got its own importance. Rajasic, at times you have to indulge, okay, at times. And
This
Tamasic
slide was
is
very
not
fine.
going to help. Okay, it is related to Tamasic means you are making your mind slow down with substances. Tamasic, substances, which is the greater problem of this world, entire world, with the advent of finding people use of these drugs and drug abuses, which is to be kept in mind. With this, I think we should close the session. Thank you very much, Harish.
Thank you, sir.
Thank you, sir. Now I request the chairpersons to present a token of appreciation to Dr. Naresh Kalakota.
I now request Dr. Shweta A, Assistant Professor,
Mic on
Department of
ಆಗಿಲ್ಲ.
Community Medicine,
ಅವ್ರು on
Oxford
ಮಾಡಿಲ್ಲ.
Medical College, Hospital and Research Center to present mementos to Dr. Vijay Kumar S. Rao and Dr. Anand B.
I request you all to fill in the feedback form which will be shared in the group so that we can improvise in further CMEs. The past few hours has been a remarkable journey of knowledge filled with insightful sessions and groundbreaking discussions.
Renowned for her empathetic patient care, exceptional clinical skills, and unwavering dedication to mental health, and a passion for research, has established her as a distinguished and inspirational figure in the field of psychiatry. I now request Dr. Swapna, Professor and Head, Department of Psychiatry, the Oxford Medical College, Hospital and Research Centre to deliver the vote of thanks.
No need of any music. Any more music? We'll put some nice closing DJ.
Good evening, everybody. So we are at the end of the session. A wonderful academic feast we had. This is an occasion for me to thank you all. Thank you is such a prayer that cannot be seen or touched. It must be felt by our heart. I feel honored and privileged to get the opportunity to propose the vote of thanks on this special occasion. Would like to thank the honorable delegates, speakers, chairpersons who blessed us with their presence. I'm also very much thankful to the organizing committee who really worked hard to organize this successful CME. I, on the behalf of organizing committee, convey deep regards and hearty thanks to our Chief Patron, Dr. SNVS Narasimha Raju Garu, our Chairman, and our Director in absentia, Dr. Sri Srinivaslu White, Dean cum Director, Dr. C.R. Jayanti, ma'am, and our Medical Superintendent, Dr. V.B. Gowda, sir. They helped us in obtaining the necessary administrative approval and guided us well in this CME. My special thanks to Rajni P. ma'am, Deputy Director, Directorate of Health and Family Welfare, Dr. Anna Rao G. Kulkarni, sir, that is National President, Indian Association of Preventive and Social Medicine, and would like to thank our beloved Murli, sir, for constant guidance in shaping this CME. I thank IPS KC and World Association of Psychosocial Rehabilitation for co-sponsoring this event and being helpful in supporting us for this CME. I also thankful to all the pharma companies who have been helpful in sponsoring this event. I would like to thank Linux, Entas and Icon. It would have been impossible to organize this event without their support. So thank you all for this successful, great event that we had today, and my heartfelt gratitude to all of you. Thank you. I would like to call upon a representative from INTAS.
Sharath, live stop now.
This will first this one, then the other.
I would like to invite Dr. Murli, please, present moderators to the icon. I would like to invite a representative from Linus.
Completely. The year out was not happening.
Thank you, ma'am. Thank you, sir. I, Dr. Varsha,
And I, Dr. Nritya, look forward to more such participation in the near future.
signing off for today.
Thank you all.
Stream ಮಾಡ್ತಾ ಇದ್ದೀನಿ.